Check two. Hey. हेलो चेक वन हे हे नहीं ये जाना चाहिए आवाज इधर आ रहा है ना वो देखो दिखा रहा है चेक तो सेटिंग कुछ रहेगा ना इनका चेक वन टू हे चेक टेस्टिंग साउंड चेक हे हे हेलो ओके इसका सेटिंग अलग से रहता है नहीं अभी आ रहा है आपने क्या किया कुछ किया चेक हे इधर आया मतलब साउंड आया साउंड कुछ प्रॉब्लम नहीं कुछ इधर से नहीं जाया ना तो रहेगा प्रॉब्लम इधर
Ganesh Vandana, do you have it in this hall? No, okay. Okay. All the other halls are starting with that. Fine. Morning, everyone. Again, on behalf of DRS WCPD, let me thank all the uh, researchers, clinicians who send their abstracts to us. We had received over 40 abstracts. A committee of 3 people went through it, selected the abstracts for oral, for poster, and some, of course, that we couldn't accommodate. So congratulations to all of you who've been selected for oral presentations. We had one round of oral presentations being judged yesterday, and then today are the rest of the presenters. To take this session ahead, let me invite on stage the 2 judges who have kindly accepted to judge these oral papers today. Gives me great pleasure to invite on stage Dr. Pablo Aschner. Dr. Pablo comes from Colombia, has great body of work and research in epidemiology and prevention, and of course, we invite you for the IDF memorial lecture that Dr. Aschner will be delivering later today at 12:30 p.m. To join Dr. Pablo in judging today's orals, gives me pleasure again to invite Dr. J.J. Mukherjee from Kolkata, a senior endocrinologist and diabetologist at the Apollo Hospital Clinics from Kolkata. Thank you, Dr. J.J. and Dr. Aschner, for accepting this. It's all yours.
Timekeeping will be...
It will be right here. It's 8 minutes per session. So it's 8 minutes maximum for each presentation with 2 minutes of question and answers for you to do that. And the judges will be judging you on all aspects, including the time.
I think it's fair to let you know what will be judged on. Adherence to time, innovation of study, quality of work, novelty, quality of oral paper, presentation skill, and then there's something called judge's discretion. So these are the 6 points on which you'll be judged. I think this judging is crap. Please present your work. We will love to hear what you have to say and see what work you've done. Not accepting cash. The rest
is not discretion.
I think we should start. Dr. Bruce?
Well, thank you very much for the opportunity to present these data. This Congress is wonderful. However, let me say that in the beginning there were a few glitches. In fact, I sent my abstract once. I submitted it before it was ready. Then I sent it again, and what ended up happening is one abstract turned into 2 presentations. So the first 2 presentations are really one, and I think perhaps that'll allow us to have 10 minutes per presentation because there's one less. Okay. Well, let me know when I go over because it was never clear to me how much time we had here. Okay, so I'm going to talk about greater mortality with LDL-C on target in adults with diabetes not at high cardiovascular risk. This data comes from the ELSA study, and these are my collaborators. Diabetes without a high CVD risk. Lipid lowering generally to less than 70 milligrams per deciliter is the current, what the current guidelines say. However, lipid lowering trials are inconclusive in diabetes. The meta-analyses which were done do not show statistically significant differences. And almost uniformly, real-world studies suggest greater mortality at low LDL-C levels. So our objective was to assess all-cause mortality related to LDL-C levels among ELSA Brazil participants living with diabetes but not with high cardiovascular risk. The study population came, as I said, from our study. There were 2,098 participants with self-reported diabetes at their baseline without known CVD and having a 10-year cardiovascular risk less than 20% by the WHO charts. Diabetes was ascertained by self-report or medication use. Deaths were ascertained through annual follow-up contacts. We looked at both a frailty index and a frailty phenotype, and the 10-year risk was based on the WHO risk chart working group for tropical Latin America, which includes Brazil. We analyzed our data via Cox proportional hazards models, which were multiply adjusted for potential confounders, and then we did stratified analysis additionally. We did initial analysis, and then we did further sensitivity analysis, excluding deaths in the first 5 years of follow-up and adjusting for frailty. These were sensitivity analysis because frailty was determined only midway through the study, so we had to a reduced sample for these. Our results are the following. This is stratified analysis by LDL-C. The reference group is LDL-C between 100 and 129 milligrams per deciliter. And what you see is you get up to 160, you have greater risk, not statistically significant, probably because of relatively small sample size. But then look at what happens when the LDL-C gets lower. You get from 70 to 99, you have a relative risk of 1.49, increased risk of death, not statistically significant. But below that, you have increased statistically significant deaths, greater than a hazard ratio greater than 2.5 for each of the two groups. When we put this all together and just have reference 100 to 130 compared to LDL-C less than 100, what we see is this, in adjusting for a zillion things, we have a hazard ratio adjusted of 1.67, 67% greater deaths in the patients with our participants with lower levels. When we stratify this by age, it seems to be more important in elderly individuals. When we stratified it by statin use, those who are using statins don't have a statistically significant association. And when we stratify it by sex, women have a greater association. And then perhaps more interestingly, when we stratify it by cause of death, or when we look at separately for different causes of death, a signal comes out that there are greater deaths by cancer in those that have low LDL-C, statistically significant. Then in our secondary analysis, when we adjusted for frailty phenotype, the sample size is smaller, we see no effect of frailty. Both the hazard ratio after adjusting for frailty was greater than 2, and after Também, excluding for, after also, pardon the Portuguese, after also excluding for the deaths in the first 5 years, there was still remained a statistically significant association. This is for the frailty phenotype, one way to assess frailty. The same thing was found basically when we assessed for the looking at frailty via the frailty index, statistically significant associations of low LDL-C leading to death. And then when we did a continuous analysis, on the bottom here you see the LDL-C with the histogram of the distribution in our participants. And what you see is a U-shaped or almost J-shaped curve. In this analysis, it doesn't reach statistical significance in the higher level, but it clearly reaches statistical significance in the lower level. Now for discussion, it's now, despite the fact that for decades, the general statement that was made was that diabetes was a CVD risk equivalent. If you had diabetes, it was equivalent to already having known cardiovascular disease. There have been several studies now that show that that is not the case. And in fact, in the Brazilian National Health Survey, a representative survey, which for the first time in 2014-2015 measured glycosylated hemoglobin, it was and measured a series of other things also. When CVD risk was calculated for the representative sample of diabetes in the population, excluding those that said that they had known cardiovascular disease, only 3.4% of the patients or the participants with diabetes in that study had a CVD risk greater than 20%. Those with diabetes, not in our study, but generally are now known to have deaths from cancer as one of their main complications. And the risk of cardiovascular disease has dropped dramatically in patients with diabetes. 20 years ago, it was more than 50%. Now it's around 30%, with almost an equal amount of deaths from cancer. So the profile of deaths in diabetes has changed dramatically. As I mentioned, meta-analyses have not shown statistically significant reduction of total mortality in diabetes. Trial data, it's interesting, there are a series of analyses in trial data that look at how low the LDLC how low an LDLC was achieved. And as the LDLC achievement gets lower, the risk of instant cancer increases. Our data, when I say an overwhelming majority of studies show greater death with LDLC in real-world context and observational studies, I thought I had found something new when we looked at this, and then going back to the literature, everybody finds this. There must be 10 studies in the literature, 9.5 of them documenting that mortality is greater at low LDLC levels. And our data, what's original of our data, is we show that LDLC is not merely a marker of greater risk of death due to frailty or with the exclusion of the first 5 years of mortality, other causes. And the trials, even in the meta-analysis, many of the trials don't reach an LDLC level of less than 100. They started their earlier trials, they started very high, and they didn't have very potent statins, and they ended up with LDLCs around 100. The trials that show the best benefit are those that have lesser decrease of LDLC. So in conclusion, diabetes is not a high CVD, not equivalent to high CVD, and mortality increases at low LDLC values. And given recent declines in cardiovascular mortality, increased cardiovascular cancer risk in people with diabetes, LDLC treatment targets warrant further trial evaluation. Thank you very much.
Thank you. Interesting. Any questions? So,
there's one there.
yep. Oh,
Have you tried how low LDLC has further worsening of increase in mortality? U-shaped curve. At what level, up to what level?
Yeah.
It is very nice paper. At what level the curve starts rising again of LDLC, whether it is 50, whether it is 70, or maybe below 70? Have you tried to do subgroup stratification for that?
I would say that studies suggest, not just our study, I showed what our study showed. I would say that studies suggest that when you get below 100 or 90 or so, you start getting increased risk of other things and you start getting decreased mortality. In fact, there's a recent trial that with benzoic acid, which is another demonstration that LDLC lowering protects against death and diabetes. And the LDLC which they achieved was like 96 milligrams per deciliter. So it wasn't, there aren't recent studies that go down to below 70 or 55, what people are recommending, what the authorities are recommending these days. Okay.
okay. Thank you. So I think that's it.
Just one question.
Sure.
You showed that low LDLC is related to increased cancer. That's what you found?
LDLC
Yeah,
increases, especially increases the risk of cancer deaths.
Was your population screened for cancer when you started the study? How do you know that there was no confounding?
We asked people if they had cancer.
But no specific.
Not specific cancers.
Second,
no.
in frailty, when you exclude.
But let me remember that we exclude the first 5 years of
fair
cancer
enough,
deaths. Yeah.
Because you are linking that low LDLC is increasing cancer risk. My question is, did they already have some cancer to start with?
It's always possible. These were healthy volunteers that came to the study,
Okay.
and I believe we excluded. I can't. I'm not positive, but I believe that there were so few of them. I believe we excluded people that said they had cancer as baseline.
Second, when you adjusted for frailty, I found that less than 100 LDLC cholesterol, LDLC, was associated with increased risk, whereas in the overall population, you showed less than 70.
No, in the overall, I'm sorry, I must have explained this poorly. No, the overall population is less than 100.
Less than 100.
The cut point is the same for those analyses.
All right, thank you.
Thank you. So now it's Zumayaran Mohanty.
A very good morning to everyone. I would like to thank Sasang sir, Manoj sir, Bansi sir, and Purvi ma'am for giving me this opportunity. today I am going to discuss about my topic. Change. Yes, sir. Thank you. Thank you. Ezetimibe as add-on therapy with statins in diabetic dyslipidemia. I will first of all thank to Dr. Kiran sir who rectified many of my mistakes during this topic. And first of all, before going to the topic, I will slightly elaborate about the CVD risk. As we all know, the rapid increase in prevalence of CVD, according around the 24% of all death aged between 25 to 69 years. But in India, it's more in the younger age. That is the 10% of all heart attacks in people of 40, less than 40 years. Although multiple risk factors including smoking, sedentary lifestyle, obesity, hypertension, all important contributor, but diabetes with dyslipidemia is the major condition necessary for the atherosclerotic process. There are the treatment options we all know, that is HMG-CoA reductase inhibitor, fibric acid, bile acid resins, nicotine acid derivatives, cholesterol absorption inhibitors, ezetimibe, and of course the lifestyle modification, proper diet, exercise, avoidance of alcohol and tobacco. And about the non-statin therapy, why I choose ezetimibe, I will discuss about it later. The current approach in dyslipidemia management, high intensity therapy, LDL should be reduced 50% with daily dosing, and moderate statin therapy, LDL reduction should be around 30 to 50%, and low statin therapy, LDL reduction will be less than 30%. Why the use of combinations? Because the single therapy is time consuming and the patient who is a very high risk. What the guidelines say, according to the ESC guideline, if despite of maximal tolerated statin dosage, the reduction from the baseline of LDL goal is not achieved, then we can start intensification with non-statin agents. As per the risk group, this is extremely high risk group, category A, category B, and very high risk group. In category A, the coronary artery disease with diabetes without target or damage, and familial hypercholesteremia with CKD stage 3B, and in category B, diabetes with polyvascular disease along with the ASVD risk factor, and in case of high risk, any one of the following: ASCVD, homozygous familial hypercholesteremia, diabetes with greater than more 3 major ASCVD risk factors. So what is LDL-C? LDL-C is a dangerously modified small dense glycolated oxygenated molecule due to the result of increased free fatty acid level, which leads to endothelial dysfunction, atherogenesis and plaque. We all know about the mode of action of rosuvastatin, as it converts the HMG coenzyme A to mevalomic acid, which is the rate limiting step of cholesterol synthesis. Rosuvastatin therefore decreases the hepatic cholesterol synthesis, which in turn leads to the decreased concentration of hepatocellular cholesterol. And there is also the non-lipid action of statin, mostly the vascular endothelium effect. It improves the releasing of nitrous oxide, and anti-inflammatory effect decreases the CRP. It also improves the both systolic and diastolic function and improves the vascular elasticity. So why I choose ezetimibe? Ezetimibe inhibits the intestinal cholesterol absorption by selectively blocking the Niemann-Pick C1-like protein in the jejunal brush border. Diabetes have a higher level of NPCL1 gene expression. Type 2 diabetes patients have increased absorption of cholesterol. So adding ezetimibe to the current statin therapy helps in lowering the cholesterol absorption. This is the algorithm for the treatment of LDL. Now this is my trial among at my rural area, and the series of case studies on ezetimibe as add-on therapy with statin among the rural population, which is now up to 56 patients. But while I submit this, it is uh, on 32 patients. It's a period of 6 weeks observational study who are already on statins. I changed them to rosuvastatin 10 mg with HDMI of 10 mg. After 4 to 6 weeks, there is a marked reduction in LDL level and triglyceride level with the increase in the HDL level. Also, the patients are advised about the calorie intake, the diet, the regular exercise, and cessation of smoking and decreasing the alcohol. Here you can see the graph of the LDL of the 32 patients during the first visit and after the visit after 6 weeks. There is a marked reduction in the level of LDL. And here is the graph of the triglyceride of the 32 patients at the first visit and again after the visit of the 6 weeks. And here is the HDL level, which is slightly increased in case of the 32 patients after the second visit. And the inclusion criteria is the patients already dyslipidemia and they are all on statins and they all are diabetic with hypertensive. My exclusion criteria is type 1 diabetes patients, pregnancy, liver disease, and the ejection fraction is less than 60. So my conclusion is in type 2 diabetes, addition of ezetimibe to rosuvastatin monotherapy resulted in the significant reduction in the ApoB and A1 ratio, a predictor for the cardiovascular disease, also in the lipid parameter compared to the rosuvastatin monotherapy. Ezetimibe as an additional therapy for diabetic dyslipidemia patient is a favorable approach for lowering TG and LDL level. Combination regimen of low dose statin with ezetimibe is preferable who patients are intolerant to high dose of statins. But for a special population in pregnancy, we should discontinue rosuvastatin with ezetimibe when pregnancy diagnosed as it can cause fetal harm. Lactation is not recommended. In pediatric, the safety and efficacy have not established. In geriatric use, it is a risk factor for myopathy and rhabdomyolysis, so the selection should be made cautiously. And in renal failure, the renal impairment is a risk factor for myopathy and rhabdomyolysis, so the patient with severe renal impairment, eGFR less than 30 and not on hemodialysis, the recommended dosage of starting is 5 to 10 mg. And in hepatic failure, it's completely contraindicated patient with acute liver failure and decompensated cirrhosis. Thank you. Thank you all.
Thank you.
Thank you, sir.
There is a conclusion about the relationship between ApoA and ApoB.
Yes.
Did you measure them?
No, sir.
No.
No.
So you deduce it from the LDL and the HDL behavior?
Yes, sir.
Okay. Thank you.
Thank you.
You showed a graph with day 1 to day 32, was it?
Yeah.
The LDL and the triglycerides.
Yes, sir.
But you only measured at 0 and 6 weeks, right?
Yes, sir.
So how did you get those graphs also?
No, sir. The graph is the patients because the lower graph is
That's
the number of patients,
Okay.
and that is the number of.
What was the extra percentage reduction in LDL-C when you added ezetimibe as opposed to only rosuvastatin? Did
Sir, that is up
you
to.
didn't present that data?
No, sir. That is up to 6 to 7%.
Okay.
Additional
but
6
that
to
data
7%.
should have been shown. Isn't that was the whole idea of adding ezetimibe, I presume?
No, sir. The idea is to that they both work more synergistically, and
How? By you measuring what? What parameter are you measuring to show their working?
because sir,
synergistically?
I already choose those patients who are on statin therapy, like they are on rosuvastatin 20 mg or they are on 10 mg, and the data, the TG level and the LDL after using the statins are like that. When I add ezetimibe to them, there is the decrease.
Okay, all right. Any questions from the floor, quickly? To the mic, sir, to the mic. To the mic, to the mic.
Yeah.
You said statin intolerant patients.
Yeah.
What is the definition of intolerance?
So intolerance means a high dose of statin, they are mostly complaining of muscle pain.
Are these are the population who complained of muscle pain?
No. These are the populations who are already on statins. They are they are only either 10 mg or 20 mg or 40 mg, and mostly the data, the levels are with statins. Then I start adding ezetimibe. The second data is after adding the decrease in the after adding the ezetimibe.
Agreed, but then in the inclusion criteria you mentioned statin intolerant patients, right?
No, I already, sir, I already added that they are with statins and also the intolerant.
So you included both.
Yeah.
Statin intolerant
Yeah.
Okay, thank you very much.
Thank you,
you.
sir.
Next, Maria.
Good morning. I would like to present this paper this morning in the name of my co-authors. And the idea is to use data from the ELSA Brazil study, the Brazilian longitudinal study of adult health, to address whether associations of ultra-processed food intake with the incidence of cardiometabolic and mental health conditions go indeed beyond specific subgroups of ultra-processed foods. Of course, most foods are processed, and whether it's by freezing, grinding, fermentation, pasteurization, or other means. In 2009, Carlos Monteiro and his colleagues proposed a system to classify foods according to the amount of processing they undergo, not by the nutrient content, which was prevailing at that time. And they used 4 categories of processing. First, unprocessed or minimally processed food, eating an apple. Processed culinary ingredients, oil, salt, sugar. Processed foods, the ones we learn how to eat with our grandmothers and our parents, the good type of food. And ultra-processed food, which is something that actually started last century, didn't exist before. And this is what we are going to be talking about today. So what are ultra-processed foods? Ultra-processed foods are industrial formulations. We could perhaps call them products rather than foods, which are primarily or entirely made from substances that were extracted from foods. They are rich in chemical additives for coloring, preserving, for flavoring, for emulsifying, and they are designed to be highly convenient and appealing, and if you wish, addicting. Ultra-processed food consumption has increased dramatically over the last decades. Initially in high-income countries, and then in middle and then low-income countries. And this increased consumption is happening not only in adults, but among teenagers, children, and even babies. In some countries, ultra-processed food consumption today constitutes over 70% of their daily food intake. And in some countries, this is higher for children than for adults. Ultra-processed foods have a tremendous impact in socioeconomical aspects, in cultural aspects, but what we are going to be addressing today is their relationship with adverse health outcomes. And a summary of this that you can find in this paper published this year in BMJ, which addresses everything that has been described in terms of adverse health outcomes related to ultra-processed food. And the avoidance of ultra-processed food has been included in many guidelines, either governmental or medical society guidelines in various countries in the world, including I learned recently in India. Now, a question that was raised last year is, should the nutritional advice regarding diabetes be focused only on specific subgroups of ultra-processed food, or should we consider the degree of processing in the recommendation? And there were 2 papers published last year, one led by Harvard group, and one led by our group from ELSA Brazil, the second one. And 2 new papers were published this year. And they address, with a single outcome, diabetes, the association with the subgroups of ultra-processed food. But for diabetes prevention of its complications or its incidence, we need to consider many outcomes and not just incidence of diabetes, because we are concerned about diabetes complications as well. So the purpose of this, our presentation this morning is to assess the association of pre-specified subgroups of ultra-processed food with incidence of numerous cardiometabolic and related mental health outcomes. And we did this in Elsa, Brazil. The outcomes that we assessed were a large weight gain, a large waist gain, metabolic syndrome, hypertension, metabolic associated steatotic liver disease, diabetes, common mental disorder assessed by CSAR, it was a questionnaire, a score of at least 12, depressive episodes and anxiety disorders also assessed by this questionnaire. And we did 3 steps of analysis. First, we evaluated the association of ultra-processed food as an entire group with comparing them with the other processing categories, and we did that for all the 9 outcomes. Then we divided ultra-processed food in their subgroups and did the same type of analysis. And finally, we got those subgroups that were not found to be statistically significant and aggregate them in a single aggregate, and then evaluate this aggregate with the 9 outcomes. So here is what we found. First, analyzing ultra-processed food with all these outcomes, as you can see in the right, all the 9 outcomes were associated with increased consumption of ultra-processed foods. Now, when we separate them in subgroups, and you can see in gray in the left, what are the subgroups? Ready packaged bread, baked and fried snacks, non-dairy sweet snacks and desserts, spreads, yogurt and dairy sweets, processed meats, ready-to-eat, heat mixed dishes, sweetened beverages, and distilled alcoholic beverages. And you'll see in red and pink analysis that show risk. In light dark and green, protection. And white, no association. And we differentiate by darker colors those that were statistically significant in this individual analysis, these individual associations. So what we can see is that processed meat and sweet beverage indeed were the subgroups that consistently were associated with increased risk, that the common mental disorders were the outcomes that were more frequently associated with increased risk. And now the third analysis that we did was once we found some subgroups that were statistically significant, we got the remaining ones that were not and put them into one aggregate to find out if the aggregate would constitute risk. And this is what we are showing here. So we are comparing for each of them the overall assessment, the remaining items, and then the remaining items adjusted. You know, what was this additional adjustment that we are doing here? We adjusted for what was statistically significant so that we could indeed say that the aggregate remaining represented risk. And what we found for elevated weight gain and elevated waist gain, we found that the aggregate was also statistically significant. And for common mental disorders, the same pattern. So our main results show that most subgroups of ultra-processed food predicted risk for at least one of the outcomes evaluated, that sugary beverages and processed meats were the most frequent risk indicators, the large weight and large waist gain, as well as common mental health conditions, were frequently predicted by individual subgroups of ultra-processed food, as well as by the remaining aggregate not found individually significant. So although varying across outcomes, the overall picture of ultra-processed food subgroup intake is frequently indicative of risk. Waist and weight gain, as well as common mental health conditions, frequently represented increased risk. Yogurt and dairy desserts appear protective for diabetes, which is consistent with other studies. So in conclusions, since a healthy diet signifies the prevention of various health outcomes, not a single outcome, as is traditional concept of a healthy diet. The avoidance of ultra-processed food intake is a helpful concept of a healthy diet for general clinical and public health messaging. And this message is relevant also for the prevention of diabetes and its complications. Thank you.
Thank you. Interesting. I'll have to revise my diet.
What I found surprising was some of these ultra-processed food does give protection to certain things. I was very, very amazed actually. MASLD was protected by certain kinds of ultra-processed food you mentioned. I mean, how do you explain that?
Yeah, we actually have done quite a bit of work in Elsa, Brazil regarding the specific group of that appears here, the dairy desserts and yogurt. So we were already shocked by this fact in the beginning, even before we start using the ultra-processed food concept. It's well known that milk products, particularly yogurt, protect against diabetes and protect about various cardiovascular disease outcomes. So even if they have some additives that could be related to risk, overall they still confer protection.
You showed the risk with the common mental disorders was very high. So could it be that because they have a mental disorder, they are consuming more of junk food or ultra-processed food? Or was it the ultra-processed food that was leading to the anxiety?
Reverse causality? It's always possible, reverse causality, because we have a long follow-up. The longer the follow-up, the least the possibility of reverse causality.
Yeah, also, we excluded people that had those conditions at baseline.
Yeah, that's basic cohort analysis, yes.
Bharat Chabu, yeah.
Good morning, everyone. Thank you, chairs and judges, for allowing me here. So I'm going to present the work which we have done in monitoring. Basically, CGM, we all know since 2015 is in India, and we are using this tool. So we thought of with the idea that since 9 years we are using CGM, and how is the practices and preferences still holding amongst the Indian clinicians, specifically the clinicians who are working in the field of diabetology. Let they be primary care physician or super specialist. Let us try to see, and this was a small attempt at that. So because we all know that glycemic control is the must and integral for any clinician, and what patients wants is a good glycemic control, and doctor also strives for the same. CGM, we all know, has proven its value in achieving that glycemic control through all those small tweaks which we can bring in our treatment and lifestyle with the help of CGM, because it gives us a real-time tracking. And that is what is very, very useful when we want to titrate, up titrate, down titrate, or even modify the lifestyle. Now we also know that Indian population is very unique because we are a predominantly carb eater diet. START study has proven this, and that is what gives the glycemic variability. The glycemic variability is very high amongst Indians, as we see. There are also cultural practices, lots of fasting, geographical variations also. The food changes every 200 kilometers, how they take, when they take, and what they take changes every 200 kilometers. And that is what necessitates a personalized care in diabetes, which can only be done with the help of a continuous glucose monitoring if done right. Now, understanding the current practice is very important to look for the way forward. How we move ahead depends on what we are and where we are right now. So that is the whole idea and background from which this study originated. So the objective was to understand the practices and perception of Indian clinician regarding the uses of CGM in especially type 2 diabetes mellitus. We were restricting our study to type 2 diabetes mellitus. So what we did, we actually did a cross-sectional questionnaire-based survey. Google form was floated via mail to various practitioners. It was geographically diversified, the population, and we sent an email with the Google form link and asked them to fill the form. This was done between January 2024 and April 24. The clinicians who were involved in diabetes care and agreeing to actually B part of the survey were included. Then data was analyzed and we expressed the descriptive statistics using Microsoft Excel, and for Microsoft 365, Microsoft Office we use for this. The demographic which we had was a sample size of 310 clinicians from 140 cities across India, and they participated in this survey. 70% and more than 70% were young population. So we thought that they are more inclined to give surveys, but that is our assumption. We cannot comment on that. But most of them were young clinicians who were responding to the survey. As far as qualification was concerned, most of the doctors were MD physicians, those who were working as a physician level, and they were 80% of the whole flock. 6.77% was the super specialist, and 13% was MBBS doctors who are working as a primary care physician at the ground level. Now, regarding practice setting, when we saw the breakdown, 62% were private practitioners, 4% were government practitioners, 25% were working in a corporate hospital, and 7% were working in a nursing home, either their own or someone else. Now, proportion of type 2 DM patient on oral anti-hyperglycemic agents who are recommended to perform CGM by the doctors. So, over half of clinicians, 58% to be very precise, mentioned that up to 20% of their type 2 DM patient on oral drugs were recommended CGM. When we further digged out the data, then we saw that on insulin, 70% of the clinician mentioned that 40% of type 2 DM patient on insulin therapy were recommended. This is recommendation. This is recommendation by doctor during one or other consultation over a period of time. So 40% actually recommended to their insulinized patients. What was the annual frequency of CGM testing which is recommended? 2/3 of doctor recommended frequency of CGM 1 or 2 times a year. So this was actually recommendation from doctor which was coming, and they were able to recommend it once or twice in 2/3 of the cases. So it was a good representation of recommendation as far as we thought. Now, when we asked further, what was the top 3 recommendation for recommending CGM in patients? So first was to titrate the dose of the drug, and second was to understand the impact of diet on the glucose level. Third was to know about the proportion of time for which glucose level are in target, which is we commonly call as time in range. When we ask them to rate the usefulness of metrics, there are various metrics which the CGM gives. The usefulness of metrics which is provided by CGM to assess glycemic control, when we wanted them to rate them, they found time in range to be very useful. They found average blood glucose to be somewhat useful, time below range for somewhat useful, and time above range they were neutral on this. There was no clear outcome regarding that. Regarding the study, if I talk about strength, it is a pan-India survey. It has a very good geographic divide, a demographic divide, which is very good. But like any study, it has on its weakness, and the weaknesses are because it's a very small sample size. So we need to have a larger data to support our findings. And secondly, it is only perception. It is not the real practice because the surveys were anonymous. So it was actually doctor who are putting the answer. We don't know the intention, whether they are true in answering what they are actually doing and what they are preaching. Whether they match or not, we don't know. We don't know the intention. But yes, there is definitely a way forward. The way forward is to verify these results from actual clinical practice, which we would like to do. And to conclude, I would say that this result show preference of CGM in Indian clinician. It is not like that it is not preferred. The top reasons for CGM includes optimizing medication, understanding of impact of diet, and knowledge about proportion in time in range. And among patients who are recommended, majority are recommended once or twice a year, not continuous. And knowledge of time in range was the most important metrics which doctors were looking at as far as CGM was concerned. And the last thing, because technology will be there definitely in diabetes, so technologies in diabetes management seems to be increasing in Indian healthcare system. With that, I thank you all. Thank you.
Thank you. It's interesting to know the attitudes of physicians. I wonder whether this reflects that they recommended, or whether there is some restriction because of cost. Could you tell the difference between what they recommended and what was actually performed?
Sir, your question holds the answer actually. In India, we are a cost-centric country. So recommendation is one thing and affordability is another. And we are looking forward to a CGM matrix. Either it should come down in cost for a country like India. Secondly, we are looking for public-private partnership, and many of my friends are using that way also, where we are using public-private partnership between various pharma companies and various social organizations, those who are giving CGM to the needy patient.
Yeah,
That is how we are doing.
But the data refers to what they recommend.
Yes, sir. What they want to do.
And about the use of insulin, could you differentiate between basal insulin or multiple doses? Because
Very good question, sir. And unfortunately, we missed that question. And we later thought when we were analyzing the data that we should also have incorporated. But in future study, we are trying to do a much robust, including orals also, what orals patients are taking and what they are recommended. Because like insulin, orals also hold key for hypoglycemia and other things.
That's right. Thank you.
But my one question is, one drawback should be that most of the doctors were from the private setup. That's why the use of CGM is so high. I saw only 4.5% are from the government hospitals. Because the evidence for CGM in type 2 diabetes is not that great. So I think people in the private setup are using it because they can use it, because they want to use it. You saw most of the reason was just to see what's happening.
Yes.
I mean, the indication for use was, I just want to see.
Yes.
No specific indication. I'm surprised they were not interested in the risk of hypoglycemia.
Yes.
They only want to see time in range. So it's a tool they're using, and that's because.
And sir, this is where this study is actually useful, I tell you.
It's very interesting, yes.
I thought that they should be taught first, that hypoglycemia is the first thing to look for in CGM. They were more interested in looking at the graphs and the TIR, because I think we are somehow more talking about TIR and we are not talking about hypos that much.
They're playing with the tool at the moment. I think that's what this survey tells me.
Yes. Yeah, sir, please.
Do you have any data on what the patients said? What was their experience?
Sir, not this study. I presented my study, which is PE-CGM study in ATTD this year. And this was not this actually cohort, so it is not justified if I say this study data is this. Patient perception was very good in my study, which
that's
I
what
did.
I would have suspected.
Yes.
And they would
Patient
have wanted
perception was very good, and there was an addictive approach in patient, what we found in our study, where once the patient was on CGM, he wanted again to be on CGM if he is affording it, because that gives him actually the true picture of what he is doing, what he is eating. And the biggest part was, all the patients who are on CGM, 92% of the patient had their HbA1c level lowered.
An educated patient is the best patient to have. Thank you.
Okay, I think we'll move on. Thank you, brother.
Thank you, sir. Thank you. Thank you, everyone.
Nitin, are you here? Yeah, please.
So, good morning all. Firstly, let me thank the organizers for giving this opportunity to present our data. So what we're seeing on screen is a real-world study, which is about the influence of hypertension duration on clinical and the baseline demographic characteristics among the Indian patients with the hypertension who are receiving telmisartan and amlodipine fixed dose combination. So we have labeled this as a TACT India study. So as per the ICMR India study, the 17 data. So what we see in India, the prevalence of hypertension is 35.5%. With this data is over a 1,13,000 patient population who have been studied across India. And the rationale, what over here is that hypertension, as we all know, that it leads to the severe healthcare complications if it is left untreated. And as per the 2023 guidelines, the ESH guidelines as well. So the RAS blockers, the ACE inhibitors, the ARBs, along with the thiazide diuretics or a CCB has to be there for controlling the hypertension. And however, there is a lacuna of the real world data or the recent data for the Indian patient population. So hence we thought of having this study of telmisartan and amlodipine FDC amongst the Indian patient to understand the safety and effectiveness. So the objective was to see the effectiveness and safety of this combination amongst the in management of hypertension. So we had this patients of hypertension who have been enrolled. The combination used was telmisartan and amlodipine, and the study duration was of 8 weeks. those patients who were more than 18 years of age were included. Newly diagnosed patients of hypertension where their systolic and diastolic blood pressure were more than 140/90 mm of Hg, or those who were uncontrolled on monotherapy with this blood pressure were eligible for this for enrolling in the study. Those patients with known history of hypersensitivity to any of the component of this product, or the pregnant women, or the biliary obstructive disorders, they were excluded. The primary outcome, what we are going to see, the change in the SBP from the baseline to week 8, and the secondary outcomes to assess the percentage of the patients who are achieving this goal of coming into the category of less than 140/90. So that was the whole idea. And to describe the demographic characteristics, because the data was not there with us, or the latest data is not there. Of course, the safety outcomes we will be looking at. So what we are seeing is the methodology, and what we are going to see is the interim analysis, which is the baseline characteristics of the patient population. So after getting the EC approval and consent of the patients, they were screened, enrolled. With this, we could manage to get 6,232 patients. They were given the standard of care along with the telmisartan and amlodipine FDC. And the assessment of the baseline parameters were done. So what we are going to see is the interim analysis of this, and towards the end of the study is completed as of yet. What I'm presenting is the interim analysis of the baseline characteristics. So what we are going to at the end of the study, what we're going to assess the change in BP and any assessment of the adverse events, if any. So the interim analysis objective is to see the baseline characteristics of these patients. So we could get around over 6,200 patients of hypertension, who were out of which the new onset hypertension patients were around 33%, and the long-standing hypertension patients were around 77%. The demographic-wise distribution of the age, if we see, most of them belong to the category of 51 to 60 years of age. The second most common category was the 61 to 70 years of age. If we gender-wise distribution, of course, the pale patient population was more in both the groups, be it new onset or the long-standing hypertensive patients. Compared to coming to the BMI and the waist circumference, the BMI of the new onset or the long-standing hypertensive patients was almost similar, but there was a difference in the waist circumference of the patients who were of new onset and the long-standing hypertensive patients. The demographic distribution, if you see, the active versus sedentary, those patients who were active or sedentary, so the maximum patients who are active in both the groups compared to the sedentary lifestyle. Coming to the comorbid conditions, of course, diabetes and hypertension go hand in hand, which is always known. So the study also shows that in real world, it is going hand in hand, and maximum patients were seen of diabetes mellitus. And the most common medication which was given was metformin, of course, for these patients. So this is all the real world data which has been prescribed in the day-to-day practice. So with this, we concluding that the sub-analysis of the TACT India study among the Indian patients with hypertension who are receiving this combination of telmisartan and amlodipine underscores the importance of considering the patient characteristics such as age, the waist circumference, the comorbidities in tailoring the management of hypertension management strategies among the patients who are of new onset or of long-standing hypertension. So these are my disclosures, and thank you. Thank you for patient listening.
Thank you. You did a very good time. There's time for questions. I wouldn't consider this an interim analysis because you are actually just showing the baseline characteristics. Yeah. Interim would mean showing results before ending the study.
Absolutely.
It would be interesting to, try to match and compare with other treatments. Since you have a large population under observation, you can actually compare those who were taking this combination with those who were taking other type of treatments. And you could actually there are some statistical methods like propensity score matching to try to match the different characteristics that may influence your treatment. Otherwise, you never know if what would have happened if they had received another treatment instead of the one that you are giving.
Right. Yeah.
Sorry, but I have a question. There was more heart attacks, more cardiovascular disease among the newly treated than among those who were
Long-standing.
long time. How do you explain that?
So could be the lifestyle changes which are happening in the younger patient population recently. So probably we are not moving the sitting at one place because our lifestyles are that way. So that could be the possible reason that it is more of cardiovascular disease are seen in the recent younger patient population who are being newly diagnosed. While the long-standing ones, they are taking their medications appropriately. Even the younger patient population, the newly diagnosed which are there, they may not be identifying or knowing the symptoms or reaching out to the HCPs immediately, that probably stress-related, work-related effect and headaches, and also probably which are the common symptoms, or palpitations, which could be related to anxiety. So those type of symptoms which are usually neglected in the younger patient population nowadays. So that could be the explanation.
We still have time, that's why I'm asking the question.
Sure.
It's more of an observational data, right? Just to show that your combination.
Absolutely.
Is it a post-marketing study? Because I mean, why don't you compare it with, say, telmisartan plus cilnidipine? I mean,
right. It's a real world study, sir. That is what we wanted to see. That what in practice does it really reflect what has been studied earlier? So this has been proven. This is not a new science.
a lot of studies showing that telmi and amlodipine work.
Right, but the characteristics were not there. The recent data of the hypertensive patient characteristics is not there. So that was the thing which we discussed with the steering committee members also before designing the study. So we had a group of cardiologists, physicians in this as a steering committee members.
All that. I mean,
yeah,
I'm still a little bit confused about the purpose of the study. I mean,
right. So this is about the real world practice of managing hypertension.
So real world data.
Real world data. So which is very less. Yeah. Thank you. Thank you for patient listening.
Subhashri.
At the outset, I would like to thank DRS Organizing Committee for giving me this opportunity and pay my regards to the respected chairpersons present here. My study is about incidence of delay in treatment-seeking behavior among type 2 diabetes patients. It is a clinic-based cross-sectional descriptive study in India and conducted across Mumbai, which is our very own city, in 20 centers. The very inception of this study, sir, was because we realized that type 2 diabetes diagnosis does not mean treatment, especially in India. So the source of data for this study was the day-to-day patients who came to our OPD and those who consented for the study. It was a multicentric prospective cross-sectional study, real-world study, and the data was collected over an ECRF. It was conducted over 3 months in treatment-naive type 2 diabetes patient whose inclusion criteria was age more than 18, patients diagnosed with type 2 diabetes, they were drug naive and they consented. The exclusion criteria was age less than 18 and the patients who were diagnosed with any other type of diabetes. We had approximately around 487 patients in this study with a good gender split, approximately 55% women and 45% men. Average age group was 46 years and an average A1C at which we detected the patients was somewhere around 9. The comorbidities that we encountered during this study in the patients were most commonly hypertension followed by hypothyroidism. There was a history of stroke, erectile dysfunction, cardiovascular diseases. The delay in coming to allopathic treatment and what were the treatments which were tried by these patients in the interim period. 47% of the patients who were diagnosed with type 2 diabetes delayed their treatment by 3 months. Alarming figure of 14% patients delayed their treatment for more than an year. 58% of those who delayed the treatment have been using alternative therapy. Now, in alternative therapy, we wanted to know what kind of alternative therapy was preferred by this patient. So we realized that Ayurvedic was most preferred, that was about 61% of patient, homeopathy 24%, homemade medication 10%, and Unani was tried by about 5% of patient. Lifestyle and diet interventions were hardly tried by any of these patients. Now, The source of recommendation of alternative medicine and attitude towards modern medicine. To our surprise, in a city like Mumbai, only 40% of the patient consulted 60% of the patient consulted a certified doctor and 40% did not consult any certified doctor before trying these medications. So, out of those who delayed the treatment, gave us an explanation that they don't want to try modern medicine because it needs to be taken lifelong, it has serious side effects, it does not cure or is not effective, it's expensive. And then we were told that our family members tell not to treat the diabetes immediately after the diagnosis. It can be taken care by alternative medications. So these were the recommendations that were given to the patients. 40% did not go to any certified doctor. In the discussion, when we referred to the literature, we realized that there was hardly any literature on how many percentage of patients delay the treatment in type 2 diabetes. We came across a couple of studies which were conducted by Galib R in 2020, which said that patients do try Ayurvedic treatment, but the amount of delay that happens between diagnosis and treatment was, and especially allopathy treatment, was not mentioned anywhere. There was another study by Shukla in 2020 which said that 44% among these patients were trying alternative therapies. So generating awareness on good practices was very important. To conclude it all, I would like to say that our study participants who visited the clinic, 46% have delayed the treatment for more than 3 months, 14% more than a year, and 27% more than 6 months. Of these participants, 58% have tried alternative treatment, 32% have tried lifestyle and dietary changes, and 10% have not done anything about knowing that they are type 2 diabetes, they have not done anything about it. 61% of the patient tried Ayurveda, 24% tried homeopathy. Again, over 60% of the patients did not consult any certified doctor before taking these medications. They have referred to internet, they have consulted family, they have consulted friends. This study highlights a substantial delay in treatment-seeking behavior among newly diagnosed type 2 diabetes patients, especially in metro city like Mumbai, where the access to a specialist is extremely good. These delays leads to poor initial glycemic control. The study emphasizes the importance of enhanced population education and to start the early intervention in management of type 2 diabetes to prevent complications and improve long-term outcome. Today on this forum of WCPD, we are talking about preventing the complications of diabetes. This very study, we all know as treating doctors the importance of legacy effect, the metabolic memory, the importance of starting the treatment early. And this is where we are in the city of Mumbai, where patients are not even starting the treatment after diagnosis of type 2 diabetes. Thank you so much for the patient hearing.
I think these are pretty good results actually, because it's Mumbai. I'm sure the situation is much worse. Here I see only let me read about only 46% 3 months and about 14% for a year. I'm sure in other parts of the world, it
Sir,
must be much more than
absolutely,
this.
sir. We wanted this to be a pilot project in Mumbai, and these data needs to be reflected in every metro city as well as in rural India, so that we start some good awareness programs all over our country and take this initiative forward, sir.
My question would be, it's not clear to me what is actually delayed treatment, because they actually had consulted a physician when they were diagnosed. So I wonder whether it's non-adherence to treatment when they were advised to change the lifestyle, or maybe inertia from the physician who saw them for the first time. I'm not sure what would be the definition of delayed treatment. Is it medications?
It is medication, sir. Basically, the criteria is that any patient who knew that he's a type 2 diabetic on any kind of screening that he underwent for his job purpose or employment. He was aware that he's a type 2 diabetic, but he did not want to seek the treatment despite being aware, sir. He delayed the treatment. That is what it is about, sir. So he was advised, but he probably did not undergo any treatment.
Sorry to, but then that would mean that they avoided medications that
They
were,
avoided medications,
that were
sir.
prescribed.
Absolutely, sir.
Okay.
Yeah, please go ahead.
Yeah, very nice presentation.
Thank you, sir.
I can imagine a lot of these people feeling, oh my God, I'm told that I have this disease. It's going to wreck me financially. It's going to wreck my family financially. So the question is, if these were to go to public hospitals or public clinics, what would happen? Would they get good care? Would they get free medicines? Or would they end up standing in
Yes,
long
sir.
lines and getting virtually nothing?
So most of our government hospitals are catering to them with free medications. Although they are given prescriptions by probably not a qualified diabetologist, but they do have access to MBBS doctors, sir. And it is easily available in India, sir.
My question is, seeking help from a Ayurvedic or a homeopathic doctor, that's not delay in treatment. You see, the patient realized he's got something wrong and visited a qualified, I mean, it's not allopathic doctor, but he did visit a doctor, so he can't say it's delay.
So these patients did not visit a certified doctor, sir. They have used internet, friends, family as their recommendation. So certified doctor, those who visited were only 60% out of them, sir.
10% use home remedies. Please tell me, I want to try what home remedies did they use? Okay, thank you.
Sir, there is a list out there. I'm sure you're aware about it, what goes on here, sir. You're very much among us, sir, when it comes to it. Thank you so much, sir.
Good morning, everyone. I'm Dr. Anushree Mehta. I'll be presenting the study today. Our study was guiding adolescents with diabetes into adult care. So it is very widely known that adolescents with type 1 diabetes continue to have a worse diabetes control. They have a significantly higher HbA1c when compared with younger children and adults, despite the substantial advancements in the technology over the last 2 decades and the extensive improvement in our understanding of the disease. Due to these challenges, the pediatric department and the adult diabetes clinic joined forces and they created a transition clinic that was especially meant to assist teenagers and young adults in making a switch from a pediatric to adult model of care. This is the first structured diabetes transition clinic for type 1 diabetes patients in a tertiary hospital in Mumbai. The purpose of the study was to evaluate the efficacy of the recently created transition clinic. This is a retrospective descriptive study of emerging adults with type 1 diabetes who are treated in a transition clinic jointly operated by a pediatric and adult multidisciplinary care team during 2022 and 23. And the primary outcome was the glycemic control as well as the incidence of acute and chronic complications. The secondary outcome was the knowledge, attitude, and behavior towards the condition and continuation of treatment following the transition. So the mean age, there were around 23 patients who were enrolled. Unfortunately, 7 were lost to follow-up. The mean age was 22. Age at the time of diagnosis, mean age at the time of diagnosis was 7.69. Male is to female ratio was 9:7. The BMI was 21. The average duration of diabetes was around 15 years. Most of the patients were graduates, and most of them were employed except for one patient who was unemployed, and 100% of them were on multiple daily insulin injections. If you look at the primary outcome, at the HbA1c, you can see that at baseline, the HbA1c was very high, it was 11%. At 3 months, it came down to 9.96. At 6 months, it came down to 8.24. And at 12 months, that is after a year, it was 8.19. So there was a significant improvement in the glycemic control. Now, if we look at the incidence of acute complications, so in the year prior to enrollment or prior to starting the transition clinic, the incidence of DK and hypoglycemia was actually quite high. During the 1 year of the transition clinic, that is the study period, the incidence came down significantly. And since then to now, the incidence has been very, very small. There were only 5 of them who had mild NPDR. None of them had any microalbuminuria or neuropathy as tested clinically. So this was very interesting to look at the knowledge, attitude, and behavior. So before the transition clinic, if you look at the various questions, the orange is no and the blue is yes. So when we asked them if they carried a medical alert identification, most of them did not. Do they feel constantly concerned about food and eating? Most of them said yes. Do you feel comfortable with diabetes in social situations? Do you feel uncomfortable? Most of them said yes. Are you confident with insulin dose adjustment? Most of them were not. Do you miss insulin doses? Most of them said yes to that. Are you confident with your insulin injection technique? Again, most of them were not confident. Do you know about carbohydrate counting? Most of them did not know about it, and most of them had difficulty in accepting their diabetes. So there was a high proportion of patients who had basic knowledge gap and inadequate diabetes management skill set with several issues before enrolling into the transition clinic. And after a year of transition clinic where education and other things were provided, you can see a drastic change in the knowledge, attitude, and behavior of these patients. All of them started carrying a medical alert identification card. They felt more confident, less concerned about food and eating, less uncomfortable with diabetes in social situation. They were confident with insulin dose, more confident with insulin dose adjustment, and none of them were now missing their insulin doses. They were confident with their insulin injection technique, and carbohydrate counting, I think, is always a little tricky. And most of them actually were able to accept their diabetes better. So after attending the clinic, the emerging adults showed a marked improvement in their ability to manage their diabetes, as well as they showed a substantial shift in their attitude. So guidelines must be there for how to run a structured transition clinic specific to the Indian situation. The transition clinic should include a pediatric as well as an adult diabetologist, and we should have a whole team of a dietitian, psychologist, social worker, educator, counselor, so one doctor army. The clinic should include sessions on nutrition, exercise, how to do various diabetes related techniques, what investigations they should do annually. We should give them education on how to manage their insulin dose, and what is very, very important is the counseling, the support of the family, and we have to give them a positive reinforcement every time we get an opportunity. In conclusion, a well-designed transition program and multidisciplinary care team can improve glycemic control, maintain continuity of care and clinic attendance. Maintaining adequate glucose control is the ultimate aim of type 1 diabetes treatment. We want to enable the child to develop into a self-reliant and a self-assured adult. Thank you. Yes, agreed.
Children under control.
Yes.
Usually the transition makes things worse. But here, what you show is that they were much worse.
They were much worse.
Is it because of pediatric treatment of children is not good? There is no, is there a huge difference between the way the pediatric diabetologists
pediatric endocrinology is a new field in India. It's only now that we are seeing a lot of pediatric endocrinologists who have, special focus on type 1 diabetes. Otherwise, most of the type 1 children were actually being managed by adult diabetologists previously, or their pediatricians. So that special focus on type 1 diabetes is happening now the last few years, in India at least. And I think that's why because this was a government setup, so a lot of these children were probably lost. They did not receive the education that they should have received earlier. And maybe that's why we have such great results as far as the attitude and behavior is concerned.
I think that should be the conclusion of your study. It's not the transition clinic which made the difference.
Yes.
What made the difference is probably they got proper care for the first time in their lives,
Yes.
rather than the transition clinic, because the care before was
terrible.
I mean, I won't say substandard, very substandard. To get so many DKAs,
Yes.
I mean, that means they were mismanaged. So it's not the transition clinic. It's the first time that you put a team together and you gave them the care that they need. Over to you.
So I'm also part of the team, which is why I thought
Well
I'd just share a little bit of the context setting. So this is one of the largest tertiary care hospitals in Mumbai, wherein the pediatric department on an average sees about 200 to 300 new patients in the OPD. So it is very limited, the time constraint for a resident or even a physician in the pediatric department to actually see and talk to them. We, on the other hand, that's Kiran, Akshay, we all have a specialized diabetes OPD, wherein also we see a lot of patients, maybe about 50 to 70 patients on a daily basis. But because we are able to identify these patients and probably sit with them and set some context and give them some more education, all that, that's what probably is the difference. Yeah.
I think, thank you.
Thank you.
I think Amit was not able to present yesterday. Why? What happened? A flight got delayed or something?
So
you
I
can
will chair the session in another.
Okay, please come and present.
Thank you so much, organizers, for giving me this opportunity and considering me for presentation which was scheduled yesterday, but today. At the outset, I would like to pay my regards to esteemed judges as well. So what we're going to talk about today is evaluation of a point of care monitoring AI system for detecting diabetic retinopathy at community healthcare center. So these are a couple of community healthcare centers at one based out at Naigaon, which is Dadar in Mumbai only. So we know eye is a non-invasive window for diabetic complications. The other diabetic complications are usually screened by invasive methods. However, eye screening is one of the non-invasive methods. So we know that India is facing the significant public health challenge, and DR remains the leading cause of blindness in India, as well as there is limited access to specialized ophthalmologists in the urban, semi-urban, urban slums, and as well as in rural areas. So in such context, in such scenarios, AI can actually offer for screening of these individuals so that they can be referred at higher centers for further treatment and management. So it's more of a screening tool, but yes, it will prevent that blindness overall. So we are thinking about a rationale wherein we can deploy such kind of methods which are initially one retinopathy consultation, one fundoscopy consultation costs around 3,000 to 5,000 rupees. Similarly, we can reduce down to such tools at very, very less cost at primary health centers and urban health centers. So the aim is to evaluate performance of an AI-based grading system in GR, as well as look at its feasibility. So at the methodology, it's an observational cross-section study done at a couple of centers. One of them is a geriatric center, geriatric diabetes center, and another one is a diabetic OPD in urban health center. So the study population is type 2 diabetes patients, and we followed the convenient sampling technique, and ethical approval was taken from my own medical college. Okay, so this is most of us are aware of this is how the screening is done. There's an image you put. There are some points wherein there are some hidden layers in each and every image, and there is an output layer at the end, and it just gives us a probability of having a diabetic retinopathy, or whether the patient has it or does not have it. So development are deep learning models, not an AI or not a ML as well. It's more deep learning, and the model architecture is deep convolutional neural network models, and image was quality controlled with the help of deep learning as well. Deployment was done over the 4 weeks in primary healthcare practices, which is a couple of centers, and 4 team members were trained to take the images out, and the patients underwent the imaging, and the images such captured were assessed by AI on one side, and the gold standard was a trained ophthalmologist from KN Hospital who assessed there was a gold standard. So what we found out is that microaneurysm being the most prevalent, followed by hemorrhages, hard exudates, and as far as the results are concerned, the overall accuracy was pretty good for diabetic retinopathy, which is 84% with confidence interval, as you can see, and diabetic macular edema of 90%. Overall, PPV for DR, diabetic retinopathy rejection, is high, which suggests that the individuals with positive test results are highly likely to have a diabetic retinopathy. However, the PPV of the DME is little lower, so there is a chance of higher false positives. But as this is a screening tool, we can still have those higher false positive and send them across to the tertiary care centers, and further evaluation from ophthalmologists can be done. So the whole crux of these kind of tools could definitely be screening of all the individuals who are suffering from diabetes, early picking them up, and then treating them accordingly. So my conclusions are the AI system demonstrated effectiveness in identifying moderate to severe DR with potential to improving screening efficiency in primary care setting. And there are some limitations like high false positive, but when we look at the context of this particular kind of project, we always look at the picking them up at the earliest and maybe referring them back to the ophthalmologist. So probably those high false positive could be beneficial at the end. AI needs continuous learning. That's why it is deep learning, and it again and again, more the number of images, more accurate the results would be. As I mentioned in one of my slides, is the earlier images were taken out from some databases which are already available. So these only images which we have captured are still being used for further refinement of the device. These are my references. At the outset, I would like to acknowledge the GA Institute of Technology of Innovation and Development Group with which we could do this project. And it's an academic work supported by Department of Community Medicine at GS Medical College and KM Hospital. So this is one of the area which we did. It was actually a computer room of one of the schools, small schools, and there we could do it because it requires a dark room and all. So in the limited resource setting also, such things are possible. As it comes to Mumbai, it's always Bollywood, and there's a very beautiful song by Aanखें भी होती है दिल की जुबां और बिन बोले कह देती है हालत ये पल में बयां. So it's a window of
Can you
us.
translate that for Pablo, please?
The first slide is window to diagnosing the diabetic retinopathy. Thank you so much, sir.
Okay, my question, this sounds too good to be true. Your positive predictive value was quite high, and negative, I mean, you're not missing DR. Compared to other systems which have been used around the world, how do you compare your data?
Yes, sir. So the sample size was pretty low. 250 only were taken. So probably that is because the sample size, the denominator is low, and probably that's why it yielded high for false positive.
The very few false negatives,
Yes,
see, what I am concerned is if I get false positive, I'm not worried.
Yes, sir.
I can get my ophthalmologist to see it. If you give the false negative, if I miss a DR or a macular edema, then that's an issue. So compare it with the literature, and you have compared with other studies?
No, in the discussion, so because being a paper, we did not compare the discussion part here. But what I'd like to probably, it could be again the limitation. One of the center is geriatric OPD. So probably that is one more thing wherein the prevalence being high, the PPV is high, probably.
Sir, go ahead. Amit, hi.
Hello,
Congrats, first of all. And after a long time, I'm seeing a AI paper on retinopathy because I've done some good work over retinopathy in the last 6 years or possibly more than that. In fact, I'm talking tomorrow. What I would say is you mentioned microaneurysms at one slide, results 1, and then you jumped to results 2 where it did not appear. And in your conclusion, it said moderate and severe DR. So is your program in AI not eligible or it's not capable of identifying the microaneurysm? Because that's the main thing. If you miss a microaneurysm, you lose everything.
Yes, sir.
Whereas moderate and severe DR, any stage, everyone present out here, irrespective of which fundus camera you're using, you will be able to identify there's something wrong going in that
Certainly.
posterior fold of 45 degrees, which includes the optic disc and the macula. So do you think that then the AI would make a big difference? Because AI would be helpful to me if I'm able to identify that particular microaneurysm. Even one microaneurysm is not innocent
Yes.
for any other purpose, right? So what do you think about that? A, and B, diabetic macular edema is a question, do we need to confirm it either with an OCT or anything else? Because many times what I've seen is when you do an AI, they say DME. Actually, there is no DME going on when you do an OCT. Does it add to an extra cost to your patient?
Yes, sir. So again, being a screening, I'll answer the first. Thank you for the question, and I'll answer the first question. Yes, microaneurysms are there, and the overall DR was considered. All of these factors which were presenting in the DR were considered as positive in severe and moderate. So that's why the overall picture is
So the mild diabetic retinopathy stage, which includes only
microaneurysms.
is missing.
Yeah, is missing. Yeah, it is missing. Certainly, sir. Certainly, sir.
What was the reference? I mean, what did you use as a reference to say that there was or there wasn't?
Yes, sir. OCT was not done. It was again based on the same images. And the images only were, so the gold standard was the opinion from an ophthalmologist. That's it. So because OCT is a, yeah. So probably, so we'll study it further and for the further analysis, we'll keep it. Certainly, sir. Thank you so much, sir. It will definitely add up to the quality of the research. Thank you so much. Thank you so much for the patient listening.
I think we have concluded. Thank you very much. Thank you to all the presenters. And what group picture for everybody. So all the presenters, please come on stage. All the presenters, please.
Thank you. Thank you.
Yeah, yes.
Right. Moving ahead with today's session on Miss Metabolism, Dr. Kiran Shah.
Hello, good morning everyone. Today we are going to have one more session, Mixed Metabolics. First, first topic is OSA and metabolic syndrome in real world by Dr. Shaila Sheikh. She is a very good orator. We have listened many times. She is a endocrinologist from, one of the best endocrinologists from Bombay. So I request her to start.
Thank you. Thank you for those kind words. Good morning, everybody. Since we're a small group, maybe if I can have a hand mic and we can make this a little more interesting and interactive. Okay with everybody? Great. Okay. The topic assigned to me, as Sir has just announced, is OSA and metabolic syndrome. Tell me honestly, in your clinical, we are all busy clinicians. And we also have, I'm also going to ask today the pharma industry some questions also. That when you look at a patient who's sitting in front of you, maybe it's OSA, as we all know, when you talk about OSA, you talk in terms of a constellation. It's a syndrome, right? You're talking in terms of abdominal obesity, insulin resistance, you talk in terms of hypertension, dysglycemia, and dyslipidemia, right? So when you look at this patient who's sitting in front of you, and when you look at, you mainly think in terms of, I guess, blood pressure, you think in terms of sugars, you may think in terms of cholesterol. Do we ever ask this patient, are you sleeping well? Do we ever ask them? Till the patient complains to us, and oh wow. Every patient? Bowel movement and sleep. Achha, sleep is asked to every patient, then great.
And bowel movement. And bowel movement. Very important.
Okay, I'm very impressed by this group. Then I think, sir, mujhe baat hi nahi karna chahiye. Okay. Stress, yes. Stress we do all inquire, because stress we believe is yes. But generally we don't tend to ask them, see, most of the patients tell we don't sleep well, and then because they have pain in their legs or something like that. Most of them, at least my metabolic syndrome. But to be very honest, learning experience for me, I don't actively inquire regarding their sleep. Are you sleeping well is not a question. Venkatesh, is a question you ask very regularly in your consulting? Sometimes. So Venkatesh is like me then. We are on the same page. I don't see 100 patients a day. So I can't ask 100 times a day. I see a limited number. So today I'm learning a lot. And that's the reason why I like these meetings, is because invariably I learn something before I go out of the room. And today I learned two very important things from everybody out here. I'm also going to go back and ask people to fill a sleep questionnaire and maybe look at that stop bang questionnaire a little more carefully, because I am guilty over here. Coming to the topic, sir, 5 minutes nahi reh sakte mere liye. That's not fair. Oh no, that's okay. Not an issue. As long as I have an interactive audience, somebody is actually listening to me, I'm more than happy. I'm so big thank you. Privileged. And the most important thing is, as long as I also learn something before I get out. Otherwise, it's a waste of a journey.
CID was lovely, so I made sure I come.
Oh, so sweet. Thank you. Thanks a million. That timer needs to be changed. Huh? Otherwise, Venkatesh won't be able to talk. Oh, so 7 minutes, not fair. Sir. Okay. Can I have a changer, something to change this also? Slide changer, please. That's fine now. So, abhi sahi hai. 15 minutes. Okay, so when you talk about OSA, we normally talk, most common form of sleep apnea is obstructive sleep apnea. That's something which we all know about. We all also, if I can have a point changer, that will really appreciate it. We all know these are basically repeated episodes of either partial or complete airway collapse. When it's complete airway collapse, thanks, bacha. When it's complete airway collapse, you're going to say, of course, apnea. When it's partial, you're going to talk about hypopnea. I won't get into that. What is interesting, the only thing which I put up in this slide, friends, is what's very interesting, look at these numbers. Like when you look at this number, this is 2019, and now we have 2023. Almost double. I don't know whether it is because of, to be honest, I don't know whether it is because of the increase in awareness, where we have started looking at maybe OS a little more seriously, looking at sleep disorders a little more seriously. We've talked about, maybe we're talking about a blue light affecting sleep much more seriously, apart from the OSA issue. But the fact remains that when you look at the presence of OSA at this point of India, at this point of time, there's a massive jump from 52 to 104 million. Whether obesity has contributed to it, whether it is that increase, we are the diabetes capital of the world is contributing to it, or whether our increased awareness is contributing to it, I think it's a little bit of everything which is finally contributing to it. Or maybe much more easier availability of being able to do sleep studies, we are able to do polysomnography at home much more easily now than what we were able to do 5 years back. But there are a number of factors which possibly could be contributing to this prevalence. Coming to signs and symptoms, most commonly, at least when I actually ask for a sleep history, to be very honest, is 2 or 3 clinical scenarios. I will ask about it if my patient tells me I'm snoring excessively, or the partner starts complaining, ma'am, nobody can sleep in the same room, which is a very, very common complaint. Or the second reason when when I realize this patient could possibly be having a sleep issues, if the patient says, I'm very sleepy in the day, I'm just feeling sleepy. Again, somebody complains, ma'am, you're talking to me and this guy or this female just goes to sleep, which can again be an issue of interpersonal issues. Or the patient starts complaining of a lot of fatigability, which I really can't understand. I mean, the parameters may look good, everything may be looking good, there's no medication which could possibly cause it, and still the patient could be saying, I'm tired, tired, tired. And that's when my brain starts looking for other reasons, and that's when I think these are the 3 most common. According to you all, I said in the beginning, I'm going to now make it very interactive and question. According to you all, is there some other parameter which you see much more commonly? These are the 3 parameters. Sir, chairpersons are the best people also too. Is there some other thing which you can, think of where you can think, these are the 3 things which I really look back and say, okay, there's something quite wrong over here. Something else which strikes your mind? What also I have seen in some of my patients is, when blood pressure is not controlled. Resistant hypertension is another reason where you find these patients actually have OSA. When I realized this, to be honest, I went back and checked out a lot of data, and what was seen is one of the sleep guidelines tell you that one of the reasons why you should evaluate a patient for OSA, for OSA is a patient who has resistant hypertension. Normally, we also say, yes, when you have a patient with resistant hypertension, 3 antihypertensive drugs, we know all the rest of the grind. But also, you're supposed to check these patients for obstructive sleep apnea, because though the patient may not have complaints, and again, data says that 50% of patients, mind you, don't have complaints. So you may actually be able to pick up OSA in a patient who apparently has no complaint, who's just coming to you with resistant hypertension, because one of the parameters most well studied in OSA, friends, is resistant hypertension. Okay. And if you look at the pathophysiology, if you look at actually the cause of it, madam, Maulik ma'am, if you look at, ma'am is my teacher, so I can stop anything for her. If you look at the obstructive sleep apnea pathophysiology, what do you really see? You see a patient who has definitely sleep fragmentation, there's no questioning that, friends, but the basic pathogenesis is the intermittent hypoxia. And what happens because of this intermittent hypoxia? We all know finally there's going to be oxidative stress. Oxidative stress is what is a direct result of the intermittent hypoxia, and finally this is going to result in a lot of inflammation. Now, how is all this inflammation connected? All this results in endothelial dysfunction. And this endothelial dysfunction results in a number of cytokines, in an increase in the intracellular adhesion molecules, in the increased leukocyte adhesion vascular endothelium. All these factors are going to be part of this inflammatory process. Actually, if you look at all our chronic disorders, whether be it diabetes also, we always say inflammation. We say inflammation is like that common soil which involves all these parameters. Now over here, as I said, refractory hypertension, and along with this hypoxia which you are seeing, what you are also seeing, friends, very, very important, is sympathetic activation. And a result of this sympathetic activation, again, is directly correlated to all, whether it's diabetes, whether it is hypertension, whether it is dyslipidemia, all these parameters which you are seeing as part of the metabolic syndrome. So there are 2 basic pathophysiologies. One will be the hypoxia, one will be the sympathetic hypertension, activation, and what happens as a result? This is the vicious cycle that you see. You see a patient with leptin resistance, you see a patient with reduced adiponectin levels, you see a patient with increased inflammatory markers, be it what may, and you see an obese person out there. And this obese person, as a result of this sympathetic activity and inflammation, results in decreased chemosensitivity, which is going to contribute to the sleep apnea. Now, this entire pathophysiology has also resulted in an obese patient, mechanical factors, which are again going to result in sleep apnea. So you are basically having a completely new pathophysiology, a new perspective as far as OSA and the metabolic syndrome goes. And this is what is now accepted. This is 2020 data which says that when you look at a patient of OS and obesity, you should be thinking not in terms of only a respiratory problem. You need to think in terms of a metabolic problem, because this has metabolic implications for that patient out there. So you've moved away from thinking in terms of only respiration, only CNS, only somnolence, only daytime fatigue, from all that to a patient where you're contributing to all the metabolic factors possible. Do I have data? When I'm saying all this, do I have data? A little crowded slide, because I didn't want to waste too much time in talking about everything, but huge amount of data out here which says, yes, there is connection, there is relation. What about a meta-analysis? What about reviews? Again, a systematic review which says, definitely there is, I would say that it increases the risk. They are definitely associated with each other. The exact causality is still not known. And there's no proof that there's actually they cause one or the other. The reason being is it's very difficult to do RCTs which actually show causality because of ethics committee clearance. So you can't get ethics committee clearance to actually say a patient who's having maybe severe or moderate OSA to not allow them to go on therapy. I mean, Venkatesh would know ethics committee clearance better than me. And coming to what kind of data shows that it does benefit, do we have data which says that yes, it does benefit patients? This is a there are actually a number of trials, 4 trials which are really the sleep study you have, the trial you have a number of trials. The reason I found this trial interesting was because when you look at the Rikatsa trial, what do you see is these were patients who had, this was a trial which was conducted to see whether CPAP can improve cardiovascular outcomes. These were patients with coronary artery disease, moderate to severe OSA, either on the CPAP or not on the CPAP. For how many hours minimum the patient should be on CPAP to see benefit? How many hours? At least 4 hours. 4 hours. Minimum 4 hours is what's required. 6 to 8 hours is perfect. That would be, but the patient to sleep for 6 to 8 hours for that. I mean, often our patients, the biggest issue now in our country has become inadequate sleep. So generally, because if you look at the sleep cycle per se, I mean, when you look at the REM and the non-REM sleep, what is seen that 6 to 7 hours is what our patients sleep. So if they do it at least, but minimum 4 hours, then that's reasonably decent outcomes. So what was seen over here, as I said, friends, is patients who receive CPAP definitely showed improvement in all those parameters that you were interested in. So maybe CPAP actually has a protective effect as far as cardiovascular health is concerned. So one of the other parameters that you should be looking at when you look at a patient of having cardiovascular issue is also their sleep health, also what kind of situation they have as far as their respiratory health is concerned. And because this makes a very, very big difference as far as metabolic outcomes go of whichever disease you look at as far as metabolic therapy is concerned. So how would you approach OSA? The reason I liked these, to be honest, these 10 sentences was because this has been labeled as the 10 commandments of OSA in one of the guidelines. And I really like the aspect of the 10 commandments. And what was shown over prevention. Prevention, of course, I believe is the cornerstone of any kind of therapy. There's no questioning that whatsoever. And once you think in terms, you've gone beyond the stage of prevention. We've already spoken about where you would suspect. But what is also very, very important is a high index of suspicion. Keep your suspicion index high. Think in terms of OSA. Confirm the diagnosis. You definitely need to confirm the diagnosis, and for that you would do a sleep study. As I said, we have a lot of home sleep studies available now. quantify what kind of sleepiness, which you can do with the help of some scores, which I will talk about. Very important to treat comorbidities, because finally you're talking about the metabolic syndrome, and you would be identifying each component of the metabolic syndrome and treating it. You would look at any kind of anatomic abnormalities. Generally, you and me suspect OSMO when you see a short neck, you see an obese patient, you see a patient with some kind of respiratory difficulty. That's when I think about OSA. I'm going to think about it more when I walk out about this room, thanks to you all. But even then, that's when I think about OSA. A weight loss program, very, very important once you've said that this patient is obese. And the reason I'm saying weight loss program is very, very important, because now we have medications available. We have better lifestyle available. The last presentation I saw was on AI with retinopathy. We can take the help of a lot of AI now where weight loss is concerned. We have many more programs to offer our patients. So that's one area where you can really work up. But all this has to be, mind you, after a conversation with the patient. I think it's very important that we keep the person at the center of care. We are increasingly talking about patient-centered care. Every decision is made keeping in mind what is feasible, what is not feasible, what is actually possible for your patient, and of course, supervise the correct. Don't write a CPAP and send the patient to somebody and say, okay, now you can look after the CPAP. Please see to that it is monitored. Please see to that the patient comes back to you with a sleep study. See to it that actually everything is right as far as the patient is concerned for you to really get benefit. Often what we all do is give a prescription for a CPAP and don't tend to then subsequently check. We just ask the patient, are you taking the CPAP? Patient says, yo, ma'am, I'm taking the CPAP. I'm uncomfortable sometimes. I remove it. The wife says, ma'am, after 2 hours, he just promptly removes it. And you just say, okay, you wear it carefully, do it carefully, and that's the end of the story. We can't afford to do that. When you're doing this, you need to follow up on this patient. I've got 2.5 minutes left for me. I'm going to quickly run through some of this, because most of it you all would know. I'll just focus on what I think possibly we should discuss. So when you look at a clinical eval, I'm sure everybody does it, physical examination we all do. The only thing which I want to put across over here, a family history of OS is also something which you should keep in mind when taking a history. And mind you, male gender is supposed to be a higher risk factor. These 3 questionnaires are what we use. We use the stop bank questionnaire a little more, so I'm a little more comfortable with the stop bank questionnaire, though the Epworth sleepiness scale actually is the most simple scale to use. It's just numbering. It's very, very simple to use. But clinically, what I use is the stop bank. We all know that we use the age, the gender, the neck circumference. We use all these parameters when we're looking at this score. And of course, the Berlin questionnaire is again a questionnaire mentioned, but personally, I have not been using it much. When you look at severity, diagnosis and severity, of course, the gold standard is the PSG in lab study. What is important is when we interpret it, when you're looking at a severe patient with an AHI event, more than 30 events per hour is what you would consider to be significant. That is significant as far as your patient is concerned. When again you're doing a home sleep study, please check that at least 3 parameters have been assessed in that home sleep study, because sometimes it's not done as well as it should be, and you may actually underdiagnose your patient. But yes, home sleep studies are more convenient, more cost effective, though it may not be absolutely accurate also. Now coming to treatment, we all know this, so again I won't go into this. Positional therapy sometimes does help in a very, very significant way. As far as treatment is concerned, you could think in terms of the CPAP, you think in terms of the APAP, or you think in terms of the BiPAP. Individual decisions, individual tolerance, you would take individual calls as to what best suits your patient. These are some of the oral appliances in patients who do not want to use the CPAP, which would help the patient. The other things where surgical interventions can be done in where there's very, very severe OS and there is a mechanical factor contributing. Again, the patient may not tolerate the CPAP. As I said, very important to follow up and monitor your patient also. So if I summarize in the last, sorry if you can give me 1 more minute. If I summarize, definitely interrelated conditions. You need to look beyond OSA. You need to think in terms of the patient as a whole. A little more holistic approach when you look at your patient out there is what is the key forward. apparent condition which we really did not look at so seriously is something which we are looking at much more seriously, because it has ramifications beyond the lung. It has ramifications beyond the lung and the brain. And what we are realizing is that it affects practically every component of the metabolic syndrome. The component of metabolic syndrome best studied is obesity and hypertension. Very clear-cut data that it helps. Data also which shows that it prevents the progression of normotensive patient to a patient of hypertensive also if the patient has OSA. So that's the kind of clear-cut data we have as far as hypertension is concerned. Diabetes, we have a little gray data, not very, very clear. There are some studies which show that yes, it does help as far as dysglycemia is concerned. Some studies are not very clear on that. Dyslipidemia, again, not very clear studies, but weight loss, again, very clear studies. So it does help as far as weight loss is concerned. And so if these two parameters also, if I look at it paradoxically, if weight loss is helped, automatically diabetes and dyslipidemia is going to be helped. So maybe not the direct relation, but definitely an indirect correlate can be managed out there. The good part is we now are able to evaluate. So very, very good. You and me can do sleep studies much more easily, available at a phone call. We are able to interpret these reports. We are looking at indices. We are trying to understand what best suits our patients. Machines have become much more cost effective. So patients can, to understand tolerance, we also ask the patient sometimes to hire the machine initially before they actually buy the machine. And I think it is at the bottom line, it's very, very important that we do have an integrated approach so that we are actually able to make a difference to the patient. Thank you very much for the patient listening. And you've been a fantastic audience. Thanks.
Thank you, madam. See, it was very nice to talk on OSA. OSA is a very serious disease that it causes diabetes, hypertension, and sexual dysfunctions. But here I have seen many patients are getting cured when they are seen properly, because they have something obstruction in the upper respiratory tract, which can be cured when kissing tonsils, even palate. And these people they don't help by giving CPAP because they have basic obstruction. So we have seen many patients which are getting cured with the help of this local examination, and of course the CPAP is a gold standard for all the things. Thank you, madam, for your kind presentation, which was very nice to observe. Thank you.
Shaila, there's one question.
I totally agree.
The role of an ENT surgeon who can do not only a diagnostic endoscopy but also a drug-induced, it's called DISE, drug-induced sleep endoscopy, to see whether the obstruction is single level or multi-level, and that can be cured fully by surgery and avoid dependence on the machine without treating the etiology. Of course, weight loss or obesity management is central to any success of the surgery.
I totally agree with you. In the clinical evaluation slide, I had all these parts, the clinical evaluation and the local examination and all that. But in the interest of time, I couldn't really go into, but I totally and completely agree with you. First obstruction, local evaluation, absolutely mandatory. And it's only after you rule out a local evaluation. But because I was talking in terms of the metabolic syndrome, to be honest, that's the reason I concentrated more on the metabolic part of things. 15 minutes ke andar, jitna I could. Weight loss, agreed. Weight loss is, lifestyle is the first bottom line. While lifestyle is the first thing. Smoking cessation, alcohol, lifestyle, exercise, all that is the first thing.
Thank you, Shaila. Thank you. Thank you for a wonderful talk. Moving on, I would like to now invite Dr. Venkatesh. I think both of us have started our journey in Department of Endocrine, KEM Hospital, and he's going to take us through the secondary causes of PCOS.
Thank you, respected chairpersons. At the outset, I would like to thank Manoj and Purvi and Team DRS for giving me opportunity to speak today here. I am going to talk on the secondary causes of polycystic ovaries, the secondary causes of PCOS, and making it to something exciting and interesting through some cases. I would like to mention that the first definition of PCOS, which was defined in 1990 by NICHD, Subsequently, the Rotterdam criteria came in 2003, and in 2006, the androgen excess society criteria came in. What was common that the anovulation, the oligo-ovulation or chronic anovulation with hyperandrogenism were common, but all three criteria mentioned exclusion of other etiologies of androgen excess and infertility is required in that. So what are the common causes which are usually said for secondary PCOS? First is adrenal hyperandrogenism. Either it is a classical adrenal hyperplasia, classic or non-classic, adrenal tumors, glucocorticoid resistance, ovarian tumors, other endocrinopathies like Cushing's, acromegaly, prolactinoma, syndromes of hyperinsulinemia. So I thank to Department of Endocrinology KEM, which we have collated the data, and I'm going to show you a couple of cases which will help you to diagnose your patients of PCOS. And what is the commonest pathophysiology when we talk about PCOS is it is the abnormal GnRH pulse frequency which is causing high LHS pituitary, which is causing ovarian theca cell hypertrophy, abnormal folliculogenesis, and at the same time increase androgens either from adrenal or from the ovary. So there is a role of insulin resistance, there is a role of obesity in pathophysiology of PCOS. So let's come to the first patient. She is 28-year-old female. She was symptomatic for 6 months. She presented with oligomenorrhea and primary infertility, weight gain, swelling all over the body, history of striae, hyperpigmentation, proximal muscle weakness. She was diagnosed with diabetes and hypertension 3 months before. She consulted gynecologist for infertility. She underwent IVF in August 2016, but it went to spontaneous abortion, and she was referred to us for Cushingoid features. We did her biochemical evaluations. Her basal cortisol was high. Overnight dexamethasone suppression was also showing high cortisol, and ACTH was on also higher side. So we did a MRI which showed pituitary adenoma. She was diagnosed as Cushing's disease with secondary PCOS. She underwent and managed by transpenoidal surgery, and after the surgery she completely cured and her PCOD disappeared, and she conceived over a period of time. So if you suspect any patient in your class, I understand that florid Cushing, you don't need differential diagnosis. You can definitely go with overnight dexamethasone suppression test, but ask the patient to get the older photographs if you suspect that. And you can see that longer the duration of hypercortisolemia, more obvious are the features which are classical, and that's why I always tell the patient to get the older photographs. So this is the second lady, 26-year-old female. She was symptomatic for 2 years. She had 20 kg weight gain in 2 years, presented with acne and progressive blackening of face and nails. Menses were regular. Overnight dexamethasone suppression test showed high cortisol. The ACTH was also elevated. We did a MRI. MRI showed pituitary adenoma. At the same time, ultrasound was done showing polycystic ovaries, and she was diagnosed as Cushing's disease with secondary PCOS. She was managed with transpenoidal surgery. So ladies and gentlemen, when we suspect someone with hypercortisolemia per se, we know that insulin resistance is the primary culprit here, but at the same time, high cortisol inhibits the gonadotropin releasing hormone pulsality and decreases the gonadotropin responsiveness to GnRH. Also, there is a high cortisol inhibits the ovarian estradiol and progesterone, and there is an excess of adrenal androgen secretion, which is causing hirsutism in this class of patients. So let's come to the next patient. She's 32-year-old female, 5 months. She had symptoms of amenorrhea. Ultrasound was showing polycystic ovaries, and she was referred to us. She had joint pains, excessive perspiration, galactorrhea. Gynecologist suspected acromegaly, and she was referred to us. Her post-glucose growth hormone was very high. It was not suppressed. IGF levels were very high. Prolactin levels were also high. But classically, MRI didn't show any adenoma. MRI showed hyperplasia. It was not adenoma. So we did all the pre-op workups, and in pre-op workups, it showed X-ray chest showing some mass lesion at that time. So we did a CT of X-ray, which showing mass in the right lobe. We did a bronchoscopic biopsy, which was showing bronchial carcinoid. We confirmed that with a DOTA scan, and which showed malignant carcinoid. So she was treated with right middle lobectomy and thymectomy. And you can see that after the surgery, the growth hormone normalized. So she was diagnosed case of growth hormone releasing hormone secreting carcinoid with acromegaly with pituitary hyperplasia. So sometimes we have to investigate such patients. If you see the suspicion of index in case of acromegaly is high, and a random IGF-1 is a good screening tool here. So what happens when there is a GH excess? The insulin resistance is very, very high. There are direct effects of high GH, excessive GH and IGF secretion on the ovaries and from insulin resistance secondary to GH excess. Hyperinsulinemia stimulates androgen production by theca cells, and there is a reduction of hepatic sex hormone binding globulin, which is causing peripheral bioavailability for androgens, causing hirsutism like a picture. So coming to the next patient, she is 32-year-old female, symptomatic for 6 years, comes with primary infertility. She had irregular menses. There were acid peptic disease type of symptoms. USG were suggestive of PCOS. We did prolactin, it was high. Story doesn't end here. We did a MRI, which was showing prolactinoma, but when we took a proper family history, the father and one of the uncle of the patient had non-secreting pituitary adenoma. One of them underwent surgery, other didn't undergo surgery. So we did her calcium. Calcium was also high. We did a PTH levels, which were high. Because of her symptoms of acid peptic disease, we did a gastrin levels, which were high. So she was diagnosed a case of multiple endocrine neoplasia syndrome, where prolactinoma, primary hyperparathyroidism, gastrinoma, and secondary PCOS. So this patient was managed with cabergoline for prolactin suppression, proton pump inhibitors, pantoprazole was started, and parathyroidectomy was done in view of hypercalcemia. So what is the role of hyperprolactinemia? In high prolactin causes low amplitude GnRH pulse, which impairs the LH responsiveness, GnRH responsiveness with at pituitary level. At the same time, high prolactin, there are prolactin receptors which have been noted now on adrenal gland, which is pouring more androgens from the ovaries, causing hirsutism. So coming to next patient, now we see that how patients are mismanaged at times without investigation. She is 16-year-old young girl, comes with headache for 3 months, amenorrhea for 2 months. She had already underwent right oophorectomy 3 years back for torsion of the ovaries. No thyroid tests were done in the past. She was again posted for oophorectomy of the left side now and endocrine fitness in view of high TSH. And we did ultrasound, which was showing polycystic ovaries. Pituitary gland, prolactin was high, pituitary gland shows hyperplasia, and she was diagnosed case of primary hypothyroidism, pituitary hyperplasia, and secondary PCOS. We told the patient, please do not undergo surgery, get managed only with thyroxine, and this is the patient's, her PCOD disappeared after thyroxine supplement. She did not require any surgery at all. So hypothyroidism do present with polycystic ovaries. That's what something which we have to keep it in mind. And the pathophysiology, in hypothyroidism, the hepatic SHBG levels are low. That's why the peripheral availability of androgen is very high. And there is a state of insulin resistance in hypothyroidism, which causes hypothyroidism per se causes hirsutism and PCOS type of a picture or morphology. Again, 16-year-old female, symptomatic for 2 years, excessive facial and body hairs, change in voice. She had clitoromegaly, so we did her, USG was suggestive of PCOS, and we did her 17-hydroxyprogesterone value, which consider normal cutoff of 2. Her cutoff was very high. She was treated with prednisolone and spironolactone. So how this late onset CAH presents with? Because there is an impaired cortisol production or steroidogenesis, there is a secondary ACTH drive which is causing more androgens coming from adrenal gland as well as from the ovaries. The next patient, she is 28-year-old female, born of 3rd-degree consanguinity marriage. She was symptomatic since 16 years of age. She was evaluated for giddiness, found to have hypertension. She was on amlodipine and minipress. She had achieved menarche at 14 years of age. She had hirsutism. After 5 years, she developed cramps and weakness in both the legs and found to have low potassium, and she was started on potassium supplement. So one physician investigated for low hypokalemia, and he did a plasma renin activity, which was found to be suppressed or very low. So she was referred to us for further evaluation. We did 17-hydroxyprogesterone, which was high, and we did a ODS cortisol, which was also high. So a patient who does not have Cushingoid feature with high 17 OHP and high ODS cortisol, we made a diagnosis of glucocorticoid resistance syndrome. She was treated with dexamethasone. Usually these patients require high dose, but the dose of antihypertensive gradually gets weaned off and they don't need potassium supplements because dexamethasone also has mineralocorticoid activity. Currently she is 5 months pregnant. So what is the role of glucocorticoid resistance syndrome? There is a decreased cortisol feedback to ACTH causing slight hypercortisolemia, and that resistance causes high androgen levels, which is the culprit for polycystic ovarian type of morphology. Coming back to this 40-year-old female who is symptomatic for 1 year, comes with amenorrhea, hirsutism and weight gain. She had mooning of face and proximal muscle weakness. Her ultrasound showed bilateral polycystic ovaries. She had hypoechoic mass in right adrenal fossa. ODS cortisol was not suppressed, ACTH was normal, DHEAs were normal. We did her CT scan, was showing adrenal tumor, and she was diagnosed as adrenocorticoid carcinoma with secondary PCOS, and she underwent right adrenalectomy and doing. Next is a classical picture what you and me see in our practice. She is 16-year-old female, symptomatic for 5 to 6 months. She comes with hirsutism, oligomenorrhea, and darkening of the black skin. She had severe acanthosis nigricans. When we did her investigations, she had impaired fasting glucose, HbA1c was very high in diabetic range, fasting insulin levels were very high. So we diagnosed her as type A insulin resistance. We did the investigation for her brother also, showing similar type of picture and acanthosis. So it looks to be familial. This girl was managed with metformin and OC pills. And what is the role? And she was diagnosed further with genetic testing, found to have insulin receptor mutation. So the states of severe insulin resistance may cause PCOS type of picture. That's what we need to take into consideration. Coming to my last slide, she's female, 22-year-old, symptomatic for 2 years, presented with infertility, excessive hair growth, change in voice and oligomenorrhea. She had hirsutism, mild clitoromegaly. Androstenedione levels were very high. 17 OHP was borderline or it was elevated. Testosterone levels were very high. We did her CT scan of pelvis, which was showing a right ovarian tumor. We did FDG PET CT, which confirmed the tumor. So she was diagnosed case of right-sided sertolite tumor, underwent right-sided salpingo-oophorectomy, and her symptoms disappeared and improved completely. So sometimes there is an autonomous androgen overproduction from the ovaries, and not all PCOS are benign. We need to take consideration at times they can be malignant tumors also. So when we talk of secondary PCOS, we know what investigations we do always, that we do on day 2 of menses, LH, FSS, testosterone, but sometimes AMH, DHAS, DST, SHBG and progesterone we do. Metabolic profiles like HbA1c, lipid profile, insulin levels we do. Diagnosis of exclusion is with always rule out thyroid and prolactin, and if we get any clinical suspicion, 17-hydroxyprogesterone, overnight dexamethasone suppression test or IGF depending on clinical picture is required. So ladies and gentlemen, there are questionable, plentiful of causes, overload syndrome and PCOS still remains diagnosis of exclusion. Thank you very much.
Thank you, Venkatesh. I think an excellent case-based discussion or presentation for secondary causes of PCOS, moving from a paradigm shift from reproductive issues to metabolic issues. So any questions from the...
Yes, sir.
Very interesting that you mentioned asking people to get their old photographs. What we now know is that there are facial recognition software that can actually do a negative predictive value for Cushing's and acromegaly. Of course, that's easier.
Yes.
But this has been around for the last 10 years. But now what we now know is that we can actually use facial recognition software with the current photograph, right? Take a picture of the patient, upload it into the site, and that will give you a negative predictive value for Cushing's at a very, very interesting rate. So I thought just to add this to your...
Thank you, sir.
Absolutely.
Dr. Sheshadri is a senior endocrinologist from Chennai. Thank you very much for your comments, sir. Any other questions?
Okay, I think then we'll conclude this particular session. Can we invite the speakers on the dais for the photograph?
Thank you.
Moving ahead with today's session on unlocking the power of GIP, I would like to invite our chairperson, Dr. Abhay Wag from Nanded and Dr. Dhananjay Mane from Bhid.
Good afternoon, all of you. May I request Dr. Krishna Shashadi sir, a senior endocrinologist from Chennai, to have a talk on increasing journey in type 2 diabetes from GIP and GLP to therapeutics. Over to you, sir.
Do you have a point? Okay. Thank you very much. Please note that I have conflicts of interest for this particular talk. This works? So we'll do this session in two parts. I have joining me on this Dr. Sujoy Ghosh, a senior endocrinologist and colleague and friend from Kolkata, who between the two of us, I think hopefully this session we can take this forward. But I think it's important to understand that what is the physiological aspect of this forgotten incretin, and let me take you through this, and then maybe in between, please stop me in between if you have any questions, but we will try to have a discussion at the end of it. Okay, so all of us understand the incretin story, right? When you give insulin, when you give glucose IV, it creates a less amount of glucose to be secreted than when you take food orally. Because when you think of food, when you start taking food, there is secretion of insulin. Now, when you give insulin, when you give glucose IV, insulin secretion is mediated by glucose itself. On the other hand, when you take food by mouth, there are a bunch of hormones that are secreted by the gut that drive the secretion of insulin. And we'll show this in a minute, that when this happens, there's a greater amount of insulin that is present, one. The amount of insulin that is present is proportionate to the amount of food that is taken. Third, it prevents insulin excess in the sense that is why we don't have hypoglycemia, because it just makes sure that there are checks and balances that allow the glucose to be metabolized by the right amount of insulin. That's why we found eating a better way than giving it IV. It's very simple. Now, for many years, we did not know this, and since the original discovery of this effect, we've understood that this is mediated by two peptides. One is, in the original days, it used to be called gastric inhibitory peptide. It's not so much. That's not, we're talking about glucose insulinotropic polypeptide. That was the first, actually it was the first one to be discovered. In the 70s, it secreted also more proximal to GLP in the K cells of the duodenum. And interestingly, it is stimulated by both lipids and glucose, which means a mixed meal stimulates it, right? On the other hand, the GLP-1 is a little more distal, right? It's there over a period of time. It's mainly by glucose. And that this difference is important. We can, over a period of time when things happen, we can talk about it. But the dual stimulation is actually very important. Also, the proximal stimulation is very important, right? So, glucose-dependent insulinotropic polypeptide is GIP, and glucagon-like peptide is GLP. What happens? And this was the effect. And remember that while McIntyre's article is the one that is quoted, this was actually described independently in two places. So, if you see in the bottom line of this graph, the bottom of this graph, I don't know if these work, but you see the bottom of this graph, you will find what happens to the insulin response when you give IV glucose. You'll realize that it's not much. So this is the amount of insulin that glucose itself is able to stimulate. But when given orally, the presence of these two hormones, which are the major ones, creates this rise and also a substantial fall in the insulin secretion. And this difference is the incretin effect. I'll quantify it in a moment, but this is important. Now, we also know that while the amounts of the hormones may be different, the effect of these hormones is reduced in diabetes. People keep talking about lower GLP-1s and others, but that's not true. That the amount of the hormones may remain the same, but their ability to stimulate insulin secretion is lower in diabetes. And that is really the absence of insulin effect in diabetes. Everyone's clear about this? Please stop me if you don't understand. I don't have to finish this talk. Right. Now let's understand this something more. Right? So I told you that these work to stimulate insulin. How do they work? They work through some receptors in the pancreas, in the beta cells of the pancreas, and they stimulate glucose production. Very simple. Now, how much is each important? And this tells you what it is. If you look at this, this looks very complex, but if you look at this thing, you will understand this. You see this? This is IV glucose. Correct? These are healthy individuals. This is IV glucose. This is GLP-1. And this is GIP. Just an infusion of these. And this is two of these. So what we now know is this. That GIP stimulates glucose production. GLP-1 stimulates glucose production. But the two of them, can you see the sum of the two of them is more than these two alone? Now, people have done other studies, and I'll just mention it, that if I were to say what is the percentage of glucose production by each? Glucose itself stimulates 40% of its own insulin production. Another 40% is by GIP. Another 22% is GLP. Some of the actions of GLP may be potentiating GIP, but we won't get into that today. So, this is just a cartoon that tells you how glucose comes in. All the other things that all of you are experts in it, but ultimately these two are important in this response. We must remember that this response is predominantly a postprandial response in normal individuals. Meaning when you eat, this controls it. Right? So let's look at this. This is the incretin effect in healthy individuals. Now, this is GLP-1. I talked about it, right? What happens? This is GIP. Now go back. I told you 40, 20, 40. Glucose is 40. 20 is GLP. 40 is GIP. Make sense? So why have we not used it? I think Sujoy will talk about it. And that's because we only learn what we are able to work on. So this is what happens. This is the same thing, and just using a mixed meal in healthy men. This is oral glucose tolerance in healthy men. Now this is, let me see it from here. So this is GIP plus an exendin. That is, an exendin is an antagonist, right? When the antagonist is present, exendin 939 is an antagonist. This is the amount of the area under the curve. On the other hand, when there's no antagonist, can you see 47% of this taken place? This is exendin alone, but this is a longer acting version, and it's also the same. And this is placebo. So when you knock it out, can you see the amount of reduction that is there? So GIP accounts for, I told you, if the incretin effect is 60, 40 is by glucose, right? By GIP. So endogenous GIP does generate a more significant effect on the insulin-mediated glucose compared with the endogenous GLP-1. I think by this time you've already realized that it's just a reinforcement of what we said. Now, what is important? Why is it that we haven't worked on this? And that's because we've understood so little about it. But we know a little more about GIP now because of various studies and also the development of specific antagonists and agonists to it. And again, so Joy will refer to it in this class. But here, let me talk to you about what we know. This tells you where is GIP expressed. And then that gives you an answer of where its actions are, right? Unless the receptor is expressed, you don't have an action. So where is it expressed? In the pancreas. We know that. Because it works through the beta cell, it works through the alpha cell, but mostly we know about the beta cell action. I think that we have understood. It stimulates glucose production. But it also works predominantly at the subcutaneous adipose tissue where it moves the fatty acids back to the subcutaneous adipose tissue. So there are some controversial issues here, but what we know is that the action of it is greater in the subcutaneous adipose tissue, and we don't know too much about it, but probably lesser action in the visceral adipose tissue. We'll park it there. If we look at it, there's not much action in the brain. But if you look at other places, the one other place where it works is bone. I won't talk about bone health, but what is interesting is that when you eat, normally during the day, one of the things that gets absorbed from the bone is collagen through the day, especially in the night. When you eat, GIP reduces this reabsorption of collagen. That means it sort of preserves the osteoclast function in the bone. But we don't know much about its action on bone health, but this is important to understand. So this is a cartoon that talks about the GIP, the GLP, and the glucagon release in response to oral glucose. Again, I've given you the nudge of it, the nuggets, and this is just expanding it to reinforce this into you, because most of us, after we leave this place, we'll forget GIP. So just to reinforce this. This is the alpha cell of the pancreas. GLP-1 decreases glucagon. GIP increases glucagon. Why? So those of you who remember the old DPP-4 inhibitor stories, remember at the lowest level, it increases glucagon to preserve normoglycemia. At the highest level, it brings it down. People may remember Bo Aaron's beautiful work on this. Now, this is the same thing in a graph, that this is GIP stimulated and GLP is inherited. This is all we know. We don't know too much about its action on glucagon. It's probably much, much more complex than just this. Right? In the adipose side, it does something very interesting. One, it increases the insulin sensitivity at the adipose tissue. That's good. Second, by doing that, it improves adipose tissue function. We know a lot about its action in the subcutaneous tissue, adipose tissue. We really don't know too much about what it is doing at the visceral adipose tissue. It will be interesting to know, but we know about this now, right? Now, what is interesting is, remember I talked to you about it, that it's not just the glucose, but also the fatty acids that are involved in GIP stimulation. The second thing it does is, it improves the adipose tissue blood flow. Again, concentrate on the subcutaneous adipose tissue. How does it do? Then, when the blood flow increases, obviously the function increases. Second, this is the next step that happens. First, so, okay, it's working on the adipose tissue. Is it going to increase my fat? This is where the answer is. First is, there's an increase in the fat utilization. I won't get into each of these graphs. Just to give you the gist, and then you can stop me and talk, ask questions. The second is it reduces free fatty acids. That's good. Third, decreases blood glucose. And fourth, it increases free fatty acid re-esterification. So what you're really seeing is a consolidation of subcutaneous adipose tissue and its metabolism. So contrary to what people thought about many years, that it may actually be, what we now know is it actually stabilizes fat. So to summarize, what do we have? First, there's an enhanced insulin release in response to oral glucose. This is the incretin effect. That the majority of the incretin effect is mediated by GIP. This is mediated by so irrespective of what you do to increase prokinetics or something, that's not going to work. It's right to the brain. Second, the subcutaneous adipose tissue, you really don't know much about GLP-1 action. You know about GIP action, that it increases insulin sensitivity, increased lipid buffering capacity, increased storage capacity, which means that remember, you want a preferential subcutaneous adipose tissue storage versus a visceral adipose tissue. You don't want your fat to be going here, you want it to be going here. Third, in the pancreas, it increases insulin, it may increase glucagon at certain levels. And the opposite for glucagon is GLP-1 and increase insulin. While you talk about this, I also want you to understand that these are like Rama and Lakshmana in many ways. They act together. There are strengths of each of these that are balanced by, that the two of them are better than one. In the stomach, it reduces gastric emptying. Remember, I'm sorry, it reduces gastric emptying. So that's opposite to a GLP-1, right? But not very significant. We'll talk about it. So I'm going to stop here. I'm going to take any questions on this quickly. But I think this talk will be even more useful when Sujoy brings up the next segment. And we can always also take questions in the end. Anything that's bothersome question, I'll take it right away. Everyone's clear? Or everyone's asleep? Thank you. Sujoy, come.
Thank you, sir, for your informative session. Next, Dr. Sujoy Ghosh, sir, from Kolkata. Over to you, sir.
I think more than half of my talk is done, which is good in a way. Because there's going to be a lot of overlap, which in a way is good because like Dr. Sheshadri mentioned, that this is something which is relatively concept-wise new. We have been using incretin-based therapies, starting with DPP-4 inhibitors and then the GLP-1 receptor agonists. Now, thereafter, we are now going to have drugs which will act not only on GLP, but also on GIP. So we as clinicians need to know how is it different? How does it work differently? And what ways is it addressing something which is pathophysiologically different? Rather than saying, this is again another injectable, maybe incretin-based therapy that it is coming. And to also understand that some of the other GLP-1s, say weight-losing agents, which will come, say once weekly kind of medication that is there in the pipeline, how is this class of drugs different from them? And one of the things, for example, that Dr. Krishna was talking about is the side effect profile. You go on increasing the GLP-1, you'll probably have some of the GI side effects which will be more at the level of the stomach and beyond. This will be something different. So you've got to know, and you will also understand that all of the guidelines don't club them together. Say, for example, when you talk about in the guidelines, you have GLP based, you have SGLT2s. The newer guidelines will have GLP based, GLP plus GIP based. So we need to know about that as well. So I'll skip some of the slides, that's the disclosures, and start from where Dr. Krishna left. And he quite rightly mentioned, because this is one slide that you've seen for donkey's years now, with Michael Knox talk about what is basically an incretin effect, that when you take glucose orally, the excursion of insulin is far greater than when you inject it intravenously. And he also mentioned about these incretins. You know, we've been talking about incretins since 2008, I think, 2008-9, somewhere around there. But look at when the incretins were first discovered. 1964, you had studies to show the same thing which Dr. Krishna talked about. And the discovery of GLP-1 was in the 1980s, and we are all talking about it, and I'll show you later that the GIP was discovered even before the GLP-1s were discovered. In terms of the GLP-1s, he has quite clearly shown this in his slides as well, that it works at the brain to decrease food intake, increases insulin secretion, decreases glucagon secretion, and delays gastric emptying. And if you look at the GIP, discovered in the 70s, and he showed this slide as well, that if you're looking at insulin excursion following an infusion of either glucose or GLP-1 or GIP, the responses are a bit different. And he also did mention this. And one of the things that you can look here is, and try and remember, I don't know whether the pointer will work or not. It doesn't, okay, doesn't matter. So if you look at there, up there from the K cells in the duodenum, you have GIP. The glucose gets absorbed from different places in the gut, and from the jejunum you have the GLP-1. And he also mentioned something that is about, you can think of that about 33%, that is 1/3 of the insulin that is released in the system, occurs as a result of direct stimulation by the glucose, whereas about 22% of that is with the GLP-1, but twice of that is what is regulated by the GIP. And therefore, not surprisingly, you will have within the next few years a flurry of drugs, not only the GLP-1 based, but the GIP based, the glucagon based, the triple agonists, the dual agonists, and all of that is actually trying to add on to the potency of the current glucose lowering that you already have with the GLP-1s. We are already impressed with the GLP-1s, whether the oral ones or the injectable ones, but here we can appreciate that over and above what a GLP-1 can do, a GIP-based drug will be able to give us even greater benefits in terms of glucose lowering as well as weight. This slide I think Dr. Krishna showed as well, trying to tell us where the major places of action are. We've already realized that the pancreas is one major place. He showed details of that, and the adipose tissue. And in the pancreas, he showed a close-up view of that particular slide, which essentially tells us that it works through the cyclic AMP pathway and increases insulin secretion. In terms of the adipose tissue, we are more interested, because if you want a drug which is actually lowering your body weight, how will a drug lower body weight? Either it will reduce your energy intake, or it will increase your energy expenditure, or both. So in terms of the reduction in energy intake, he already showed you that it works at the level of the brain. Now in terms of the energy expenditure, you would want actually either the fat metabolism to increase. You want to burn out the fat. That we are not very sure happens with the GIP-based therapies. But what he showed was that the uptake into the adipocyte is increased and the lipoprotein lipase activity is increased. Now imagine your body has excess fat coming through your diet or otherwise. If this happens, that is, there is greater lipoprotein lipase and greater entry of fat in the adipocytes or the adipose cells, then the fat will preferentially go there. On the other hand, if that doesn't happen, you have what is we call a spillover effect. The first organ to be hit with that spillover effect is your liver. So every time you put on weight, if you do an ultrasound or a fibroscan thereafter, you see there is fatty liver. If you start losing weight, that is where the spillover starts going off from. So the concept that Dr. Krishna was trying to tell you was, where does the fat go? Maybe you're not burning off that extra fat through this particular mechanism, but you are sending it somewhere where it will be preferentially metabolized rather than be someone like a space occupying lesion sitting in a place where it has no business to sit. So studies have been done to show that number one, it increases adipocyte tissue lipid uptake, but does not increase body weight because it goes there rather than anywhere else. If there is no change in energy intake and expenditure, there will be no change in body weight. And hypothetically, the GIP's role may be to store fat in adipose tissue where we want it, limiting spillover of fat to ectopic sites. And again, just to try and put the two molecules together, because some of the drugs that will come in future will act not only through the GLP pathway but also to the GIP pathway. You can see some of them are complementary and some of them are antagonistic. For example, the glucagon. One increases, the other decreases. And this is again a slide I think which he talked about. So coming to one of the molecules which actually acts through both the GIP and the GLP pathway, tirzepatide is one such molecule. It is an amino acid sequence which includes a C20 fatty diacide moiety that enables it to bind to albumin, and therefore it stays in the system for a long time because of this albumin binding, and therefore the mean half-life is somewhere close to about 5 days, which actually helps us to use the drug once a week, and the plasma concentration is unaltered whatever your kidney function and your liver function is. So hepatic impairment, renal impairment, you don't have to think of dose adjustment for this drug. The receptor, now I told you this molecule binds both to the GLP-1 receptor as well as the GIP receptor. This actually works and binds to the GIP receptor with the same kind of potency as native GIP, whereas the binding to the GLP is slightly weaker. This is again a knockout model study looking at two mice, separate kinds of mice. One is a GIP receptor knockout and the other is a GLP-1 receptor knockout mice. And in the mice model study, they've done an intraperitoneal glucose tolerance test. And you can see that through this, in the different knockout mice models, the effects are different, telling us that this molecule acts through both the pathways. Had it not had any effect in one of the two models, it would mean that it works either through a GIP or through a GLP. Through this, you can demonstrate that it works through both the receptors. And in 2022, in the FDA and the EMA approved tirzepatide and has been cited in multiple consensus and guideline document. And like I was telling you, it is included in a separate category. It's not an incretin GLP-1 category. It's a separate GLP-GIP category. At present, tirzepatide is the first and only approved single molecule GIP-GLP receptor. And it's a separate category, and this is something that which technically I think the glucose lowering bit has been approved by the government of India as well. We want the weight bit to be also included in that recommendation, and more importantly, we want pharma to actually bring the molecule to our country at a reasonable price so that our patients can actually benefit from it. So when we are talking about glycemic control, we all talk about the first thing is the HbA1c. Now, how does that glucose come down? You would want to know what it does to beta cell function, what does it do to beta cell insulin sensitivity, and what happens to the glucagon concentration. So this is a series of studies called the SURPASS study. SURPASS 1 to SURPASS 5 have been published. One is in comparison to placebo. 2, as you can see, is in comparison to semaglutide 1 milligram once weekly. 3 is with degludec with or without metformin and SGLT2. And 4 is with insulin glargine. And 5 is add-on to insulin glargine plus minus metformin. And in this, what is incredible is, if you look at the 3 doses of tirzepatide once weekly that are commercially available elsewhere, not yet in India, is 5 milligram, 10 milligram, and 15 milligram. Even the 5 milligram, if you look at, it's almost close to 2% HbA1c reduction compared to the comparator. Because, for example, here the comparator group, the A1C has gone up by 0.04, added to 1.87, it's at least 1.8, 1.9. And if you look at the 15 milligram dose, the A1C reduction is greater than 2%, which is phenomenal results in terms of glucose lowering. Now, this particular study, which was published in the Lancet, it shows something very interesting. This is basically this is a clamp study which has been conducted, in which they have tried to look at glucose disposition index. Now, we all talk about HOMA, right? I don't know how many of you have done even frequently IVGTTs. In my institute, we don't have clamps, but we do frequently sampled IVGTT. One of our papers are actually coming on. There's something called a disposition index, which actually combines both the secretory capacity of the beta cells, that means beta cell function, as well as insulin sensitivity. That's the primary objective of this study. And the secondary objectives were to look at the change in clamp disposition, glucose control, insulin secretion rate and insulin sensitivity, and the fasting and the postprandial glucagon levels. So what you can see, this drug clearly demonstrates that there is improvement in not only the first phase of insulin secretion, but also the second phase of insulin secretion. You know, in diabetes, the first thing that goes wrong is an abnormality of the first phase of insulin secretion, with a prolonged second phase of insulin secretion as a compensatory mechanism in type 2 diabetes. You can see here that the first phase of insulin secretion is improved by this particular molecule, along with improved second phase of insulin secretion. And again, if you're doing a hyperinsulinemic euglycemic clamp, which usually looks at the sensitivity of the individual, you can see that there is significant improvement in the insulin sensitivity as well as the amount of insulin that is secreted. If you look at the glucagon and the area under the curve, like I said, unlike the GLP-1, the glucagon level here is not going to be different, because the GLP-1 is going to suppress it more. Here it is slightly different. In terms of the weight loss, first let us look at the quantitative aspect and then look at what happens to food intake and what happens to the quality of weight loss. So again, I go back to the series of the SURPASS trial. Here again, if you look at the percentage weight loss, because you know most of the Western world studies, they have people starting with a body weight of 110 or something like that. Then you think there is a 10 kg weight loss, it means great. So if I look at not just the amount but the percentage, it's anywhere between 8% weight loss to somewhere around 12 to 12.5% weight loss, depending on what dose of tirzepatide you are using, which is significant weight loss. And when people are allowed to take food as per their wishes, you know, you are allowing them to take food when they are on the drug, you can see over a period of time that there is reduction in food intake, which correlates with the appetite suppression at the level of the brain. And it is sustained even beyond 16 weeks when these individuals are continuing on the medication. What about the weight loss? We talked about the weight loss is predominantly fat mass, because you don't want the patient to lose lean mass and become thinner. So it's predominantly fat mass which is lost and not fat-free mass. Fat-free mass is lost also, but that is relatively less. And the change from baseline in body weight over time, because you might say, okay, this drug, like an SGLT2 inhibitor, you will see whatever weight loss happens, usually happens within the first 3 months. Then it plateaus off. Here, that phenomenon has not happened, and the weight loss continues. Then we talked about that this group of drug, if it allows us to do so much of benefits metabolically, including weight loss, what happens to the liver fat? Because you would expect that is the first organ that is going to lose weight. So here, if you look at absolute change in the liver fat content, is dramatic and is sustained over a period of time. And if you are comparing the abdominal adipose tissue as compared to the degludec, probably not right to compare insulin with this, because you know it's no brainer that this molecule is going to do far better than insulin in terms of the abdominal obesity, because one of the things that what insulin does is gives you great glucose control, but at the possible cost of increasing body weight, particularly abdominal obesity. What about safety and tolerability? Because that's a major issue for any molecule that we use. So if you look at, not surprisingly, like all incretin based therapy, because इसमें तो GLP-1 का action भी है, you will find that the GI side effects are the predominant side effects in terms of the GI side effects. Hypoglycemia has happened in only a small group of people. So from the summary, if I have to say that GIP, as Dr. Sheshadri has mentioned, plays a very important physiological role as an incretin and has got very important role at the level of the adipose tissue. Tirzepatide is one of the pioneering molecules which acts on both these targets, that is GLP-1 and GIP. And in participants with type 2 diabetes in the tirzepatide studies that I showed, there was an improvement in beta cell function in the clamp studies to a greater extent than a selective GLP-1. There is improved insulin sensitivity in a clamp to a greater extent than a selective GLP-1. There is reduced glucagon concentration in a mixed meal tolerance to a greater extent than a selective GLP-1. There is reduced food intake even after the patient was allowed to eat ad libitum, and demonstrated a tolerability profile consistent with the known pharmacology. I think I shall stop there and take any questions together if you have any.
So thank you so much, Sujoy. I think especially the way you took off was absolutely brilliant. I like the way you summarized a very, very, very complex topic. Let's wait for questions, but in the meantime, let me ask you, and we can have a discussion. So we're talking about GIP, but the traditional wisdom is that GIP is inactive in type 2 diabetes. What do you think is happening when with all of this?
Right. The traditional understanding probably was a misunderstanding. And we have to understand, when you're talking about glucose, GLP, GIP, and glucagon receptor, they are probably not the same in health, in type 2 diabetes, and in obesity. There might be differences in all three of them. In fact, I spoke to Indranil about this, that we should probably bring out a very simplified article so that people understand what goes wrong where.
Okay, I'm going to plug something. So if Sujoy is going to help me with it, the RSSDI has another journal, the IJCMD, so we will write.
Right, okay.
Yes.
Right. So we had very little understanding of the molecule, in spite of the fact that the molecule was discovered even before GLP-1. And we had some understanding about where it works. But I think, ultimately everything is industry driven. A few years ago, were you talking about heart failure that much? Now you're talking about so much about heart failure because you've got a molecule. So the moment you have a molecule related to GIP, people will dig up the old papers, find new papers, do newer studies, and then tell you this is something you didn't know. So that's what you and I have been trying to do today.
Okay. So can I just add to, so one of the interesting things is that we know that in diabetes, what happens is that the GIP receptors are non-sensitive, right? And just to add to what Sujoy said, one of the things that seems to be happening when you give these drugs is that sensitivity of those receptors seem to be restored, which means that normally what would have happened is that when you give GIP, the beta cell is not responding to GIP in diabetes. But when you give these drugs, it looks like that sensitivity is restored. And that's very interesting. And why is it that one of the reasons is we didn't have a drug. Another of the reasons is because when new drugs are developed, we actually get carried away into that till someone else comes and tells you, you know what, there's another part to it. The last bit is, people talk about, one of the things that people have been talking about, are we just dealing with a super GLP-1, or do you think that this story is actually something that is correct, that there is a role of GIP, and in this molecule that these two are actually working together?
I think there is a role for it, and people will be talking more about this particular pathway the moment retatrutide comes. When you have a triple drug, then
No, so we are off. We are off triple drugs today. So let's stay there.
So they will then talk about glucagon. We are not talking about glucagon and its role in diabetes right now, right? Because sometimes we were taught that glucagon is bad. You have hyperglucagonemia. That's why you have ketoacidosis. Therefore, you suppress the glucagon. So there is both sides of glucagon as well. So that's the reason I'm saying that we have had poor piecemeal understanding of the entire system.
Right.
Even now we are probably adding one bit to that jigsaw puzzle, but it's a much bigger puzzle.
Any other questions? Yes. Yes, please, please.
I think the spectrum of our diseases have also changed. We are seeing much more heart failure than just acute MI in clinical practice.
Possible.
And I think cardiologists have taken more to this molecule than many of us, I think. Because even in acute MI, when they are sending patients home, they have been sending on this. Like SGLT2s are most used by cardiologists for heart failure. We are seeing a lot of UTIs in them. But I think, is there any specific role in the heart, is my question.
Okay, so first is, let's take this piecemeal. One is, yes, disease presentations and spectrum change. Why? For example, probably the single most important reason why acute myocardial infarction is down and we are seeing an increase in heart failure is simply because of statin use. Last 20, 30 years, our statin use has been much, much higher. Beautiful NEJM article that shows that the reduction in the MI incidence can be directly correlated with the adoption of statin use. Second, what Sujoy said is absolutely right. A lot of times we ignore problems for which we can't have solutions. Till the SGLT2 inhibitors came in, we couldn't mainstream early heart failure.
I think the other classic example is MASLD. You know, until a few years ago, we were not even talking about it. It was only about the ultrasound showing fatty liver. Now people have started talking about it because now industry knows also that there's going to be something there which will change things, whether it's the resmetirom or whether it's going to be the newer drugs. I am not allowed to talk about off-label indications and data of tirzepatide, but there's good news. That's all that I can say.
So the other thing is that if things didn't change over time, our lives will be very boring.
No, agreed. I mean to say that, yes, metabolic syndrome includes MASLD. Now we're seeing a lot of renal involvement, everything. So disease spectrums are changing, and possibly all the newer drugs that come in will have a different role, and it's good to have so many molecules as well.
But also, I think from a science perspective, and I'll just address that bit, our ability to query the human body, to query cells, to be able to look at it and understand it, this is one bit. The availability of technology to be able to create, design, look at this. We only see, the prescription that lands on our place. But the years it has taken for us, for example, here the journey started in 63, right? It's taken 70 years for us to, or 60 years plus, for us to get here. And I keep telling up the next 10 years are the era of the GLP-1s and the coagonists and the triagonists. But can you imagine what is happening here is you're able to take the power of two drugs, two hormones, pack it into a single molecule for it to be able to address two different kind of receptors, provide the desired kind of effect, right? And I don't want to get into it, but there are interesting stuff that's happening is whether it is looking at one pathway or another pathway and getting it right. And other than, let's say, vomiting or nausea, not causing any other major side effects is actually a triumph of modern medicine. Sometimes we don't sit and think about it. The truth is that we are probably in a glorious era to take care of diabetes and metabolic disease, simply because there's a convergence of science, technology, and remember, 20 years ago, in India, we would only say, our patients can't afford it, our patients can't afford it. Our economy has grown. We are no longer a destitute nation. We are proud Indians who I heard that there's such a grey market for many of these drugs in Mumbai. As usual,
Yes,
of
it
course.
is.
As usual. But the important thing is that we have grown.
Does the nausea disappear?
Yes, over a period of time.
3 months?
See, that's one of the reasons for me to say it's a central thing. Those receptors get desensitized a little and things get better. And that's why one of the things that in all of these, each person is a little different. The second, for each person, you really want to be titrating it up. That when the drug comes in, I'm sure they're going to keep talking about it again and again. But this is just an introduction to the concept. Any other questions?
Everybody is hungry for lunch.
Yes, so am I.
Thank you so much, sir.
Again, thanks, Sujoy.
Thank you.
It was a wonderful talk, and I thanks Dr. Krishna Sheshadri sir and Dr. Sujay Ghosh sir. We'll have one photograph, sir.
One minute, sir. Additionally, we'll be presenting a memento as a token of appreciation for your valuable insight. Dr. Krishna. Sir, 1 minute. Dr. Abhewag. Dr. Sujay Ghosh. And Dr. Dhan.
and Dr. Sheetal ma'am to Gangwani ma'am to chair the session.
Good afternoon, everyone. Welcome you all. So, this session is interpretation of the tests. So, I welcome our first speaker, Dr. Amit Saraf sir. He's an excellent speaker, and he's going to talk about ABPM. Over to you, sir.
Thank you, chairpersons, for that kind and crisp introduction. I don't see my slides here. So while he's putting up the slide, I think the session is good because we have for an hour interpretation of various things which Manoj and Purvi have really put together in a very nice manner. 15 minutes of different aspects, including ABPM, to be put together. वो दरवाजा बंद कर लेना यार हम तो आ गए अंदर so yeah, so I can see my presentation now. Good. Right. At the outset, I wish when I sit in the audience, I have always a question which has bothered me, that कितना slide रहेगा speaker का, and I always felt it should be made a compulsion कि एक एज अ कॉपीराइट बोल दिया करो इतना स्लाइड्स यार, ये तो 70 स्लाइड लेके 15 मिनट पीपल ट्राई टू कवर होता नहीं है, एंड देन वी आर वेटिंग इन दी फिर व्हाट्सएप चालू हो जाता है, मैसेजेस, फोन, टॉयलेट ब्रेक, कॉफ़ी ब्रेक. आई हैव 14 स्लाइड्स. ये फर्स्ट स्लाइड है, लास्ट स्लाइड हैज़ टू बी अ थैंक यू स्लाइड, सो मेरा 12 स्लाइड्स है. Okay, so if you give me 7 to 8 minutes of your undivided attention, I promise you at the end of it, what is ambulatory blood pressure monitoring, what is the importance to it in the present day scenario, will be crystal clear, and then we take questions at the end if they are. So with that in mind, I think the first, as a courtesy, as a responsibility, it's extremely difficult to do conference in present era. I extend my heartiest congratulations to Manoj, Purvi and the entire DRS team. I think a big round of applause to them, and they have done a stupendous job, and all the very best and congratulations to them. Second, as I do almost in all my talks, first start with conclusion. If you have understood this, my job is done right at this slide, I can walk away. So 3 minutes mein main ho gaya. So to conclude, right at the beginning, we have to understand that ambulatory blood pressure monitoring offers a much more accurate blood pressure measurement than what you and me end up doing just as a standard blood pressure check in our clinics. It's crucial for the management of complex cases of hypertension. Its emerging technologies will enhance the application. We'll see all of these in the coming slides. And a call to action is we have to embrace this technology. We are embracing smartphone there. ये तो इतना smart technology नहीं है, लेकिन effective technology है. So we have to embrace these things for the betterment of our patient treatment. These are the take-home messages I crafted. Introduction. Firstly, what's ambulatory blood pressure all about? So you take a cuff, a normal blood pressure cuff, put it onto the arm of the patient with the tubings onto the cubital fossa. The cuff is sitting snugly there. How do you know a cuff is not too loose or not too tight? One finger test, one finger from the bottom edge, one finger from the top edge, one finger going in, easily right fit, two fingers going in, loose fit, one finger not going in, tight fit. So put the cuff carefully, ask the patient to spend a normal day. Sunday के दिन मत करो, घर पे बैठा रहेगा पूरा दिन. या vacation बात करने बोलना है, routine is going to change altogether. So routine average day, counsel your patient. That choose a day which is a routine average day. I tell my patients to choose a Wednesday. Typically in our country, Wednesday, Thursdays are lighter days of the week. Monday is terrible. Friday, सब लोग को weekend का याद आ जाता है. So Wednesday, Thursday, if they put an ambulatory for 24 hours, it just is going to measure the blood pressure record of that individual for those 24 hours. And the importance is that blood pressure fluctuations are carefully recorded. Number two, over the last, say, 5 or 7 years, circadian rhythm has come up a big way in the management of our patients. We all have one. Individually, each and every one of us, like a digital print, has a circadian rhythm which is unique to us. And that determines so many factors unique to us. I may have my blood pressure surges and falls uniquely in my case scenario and similarly in all of our case scenarios. And if you can identify that in a patient's case scenario, at least for blood pressure, you can target the treatment more individually. सवेरे गोली खाओ, शाम को गोली खाओ, एज ओल्ड हो गया यार. What about 4 बजे दोपहर को गोली खाओ ब्लड प्रेशर का? हो सकता है ना. If that guy is surging typically at evening 6:37, you have to target a tablet to him which is a little post lunch, so you can counter that surge. So that's individualization. That is where ambulatory comes in play. And overall, we shall see the importance of it, the indications, the procedure, how it is conducted, the interpretation of the results, clinical implications, challenges and limitations as well, future trends. So with that, the importance I've in a way covered, but it's in a hospital setup, when they meet a clinician, unfortunately the blood pressure rises at that point in time. So typical hospital acquired rise in blood pressure, similar to hospital acquired infections in a way, if I can use that colorally, it is white collar hypertension. Mass hypertension exactly uska ulta. In front of you and me normal आता है, घर पे जाके बढ़ता है. So that's mass hypertension. In many a times you're measuring it is all normal, and sometimes in his routine office, at his home, at a non-measurable area, it's coming high, which is a mass hypertension. That is picked up. And a comprehensive blood pressure profile, which I just told. The circadian rhythm of your patient is picked up by doing a simple ambulatory test. Hypertension. Your typical anxious patients who are scared to come to you. Your typical, that dashing patients who are into office work, 21st century, typical leaving home early, coming home late at night. Blood pressure could be a reason because of his lifestyle. So usually in such cases you do it. Mass hypertension again, if you want to pick it up at resistant hypertension. If you're doing everything, calcium or diuretic, then what do you do? So choose this to find out the circadian rhythm. Maybe your timings of treatment efficacy also, right? So you started therapy. He's coming to you for follow-up. On every follow-up, the blood pressure is normal. But how do you know whether it's normal back home or back at his office? So efficacy of treatment, resistant hypertension, masked and white collar. Classical indications for ambulatory blood pressure monitoring. How do you do it? I told the procedure in simple words, take in a right-handed individual and vice versa. Choose a routine day like Wednesday or a Thursday. Usually 8 o'clock in the morning, good time to start before he goes to work. Ask him to wear it during every single thing. I had patients, I'm sure all of you must have heard stories ki raat ko nikal diya, lunch ko nikal diya, washroom mein nikal diya. Every natural, normal activity of it 24 hours. And so, well, let him wear it for 24 hours. That's how it's done, typically for 24 hours. Recordings, as you're aware, 15-minute clock to 30-minute clock measurements during daytime, 30-minute to 60-minute clock at night time. So that's how it measures during the waking hours. So 8 a.m. to 8 p.m. is usual calibration on that small pager-like device which is hung onto your waist. That has a calibration of 15 to 30-minute cycle for daytime measurements, 8 a.m. to 8 p.m. 8 p.m. to 8 a.m. usually half an hour to 60 minutes, 1 hour is the print, but if you want to correlate with the patient, you can keep a diary. They should maintain the usual routine. Avoid excessive physical exertion or stress. That counts. You have a 60-year-old gentleman or a lady, they are so-called acceptable higher blood pressure or a normal blood pressure would be different than a 21-year-old young chap. So first calibrate with whom are you checking and then compare it to the readings achieved in the result. Second, we are all aware of these concepts of dippers. So typically in that early morning hours of 2 a.m. to around 4:30 a.m., we should be having a physiological fall in everything. Blood pressure, cortisol, pulse, thyroid levels, sugar levels. Everything should go down. It's like your brain essential for human physiology and harmony. The malleolo interior, as we used to read in our physiology days, is maintained by this typical nocturnal dip. If that is lost, that's a sign of a resistant hypertension. That's how you pick up an ambulatory. Now today he is 30 years of age, his BP is quite end up in resistant hypertension in the years to come. So that's how we pick it up. So that can be seen on an ambulatory. Patterns, same dipping, non-dipping can be picked up, can be regularized, treatment can be given more physiologically. So these are how you see the interpretation of results. Implications, as I said, you tailor your antihypertensive dose of ek goli savare, ek goli sham ko. So risk. So it's not only about controlling the blood pressure, it's like diabetes. Today, all of us, when we treat sugars, we aren't only controlling sugars, but controlling the vascular system. So it's all of that which identifies patient falling in that high risk. Long-term benefits of ambulatory guided management include the aid of events by ensuring that blood pressure is well controlled throughout the day and night, and all ABPM guided modalities of management improve the overall cardiovascular risk and benefits. Clinical implications are these, as we just saw. Challenges and limitations. Discomfort and compliance, most common. Many of my patients come back and tell me, वो दुखता है यार, जो बार-बार इतना जोर-जोर से. Some patients come and tell me, उसी से BP बढ़ रहा है मेरा. It's like constantly squeezing my arm every half an hour, and I'm getting concerned. So you counsel them right at the beginning. When you ask them to put on the cuff, you tell them it's like a cloth. How many of us right now are even aware we're wearing clothes? None. The skin becomes insensitive to the touch because the receptors are attuned to it. Similarly, when you first time wear a cuff, for the first 2 hours, 1.5, 2 hours, 2.5 hours at the most, it will feel a little different. Ask him to just immerse himself or herself in his routine, and that's how you get used to it. Don't pay attention in simple words to the cuff all the time. If it's too discomforting, then obviously ask him to come back. Maybe some kind of the length of the cuff, the pressure is going wrong, and that has to be readjusted. So that's the biggest non-compliance. Cost and accessibility. Cost, okay, not too much a concern, is quite economical presently, but accessibility, yes, in tier 2, tier 3 challenges, which we shall see in the next slide, but then interpretation, how do you interpret? Now, that's actually easy. We'll come to that. Future trends, wearable technology advancements. We all are wearing smart watches. I'm sure that technology is going to get better and better. AI integration, more individualized sort of wearable devices will give rise to much better results of blood pressure, sugar, pulse, and help us in treatment of our patients. That integrated with digital health platforms. So most of us have in our clinics a lot of healthcare platforms, EMRs we are using. If that is integrated with the patient's sort of digital personal device, it can give us as clinicians better outcomes, and we can treat our patients a little better, and potential for remote patient monitoring. So that's a huge advantage. You have somebody, you're sitting in Bombay city, and somebody from tier 2 or tier 3 city wants to be monitored for you for his or her blood pressure control. This can be achieved electronically by an ambulatory. He sends you the records, and that can be also done. These are the advantages. Now, the trend table, the interpretation, believe me, if you have seen an ambulatory report, is 3-4 pages stapled together, and we are all PCB students. We have not done PCM. वो आगे का हिस्टोग्राम, बार चार्ट, पाए, वो जो उसका नाम है नहीं समझता है आपको, स्कैटर ग्राफ छोड़ देने का. For us, what is relevant is the first table which they give, that B's guy, then you take the results accordingly, 20-year-old results accordingly, with a pencil and mark out amongst those 40-50 readings the machine has taken, which are relevant, which are not relevant, turn the table around, show it to him that amongst 40, 30 बार बड़ा है, there's a problem, point 1. 30 में से 25 number of readings are higher than expected, there's a bigger problem. And point number 3, amongst the troughs and the peaks, these are your peaks, these are your troughs, so I can tailor make a treatment like this. Simple. So rely only on the trend table, which is in the first half of the first part of the couple of those sheets of papers. Rest is the table interpreted in a graphical manner. So all other pages are your correlation charts, histogram, are just the same table given in that format. So if those who can understand it can interpret it, but basically the trend table is what is to be seen. Back to my conclusion. So I told you, 14 slides. ABPM offers a more accurate blood pressure assessment. It provides a comprehensive and accurate assessment of patients' blood pressure, capturing variations that are often missed by clinic measurements, and this leads to better diagnosis and more tailored treatment plans. Crucial for management of complex hypertensive cases, such as white collar and mast and resistant hypertension, provides a more detailed data needing more informed treatment decisions and improved patient's outcome. Emerging technologies will enhance the application, which will make it even more integral to the hypertensive management. Wearable devices, digital integration, and remote monitoring will expand its use and accessibility, making it easier to manage blood pressure effectively. Call to action is embrace the ABPM for better patient outcomes. I encourage you all to consider in incorporating ABPM into a practice. By doing so, you can provide your patient with the most accurate and effective hypertension management, ultimately including for a better health outcome. With that, I end my talk. Thank you so much for a patient hearing.
Thank you so much, sir. So, one question. So, once we do ABPM and then we tailor-made the treatment, adjust antihypertensive, do we need to repeat ABPM after a certain time?
Wonderful. Then that's a brilliant question, and somewhere in the indication, if you see that indication number 3 or 4 was efficacy. So if you start ABPM today, do a ABPM today, and accordingly start therapy. Usually I do it after 6 months to 1 year. Let the patient, because a lifestyle modification by the book takes at least 6 months, 3 to 6 months to sort of show a result. So repeated ABPMs, rather than giving us the same results at the end of 6 months to 1 year, I do it to see the trend if it's better than the previous graph. If not, then we can step in and give more enhanced therapy.
And so a few patients who are normotensive when we check, but then they present with microalbuminuria. So for that we add antihypertensives. So in such patient, do we need to do ABPM before adding antihypertensives?
Okay.
As a prevention of microalbuminuria or treatment of microalbuminuria?
Not a single statement answer to that question. That's the entire, it opens up a Pandora's box, because microalbuminuria you have to look up for so many reasons. But coming to the hypertensive aspect of it, ABPM is one modality. Do an ECG, LV strain का देखो, axis देखो, echo करके देखो, thickness of the LV देखो, auscultate करो, S1 loud क्या देखो, family history देखो, phenotype देखो. There are so many things. Put it all into perspective. You got a hypertensive. So ABPM is just one modality in your armamentarium. You have all of these also. It's like a checkbox. Sort of 10 things. If you have 8 of them, is hypertensive.
Any questions from the audience?
So how much we can rely on the accuracy, because we see that some of the staff they check on a digital BPR outside they check it on the outside, the staff is checking, and when the patient comes inside, there is a major discrepancy between the digital and the manual reading which we are taking. So regarding the ABPM, have you ever cross-checked how far we can rely on the accuracy?
So you're absolutely right. A lot of discrepancies do happen given the fact that patients tend to sort of remove the cuff, wear it differently than what it's initially set up. So as I answered the chairperson's question also, it's a supportive diagnostic tool. Take it along with the other supportive evidences. It's like solving a crime. You don't look at one sort of evidence. You look at so many evidences, circumstantial as they call it, and then you put it into perspective. So this, along with the other aspects, will give a better diagnosis.
Sometimes doing 3 days together is valid sometimes.
करके देखो सर, बहुत difficult है. I've done mine. मुझे भी वैसे मजा के लिए क्या अंदर से और 24 घंटा लगा के देखो, और it is difficult सर, नहीं होता है. What you're saying is theoretically absolutely true, because it's mathematics. The more averages you get, the more the better interpretation. But it's difficult after a while, to keep it on for a certain time. Your night sleep is also disturbed at time. It's not that comfortable, but it's useful to do it, because it gives you a trend that diurnal variation is to be picked up. Go ahead. Rent it out, never to be bought. But it varies. 2000 is where in Jupiter we'd give it at. Other places may be cheaper also. Hi, sir.
Amit, 2 by 2 by 7, the concept popularized by Eris, 2 times before breakfast and before dinner for 7 consecutive days. So this 28 readings over a week probably could represent. It doesn't capture nocturnal dip and morning surge, but otherwise, which had also an application.
Yeah, sir, I knew sir would bring out a brilliant point. So this is very similar to the CGMS compared to the self-monitoring of blood sugar. Similarly, your ABPM compared to self-monitoring, a lot of patients feel, and it's getting a patient involved in his or her own care. So if you, as sir said, if you put up a trend where वो खुद ही देख रहा है दिन में 2-3 बार, he's getting involved, maintaining a diary, आपको लाके दिखा रहा है. That's so he's right. अगर ये नहीं करना है, that is also equally validated.
So Dr. Amit, we have come across few instruments that are recently coming up. It doesn't disturb too much of your night sleep. It takes 2 readings around 2 a.m., then 1 at 4, then 1 at 6, like that. A little modified version of the ABPM which we are having, which can preserve your sleep to a certain extent.
Yeah. So the point is, right, sir, these devices should be, I mean, they are upcoming. Yeah. But it's like right now the Apple Watch, which takes a ECG, only lead 2. So none of us are very happy with that. If they come up with a better 12 lead, so I don't know, kabhi hoga, nahi hoga. But then as they become more advanced in their technology, hopefully it will help, it will serve us better. ऐसा सब नहीं होता है सर. Not it is in the real world. इसमें से कुछ भी नहीं होता है. He is walking up to your cabin. तो वो चल रहा है बेचारा. Entered hospital. The spirit smell outside. The Dettol detergent. I mean, antiseptic smell outside. Other sick people outside. So point is, sir, what you are describing is a ideal and a theoretical case scenario. We live in a real world. It is not possible. But as I said, it's one of the armamentariums. Use it like a tool. You can't rely. It's like you can't rely on a single piece of evidence. So only on ABPM can you rely on start-mom therapy? No, it's a good value addition. It's a feather in the cap, so to speak. अरे सर चाय कॉफी भी बोलता हूँ.
Thank you, sir, for the excellent
Pleasure.
presentation.
Thanks so much.
Thank you so much.
I would now like to invite Dr. Surjadeep Sen Gupta for the next talk.
Can you make this full screen out here? Full screen? No, it's just coming. Can you just make it a little? Good afternoon, everyone, and thank you so much, Dr. Manoj Purvi and DRS team for inviting me to do this presentation. I have no financial disclosures for this slide. Disclaimer is that I have not used this machine personally, and I'll be talking about the body composition analysis. So, hope you understand, right? So, we would be talking about body composition analysis and how is it important, what are the technologies which are there, and this is something which is state of the art and the latest which is there, which is taking into consideration how it helps, and let's see how things stand. And the primary thing, the brief given to me by Manoj was to go in for a bit of a result sheet interpretation of what we are actually doing in terms of testing. So what exactly is body composition? So it's an individual's nutritional status which is defined as the condition of the body resulting from the balance of intake, absorption, body composition assessments which are used to routinely detect or diagnose several important nutritional problems among adults and youth, including overweight status, obesity, undernutrition, osteoporosis, sarcopenia, and sarcopenic obesity. Now this includes the components which make up the body weight, such as body water, proteins, minerals, and fat. You can generally assess it in 5 ways. Either you can do the whole body thing, which doesn't exactly give you kind of a split up. You could do it in the atomic pattern, which again doesn't level, looking at the fat, extracellular fluid, cell mass, etc. And the functional status, looking at it from the organ point of view, or what this entails, the chemical 4C model in which you're going to document the amount of minerals, proteins, fat, and water, which can guide you further towards treatment. Now, what is the need for body composition assessment? The quantification of fat, muscle, bone, and water are highly informative in the diagnosis, management, and treatment of several nutrition-related problems that impact individual and population health. Now, clinicians, dietitians, and other practitioners can develop a protocol to achieve certain health-related outcomes. And weight loss, it can guide you towards how to dictate or guide the patient towards weight loss in overweight or obese patients or patients who are at risk for type 2 diabetes. Significant increases in lean tissue mass or bone mineral density in patients with sarcopenia or osteoporosis. All these techniques and practices will allow nutrition specialists to perform these duties more effectively. Now, what are the methods of body composition analysis? The bioelectrical impedance analysis is the one that we're going to discuss today. And suffice it to say that it is much cheaper, much convenient, gives the result very fast, and gives you a good result looking at the basic features that you are supposed to be looking at. So what is this in-body body composition analyzer? This machine uses the bioimpedance analysis where a small low-level electrical current flows through to calculate the human body composition. So thicker and denser the tissue, more is the resistance, more fluid the tissue like water, lesser the resistance. The sum of the resistance and the reactance measured within an individual provides the impedance values. Now, this uses 6 multi-frequencies, which is given through 5 designated points, which calculates the body composition, and they're given simultaneously to these different parts: the right arm, left arm, trunk, the right limb, the right leg, and the left leg. First 1 kilohertz, then 5 kilohertz, then 50, stepping it up to 1000 ultimately. Now, let's see what the results are like. This, in a nutshell, is what the result sheet comes through, which gives us an overview of the fat, muscle, and water content of the body. So this is the body composition analysis. This is the muscle fat analysis. This is the obesity analysis. This is the segmental analysis. On to the extracellular water ratio and phase angle. Phase angle is a metric which is I'll just be discussing shortly, and the additional parameters which can be followed up. So what exactly is this? So quickly, the body composition analysis is basically a sum total of what you are seeing. So it entails a total body water analysis, which is the muscle fat analysis that we see. This is the basic pattern that we see across the patients in which this has been done. So on the left-hand panel, you can see the basic, the first is the weight. There is the skeletal. You can see that the weight is in the normal category, but the skeletal muscle mass is less. The body fat mass is more, which is cautionary. Second is the ideal, in which all the three are additionally in one single straight line, normal, but it has subcategories which can again be showing a slightly disturbed ratio. I'll just be taking it up in the next slide. The last is the developed category, in which the muscle is more than the fat. So the cautionary is where the muscle is less than the fat. You're looking at sarcopenia or skinny obese body. The middle one is the balanced muscle and fat, a normal and healthy individual ostensibly. On the right is muscle more than fat. You're looking at muscular athletic people. So let's see the subgroups. On the cautionary C shape also, you can have a standard weight and a weak individual, in which if you see that the pattern is falling from normal to under. So such people are individuals who should follow proper exercise and diet regimes, and see very commonly in the category which we see. And these are more, normal weight but obese because of excessive body fat mass. The third category is the overweight and weak category. So let's come to the I shape which can have. It can again be categorized in the underweight and weak. And these individuals should also follow proper exercise and diet regime, mostly seen in the low socioeconomic strata. This middle one is the standard weight and healthy, which the ideal category for all, which is to be, tried and achieved. And the last is the overweight and obese categories. In these people also need proper diet and exercise counseling. The last is the D shape, in which the muscle mass is more than the fat mass. So one can have the underweight and strong people. Classically, if you see the marathon runners, long distance runners, skinnier of sorts, but good muscle mass that they have. Second is the standard weight and the strong type, the middle distance runner types, etc., who have good standard weight. And also the slightly more in this category are the sprint ones. If you see the 100 and 200 meter dash people, they are all built up, whereas the marathoners are all kind of, thinned out guys. And the last are the overweight and strong types, the bodybuilders and, the weightlifters, etc. Coming on to the next parameter, which is obesity analysis. The percent body fat is calculated by the machine, and the normal range for males is between 10 to 20%, and for women it is between 18 to 28%. So this would give you a rough idea and a guide what to advise the particular patient. Coming on to the next category, which is the segmental analysis. So through the in-body advanced BIA technology, it is very easy to understand the exact amount of lean muscle and fat in each segment of the body. For example, if you see the left-hand panel, here the individual has 2.01 kgs of muscle in the right arm, which is almost more than 100% of the required muscles. Likewise, the segmental fat analysis can also be seen and done and be guided. As you can see, most of them are in the extra fat category. Another index or a metric which is studied is for the sarcopenia assessment, which is a skeletal muscle index. So the cutoff is for males below 7 is not normal, and below 5.7 in females is not normal. So a particular metric called the appendicular skeletal mass is calculated by the amount of muscle. As you can see, right arm, right leg, and left leg, and then divided by the height by meter square to give you a particular figure. So in this particular example, there is presence of muscle wasting as seen in diabetes and sarcopenic individuals, which can be assessed through the skeletal muscle index. So this gives you a bird's eye view for this. Next, we come to the extracellular water ratio analysis and the phase angle. So the normal range for the ECW is between 0.36 and 0.39. And the extracellular water, if it is more than that, indicates inflammation or water retention in the body. And obviously, you're looking at cases where you can have edema. So this is what it is. And through the body composition analyzer, it is easy to understand where exactly there may be the presence of water retention. Another metric which is calculated, and this all comes up algorithmically by the machine, is known as the phase angle, which actually denotes the cell health of the cell membrane elasticity and integrity, and shows that the diffusion of all the nutrients and water is going in and out well. So if it is more than 4, it is normal. So in this particular index case, it is 4.3%. So at one glance, if it is more than 4, you can say that the person is by and large healthy. And it better reflects the nutritional status than weight and muscle put together if you are just leafing through. So if you have this particular metric which is more than 4, you know that generally the guy is in a good status. And what are the additional parameters? Like if you are tracing on the body composition history out here, the left-hand side, you have a positive case in which if it has been measured across the spectrum, serial analysis have been done. Out here, the weight has decreased 2 kgs. He has maintained about 37.6 kilograms of muscle, but has decreased the percent body fat by almost 2.1%. And vis-a-vis a negative case on the right-hand side, where the weight is almost the same, as you can see on the left side, which is 37.6. But you'll be able to see a slight decrease in the muscle content. At the same time, the percent body fat has gone up. So this is unhealthy. So over a period of time, if you have done sequential analysis, you'd get to know how the person is faring. And though the whole body composition report, we understand the target weight of the individual, how much fat has to be lost and how much muscle need to be gained. The optimal score is 80 points as decided by the machine. If it is less, then means obviously the patient has to catch up. But a muscular person can also have, because of extra muscle mass, can have points more than 100. So out here in this index case, what it showed was that the fat control had to be, decreased by almost 9 kgs, and muscle control, that had to be positive by almost 2.5 kgs in this particular case. So this is how it guides you and gives you a picture as to how you should be proceeding. Mimics the protein mass also, because protein is mostly water, and it by and large gives you an indication that if the water mass is good, the protein mass also should be good. So it also looks at the visceral fat area, which indicates the amount of visceral fat in the body, which is very important in clinical practice and parlance nowadays. It has a cutoff of 100 centimeters squares, and if the level rises above this, it can be a future indicator for future cardiovascular disease and metabolic problems. ICW and ECW levels should always be within the normal range, because that shows optimum body metabolism. The basal metabolic rate can be tracked to understand if the body's metabolism is improving or not. The waist-hip ratio has a normal range of 0.75 to 0.85 for females and 0.8 to 0.9 for males. But these are things, if you are calculating via this kind of an analysis, this is giving you a much better, idea and the direct parametric analysis of what of the patient actually has. And the body's, intracellular water and protein levels also shows the basic health status. Suffice it to say, it's a very, easily done analysis, can be done under 60 seconds, doesn't cost more than 500 rupees. So if you have access to that, and if you do want to pursue the the clinical status of the patient, should be, a good, apparatus to utilize in your labs, and also can be used for research purposes. And this is made by a Korean company only. And now India, we have people from the InBody team out here who are marketing it well. And though Maharashtra, we don't get so much backup in Delhi, but Maharashtra, I believe they have started doing very well. So I suppose you all can start having a look at this machine, and this definitely is something for the future, which is here to stay.
Thank you, sir, for this informative session. Any questions?
This report, which is generated all by the machine.
All by the machine, sir.
Physician will have to do the job of
So it's
explaining
yeah,
what this means to.
Pritha, do you have it on display out here? So it's basically a standing kind of a machine in which you clasp it with both hands, both rods, and you stand on it, and then it keeps on doing the measurement. So that's how it is taken.
Any Indian norms, it is a Korean machine.
We're talking about the
Indian phenotype.
Sir, we are just talking about the compositions right now. So, as per, you can just tweak it as per this, but they don't have a standardization for that.
Simple question, how much does it cost to have a machine installed?
So they have variants. I think it starts off from a cost of around 5 lakhs or something. No, 2.5 lakhs. That's the absolute high-end machine, which has multiple other parameters for research purposes. And the one precaution which is there, let me mention, in patients who are on pacemakers, it cannot be done because there's this electrical activity which is there. But metallic stents, etc., for any angioplasty patient, it can be done because the current going through the stent is almost infinitesimal, so it doesn't really impede anything. Metal implants, again, there's not a problem, but the thing is that it recognizes, metal has easier conduction. Likewise, for amputated patients, it has easier because the machine recognizes that more as water because it is not getting any resistance. So it interprets that. So as a primary, it may not be able to give you a direct thing, but over a period of time, if you're sequentially monitoring it, then you can know where the percentage error is, and you can, likewise know how much better that the patient is doing, because the margin of error would be remaining the same in all the formats.
Sen Gupta, last question, is most important. People where you diagnose sarcopenia and a low muscle mass, how do we advise to gain?
Eat more high-protein diets, high-protein diet. That is the only thing, and exercise regularly, because as we age and once the muscle mass is lost, it is mostly replaced by fibrosis. So that is something which becomes kind of irreversible. So before that starts happening, if you have a fair idea, give protein mass and obviously start exercising to build up the bulk. Resistance exercise, yes, sir.
What is the correlation between different methods you showed in terms of
These are metrics which are picked up by the machine, what I showed that, and then you can see which one you want to follow.
No, I mean doing. So
okay,
what is the gold standard? Is it DEXA or? What is current gold standard? Is it DEXA?
The only thing is, obviously, when you're looking at it, it's a much more easily accessible and easy to do. So that's what it is.
In about 60 seconds,
60 seconds, the
you get
results
the
are
whole
over.
result out.
And obviously, if you have some semblance of a doubt, you can obviously correlate it with the scans which are there conventionally present.
Thank you, sir. Excellent talk. Just a quick question for physicians like us. How do you interpret the phased equation?
So that's just a simple metric. If it is more than 4, it shows that the patient is basically by and large normal. Yeah, is doing well.
So how about if they're like 2.5, 3? How do physicians...
Cautionary, less than that obviously means muscle mass is very less, etc. And you have to look at the metrics, the different metrics separately to see how best you can customize the therapy for the patient.
Thank you.
Earliest ideal time.
It is fasting, basically.
Basically fasting.
It is fasting, and then there are some precautionary methods that you need to take, like if you have taken a shower, if you have just had a physical activity, then of course, you know, the temperature of the body changes, and because we are having this thumb electrode and the heel that is placed on, so we need to make sure that, you know, the temperature of the body is also as equal to the room temperature, plus menstruation, pregnancy, all of this we'll have to take into consideration.
Like breast implants, etc., taken up as fat mass. Yeah. Pregnancy, the machine reads it as fat mass. So it's obviously not a good time to do that analysis. Why should you be doing it in them? Right.
And for the face angle also, as a physician, if the face angle goes down by, let's say, 2.5 or so, that person definitely is in critical care. So it's a great indicator. So we've seen in CKD patients, etc., that the face angle is either equal to or less than 2.5. So the chance of survival also.
So it has a different configuration for even doing it for bedridden patients and people on dialysis, etc. But the electrodes are different. It can be done in a supine position also for such people. So it is possible, and like if it is less than 2.5, obviously the patient's mass, etc., is very badly malnourished.
Like sir had also asked, what is the intervention? Then, you know, you end up giving amino acid IV and, you know, so on.
I mean, all kinds of supplements that you're looking at, whatever is feasible practically at that point in time.
Any more questions? Okay, thank you so much, sir, for that excellent talk and a very interactive discussion. Next, we have Dr. Sheetal Avarsekar. She practices at Diabetes Center. Many accolades and accomplishments to her name. We are happy to have her. Over to you, Dr. Sheetal.
Thank you, Chairpersons. So, the topic given to me today is interpretation of fibroscan. I think before the interpretation, what we need to know is why and when should we advise a fibroscan. So this is the NAFLD spectrum as we all know it. The normal liver passes through 4 stages before it ultimately becomes cirrhotic. First phase is the fatty liver, that is the hepatic steatosis, followed by NASH, which is the onset of inflammation. Repeat episodes of inflammation then cause the onset of fibrosis, and repeat fibrotic episodes ultimately cause cirrhosis, which can lead to hepatocellular carcinoma. What is more important to know is the first step and the second step. These are reversible steps. So if the person is picked up early in the phase in this spectrum, it is possible to reverse it to a normal liver. So picking up of the patient at this early step is essential to prevent future cirrhosis and complications. In type 2 diabetics, the progression of NAFLD to cirrhosis and the related mortality is higher. As we can see, if we compare the non-diabetic and the diabetic population with NAFLD, the progression through each step is more faster and more severe. So when it comes from NAFLD to NASH, there is a 40% progression. From NASH to cirrhosis, it's 20 to 25%. From cirrhosis to HCC, it is 5%, and the chances of mortality are also higher when it comes to type 2 diabetics with NAFLD. What are the stages of fibrosis? So fibrosis is graded as stage F4 to F0 to F4. F1 is the mild stage, F2 is the intermediate stage, F3 is the advanced stage, and F4 is the cirrhotic stage. Now, what is significant about F2 is that anything above F2 is considered to be a clinically significant fibrosis stage. This histopathologically is a stage where there is just the onset of bridging fibrosis. So at this stage, the onset of fibrosis starts, and that is when it starts becoming more irreversible. So what happens at stage of F2 and more? There is a greater risk for cirrhosis, HCC, all-cause mortality, extrahepatic cancer, progression from pre-diabetes to type 2 diabetes, and CVD. What is essential to know is that in a case of advanced liver disease, the most common cause of death is not the liver disease itself, it is the CVD. So, diagnosing at an early stage is essential to prevent future CVD risk also. Now, how to judge what grade of fibrosis the person lies in? Liver biopsy is the gold standard to detect the grade of fibrosis, but it is costly, it is invasive, it requires more expertise, and it is not easily available. Hence, what has been proposed is to identify at-risk patients with a non-invasive screening test, and these should be further followed up to a hepatologist at the right time for investigations and future management. So this was a recent paper published in IgM, which showed that type 2 diabetes was associated with a higher clinically significant liver fibrosis, especially in Indians. The most important point to know out of the study is that the elevated SGPT and the SGOT levels were present in only 27% and 37% of individuals with clinically significant liver fibrosis. So traditionally, we have had a habit of advising SGOT and PT levels and decide whether the person is having a liver disease based only on those levels. This needs to change because many of these patients may not have an increased levels at that stage. So because of this, the ADA has set out a few recommendations in collaboration with the American Gastroenterology Association. The latest recommendations in 2023 are all adults with type 2 diabetes or prediabetes, particularly those with obesity or cardiometabolic risk factors or established cardiovascular disease, should be screened or risk stratified for NAFLD with clinically significant fibrosis using what we call as a FIB-4 index, even if they have normal liver enzymes. So what is this FIB-4 score? It's a very simple score which can be done very simply in an OPD setup. It requires just 4 parameters, that is the age of the patient, the SGPT, SGOT values, and the platelets. Based on the formula that I've given, it gives out a score based on which we can judge what is the risk of the patient to have an advanced fibrosis, so more than F2. If it is less than 1.3, the probability of advanced fibrosis is less. Between 1.3 to 2.67, there is an intermediate risk for advanced fibrosis, and more than 2.67, the probability of the person going into advanced fibrosis is much higher. So the ADA has recommended this protocol. After the FIB-4 test, we divide the patient categories into 3 groups. The one which has a low risk, that is if it is less than 1.3, does not require any further investigations. A repeat FIB-4 test can be done every 2 to 3 years. But all those in an intermediate risk or a high risk category should be subjected to a second non-invasive test, that is the vibration controlled transient elastography. Now this vibration controlled transient elastography is what we routinely know as FibroScan. The FibroScan is what we call as a brand name, and the test name is vibration controlled transient elastography. One thing that we all should know is the nomenclature has recently been proposed to change. NAFLD was considered to be a stigmatizing stigmatizing name because of the word fatty, and it couldn't, the steatotic liver disease patients were not classified based on their alcohol intake, based on other risk factors for causing steatosis. A new nomenclature specifically for metabolic associated dysfunction has been proposed, which is MASLD, that is metabolic dysfunction associated steatotic liver disease. It includes anyone with a steatotic liver disease with at least 1 out of 5 cardiometabolic risk factors, which are those elevated triglycerides, low HDL, type 2 diabetes or pre-diabetes, obesity, and a high blood pressure, or on treatment for any of these. So the traditional NAFLD data can be extrapolated to the current MASLD data. Now we come to what is a fibroscan. The picture that I have shown on the upper right corner is a more commonly used portable fibroscan device which we use in our routine OPD clinics. There are other advanced devices which are available which are better left to the use by the specialists. Fibroscan is an imaging technique for fibrosis risk stratification. It predicts the future cirrhosis and all-cause mortality from MASLD. It is based on that test of vibration-controlled transient elastography. What it does, it specifically gives us two numbers. One is the liver stiffness measurement, and the other one is the CAP, which is a controlled attenuation parameter. The liver stiffness measurement, which is measured in kilopascals, it's a non-invasive quantification of liver fibrosis, and the CAP is a non-invasive quantification of liver steatosis, that is the fattiness. How is the test performed? The test is performed when the patient is fasting for at least 2 hours. The person lies in a dorsal or decubitus position with the right arm in maximal abduction as shown, and the probe, the fibroscan probe, is placed on the skin in the right mid-axillary region. Now the principle of this test is that the probe sends out low frequency and low amplitude vibrations through the liver tissue. These vibrations produce what we call as shear waves. And based on a principle of ultrasonography, the speed of these waves determines the stiffness of the tissue. So as shown below, the probe generates a shear wave. The ultrasound is used to measure the speed at which the shear wave travels through the tissue, and based on the speed and an inbuilt formula, it gives out a value of the stiffness. The stiffness value is directly correlated to the square of the velocity of the shear wave that travels. This is an enlarged picture of the 10 images that we usually see in a fibroscan report. So the fibroscan computes the elastogram which as a function of the depth and the time of the shear wave. So the black thing that is seen here is the wave that passes through the tissue. The velocity directly determines the stiffness of the tissue. So softer is the tissue, faster is the velocity of the shear wave progression. As we can see in the right side of the slide, it is a relatively normal liver. The velocity is around 1.1, which gives an LSM score of around 3. In the middle is a slightly compromised liver with a slightly faster velocity of transmission of the shear wave, which gives a LSM value of around 9 kilopascals. And in the extreme right is a totally cirrhosed liver, which is, because of its thickness, the shear wave passes at a very high speed, and the resultant LSM score is very high. So the higher the speed of the wave, higher is the stiffness value, lower the speed, and lower is the stiffness value. The normal range for this LSM score is between 2 to 7 kilopascals. The average normal for an individual is around 5.3. Now, how do we correlate the LSM score with the stage of fibrosis? It depends on what is the cause of the advanced liver disease. As we can see, the cutoffs are different for the different causes of advanced liver disease. So it will be different for hepatitis B, hepatitis C, or chronic cholestatic disease, alcohol-related liver disease, or NAFLD. What are the basic cutoffs when it comes to NAFLD in general? So when the LSM score is considered, when the LSM score is less than 7.9, it is considered to be in the F0 to F1 stage. Between 7.9 to 8.8 is considered to be F2. Between 8.8 to 11.7 is considered F3. And more than 11.7 is considered to be F4 stage of fibrosis. So what is the risk for advanced fibrosis that is more than F2, that is F3 and F4, based on these scores? This is a recommendation as per the ADA. If we find the LSM score less than 8 kilopascals, it is considered to be a low risk for advanced fibrosis. These patients should be followed up in our clinic itself with a repeat surveillance every 2 to 3 years. Anything between 8 to 12 is considered to be an intermediate risk for the development of advanced fibrosis in future, and these should be referred to a hepatologist. Anything more than 12 is considered to be a very high risk for advanced fibrosis, and they should definitely be referred to a hepatologist. So, what is the role of a diabetologist when we find a higher LSM score? First and foremost, there should be a more focus on lifestyle interventions and weight loss. Weight loss, even as low as 3% weight loss, has been shown to reverse the stage of hepatic steatosis. So weight loss should be emphasized more and more in these individuals. There should be a stricter glycemic control. Use of anti-hyperglycemic agents with a potential benefit in MASLD like pioglitazone or GLP-1 receptor agonists should be considered. Cardiovascular risk assessment should be done, and there should be a stricter management of dyslipidemia and hypertension. And select patients may be advised bariatric surgery if required. So basically, it's a team approach. The patient should be handled both by the diabetologist, who should take care of the metabolic parameters, but at the same time, early referral and timely referral to a hepatologist is what is essential to prevent, to take necessary steps to prevent the future complications. Now, there could be certain conditions where it could show a false high report and lead to overestimation of fibrosis. It should not be done in cases of active hepatitis. It should not be done in cases of cholestasis like biliary obstruction. In cases of mass lesions of the liver like liver tumors, it may give a false high values. When there is liver congestion like heart failure, or when there has been a recent food intake which is less than 60 minutes. The readings may also be unreliable when there is extreme obesity, older age, presence of ascites, narrow intercostal space, and hyperinflated lungs. So clinical judgment is also important while interpreting a fibroscan report. Next parameter that is shown by the fibroscan report is the CAP, which is the controlled attenuation parameter. Now, what is CAP? CAP is measured by sending the ultrasound waves within the liver and measuring their attenuation. What is this attenuation? Attenuation is the decrease in the amplitude of the ultrasound waves as they propagate through the liver. So, a normal liver without a fatty change will have a low attenuation and a low CAP value, whereas a fatty liver will have a high attenuation rate and a high CAP value. The CAP value ranges from 100 to 400 decibels. Less than 100 is considered to be no steatosis, and more than 400 is supposed to be a very high CAP value with a very high fatty liver change. So interpretation of CAP scores, if the CAP value is somewhere between 238 to 260, it is considered to be a steatosis grade 1, which means that less than 1/3 of the liver is affected by fatty change. If it is between 260 to 290, it is considered to be steatosis grade 2, which means that around 1/3 to 2/3 of the liver is affected by fatty change. Anything above 290 is considered to be S3, which means that more than 2/3 of the liver is affected by fatty change. It has a specificity of 91% and sensitivity of 87% for hepatic steatosis detection. Now, there are certain things which should be kept in mind before you interpret a fibroscan report. First and foremost, we should ensure that the fibroscan test was done in a fasting state. At least 2 hours of fasting is essential before undergoing this test. A non-fasting report can give a high LSM value. use the correct probe, which is very essential. There are 3 probes which are usually available: the S probe, the M probe, and the XL probe. Use of a wrong probe in a wrong type of body composition can lead to a wrong value, especially in an obese individual. XL probe should be used. If an M probe is used in this kind of individuals, it may give a false high value. So there is something called as skin to liver capsule distance. If it is less than 25, an M probe should be used. If it is more than 25, an XL probe should be used. Look at the number of images. Ensure that the report states that there are at least 10 images. This is very important. Is the interquartile upon median less than or equal to 30%? If it is more than 30%, it means that there is a lot of variation in the individual values given by those 10 images. It could be because of certain other parameters that are certain other echoes that are picked up by the ultrasound. So the aim should be that the IQR upon M should be around 20 to 25%. Next, ensure that the probe is in the right place. This can be judged by looking at the ultrasound field. So if the probe is not kept in the right place, again it can give rise to false high values. If there is a change in the ultrasound field, as is seen in the second and the third picture, the shift of the probe is essential, an intercostal space higher or lower, and to keep it in the right intercostal space to get an actual report. Check whether they are less than or equal to 2 rib echoes. Now, a rib echo, if it is present in the image, it may give rise to a false high LSM value. How to judge whether the wave is a normal wave or a rib echo? Look at the margins. Look at the margins of the wave. So, as you can see in the first picture, the margins are non-parallel. It means that the image is more of a rib echo and it should be discarded. Whereas if we see in the lower picture, the margins are parallel. It means that it is an actual shear wave passing through the liver tissue. So presence of this rib echo can give rise to a false report, and we can come to a false conclusion. Now let us look at sample fibroscan reports. As we can see in this picture, first we tick the checklist. We check if the right probe was used. We assume that the patient was fasting for at least 2 hours. There are 10 images given. Look at there don't seem to be any rib echoes present. The interquartile upon median is well within the 30% target. And now we look at the values. When we look at the values, we can see that the cap value is 305, which suggests that it is a stage 3 steatosis. But look at the LSM value, it is 3.8. So it means that it is just a case of the initial step in the spectrum of NAFLD, which is a fatty liver without any significant fibrosis. As suggested, the patient lies in a low-risk category for advanced fibrosis. He has to be managed at the physician level. The weight loss is essential, but a repeat surveillance should be done every 2 to 3 years. Moving ahead, this is a second patient. After confirming that there are no rib echoes, 10 images, and the interquartile upon median is less than 30, we now look at the values. The cap value, as we can see, has come down to 275, and the LSM score has increased to 10.8, which means this is a stage where the person is in between a hepatic steatosis and advanced fibrosis. So the LSM of 10.8 means that the person lies in a stage of F2 to F3 fibrosis, and a cap means that the patient is in a S2 steatosis stage. Since it is between 8 to 12, it is an intermediate risk, and the person should be referred to a hepatologist. This is the last slide. It shows an even lower CAP score of 247, which means that, and an LSM score of above 12, that is 13, which means that the patient has already entered a cirrhotic stage. And typically, as the patient enters a cirrhotic stage, the steatosis stage comes down and the fibrosis sets in. That's why the CAP comes down and the LSM score goes up. This is a person in a high-risk category and should be referred urgently to a hepatologist. So that's the end of my talk, and I thank you all for your patient listening.
Thank you so much, Dr. Sheetal, for that elaborate and excellent talk. Do we
Thank
have
you,
any
Chairperson.
questions?
You mentioned about HCPT and they are only 27 to 35%.
Yes.
Then in a routine life, routine patients, how do we suspect to undergo this test?
So, sir, as suggested, anyone who has so ADA has recommended that all type 2 diabetics should be screened from the FIP score first, which is a non-invasive test which can be done in the clinic itself. After the FIP score crosses a certain value, that is when we decide on the stage.
If the fibroscan uses ultrasound waves, what is the difference between ultrasound machine and fibroscan machine? Can we use ultrasound for
So
judging?
those technical, I don't know about the technical details, sir. I'm sorry about that.
We should refer to a hepatologist.
Yes.
What the hepatologist is going to do?
So,
Anything extra interventions are needed because it is ultimately a metabolic disease and the diabetologist or the physician can control that. And when reversing that, the process is going to reverse. Then why should we refer to a
So further investigations, as decided by the hepatologist, can be done to grade the cirrhotic stage also. And if there is any doubt, they can undergo a liver biopsy or other advanced tests only if required. So if the hepatologist feels that it is not a case of a pure MASLD, but there could be any additional factors to it, that investigation and the treatment could be done by the hepatologist.
Ma'am, I have a question. What are the limitations and considerations that we should take in pediatric population with liver disease? Are there any limitations or considerations?
Pediatric population, I think from this, I just know that the probe that should be used should be a small size probe. And the American Gastroenterology Association has given certain cutoffs for the obesity cutoffs when it comes to pediatric age as percentiles. So we should take that population into consideration and then subject them to this report with the use of a correct probe and then refer if required.
Thank you, ma'am. Any more questions? No. Okay.
Before we conclude, I would like to request all the speakers and the chairperson to come on the stage for a group photo. No, it's cancelled. I would like Dr. Firdaus and Dr. Manas to felicitate the award. There's a short break after this. We'll start at 4.
Hello everyone. Moving ahead today's session on obesity algorithms and implementation, I would like to introduce our esteemed chairperson, Dr. Shruti Gagwani and Dr. Bushra Pawani.
Thank you. Good evening, everybody. I'm Dr. Bushra Pawani. So we'll have our session for this evening. Thank you so much for joining us. Our first speaker is Dr. Neeta Deshpande. She's a diabetologist and a bariatric physician at Belgaum Diabetes Center. She's also the medical director and professor and head of department of the Dental College, Belgaum, and the associate professor of medicine in USM KLE International Medical Program. Ma'am, please join us on the stage, and we'll give you in charge of the stage now. Thank you.
Thank you, chairpersons. At the outset, I would like to thank Dr. Purvi and Dr. Manoj Chawla and the entire team for giving us this opportunity. So this is not going to be like a didactic lecture. We don't want it to be. We want it to be more interactive, like it's a workshop. But just to set the stage, I'm going to put up certain things, and then Dr. Brij Makkar will take it forward as a workshop to give you practical tips. And then, of course, we have case-based discussions with Dr. Rucha. So few of us, diabetologists, endocrinologists, cardiologists, and even gynecologists, we all came together and made a consensus guideline, which you can see over here, which was published in JAPI in October 2023. So we adapted and adopted a lot of things that are good in obesity algorithms from different places and put it together and tweaked it a little for the Indian scenario, what we can do in our clinical practice. So I'm going to take you through the steps of this algorithm in very, very brief, and after that we will go to the practical aspects of the same thing. So as I said, this was a consensus on the current landscape and treatment trends, and at the end of it, I'm going to give you an algorithm. So basically, it was very simple. These were the four steps, as you can see. The step one is, of course, the anthropometric evaluation. Because unless you examine the patient and evaluate, you can't define whether this person has obesity or not in the first place. It's like how you do a biochemical diagnosis first for diabetes. Here you do an anthropometric diagnosis for obesity first, and then you move on ahead. So that's the first step, and how we can possibly do it, that also we'll be telling you. And then the step two is the comorbidities, the clinical evaluation of the patient, what obesity itself has caused in that patient, that is obesity comorbidities as we call it, and associated conditions. Because unless you actually look for these comorbid conditions and consequences, you will not be able to treat obesity. The simplest example is if depression coexists. Can you treat obesity? Very difficult. So these are things or comorbidities or consequences. So this is the second step. And then the third step is once you have known the anthropometric measurements and once you have known the comorbid conditions, then you actually stratify. What do you want to stratify? You want to stratify the risk that this patient has, and then you can manage. So that's what the algorithm is all about. Evaluate anthropometry, evaluate comorbid conditions, risk stratify, and then try to manage. And the fourth step, which is not there in many algorithms, but which we know is the most important thing in obesity, and that is follow-up. So very briefly, if you look at the first step, it is to assess the anthropometry, which is assess the body mass index and waist circumference, which is the most important thing. I won't go into the details of what those values should be like. You will get that anywhere, because this is a practical workshop on how to go about like setting up an obesity system and clinic. So basically this is what you look for. So what you need is what Dr. Makkar is going to tell you later on. So basically BMI and waist circumference. Of course, what we haven't put here actually is measuring fat percentage. We're not measuring fat percentage here exactly, but it's a good thing to have. Bioelectric impedance machines are available nowadays. You don't have to do DEXA in every patient. And that is the other part of anthropometry and evaluation that you can go to. So these were the consensus statements, and the consensus was that the BMI-centric approach to the diagnosis and management of obesity has limitations. Then the combined use of BMI and waist circumference is recommended for better identification. Ethnic-based cutoff should be used. We know what the Asia-Pacific guidelines are for Indians and the Southeast Asia region. And complication-centric obesity management, I'm going to show you that very soon, can help individualize management, optimize patient outcomes, and improve the benefit to risk ratio and cost effectiveness of interventions. Next is the step 2. I'm just elaborating a little. As I said, evaluate the complications and consequences, endocrine evaluation tests, and socioeconomic status. Why this is important is there is no limit to the number of things you can add here. And based on your scenario, based on the place where you practice, each one of you must make your own protocols. These are guidelines. Use these guidelines and make the protocols for yourself. So that is what is important in creating an obesity clinic. So this was the consensus statement that these are some of the complications you should look for. We know that all the metabolic conditions that are there with associated with obesity, cardiovascular risk, mechanical complications like osteoarthritis, stress incontinence, and GERD, obstructive sleep apnea, immobility, cancer even. So all this should be part of your protocol. Evaluation and asking questions, just tick, tick, tick that. Is all of this there is what you should actually look for and put it into your protocol, that you're going to look for these things. You may not ask it, but your people, your front desk, your coordinators, whoever is there with you will keep this checklist and talk about this particular checklist. So that is what you need to do. Then comes the step 3. After you have evaluated everything, you've done the anthropometry, body mass index, waist circumference, perhaps the fat percentage with the bioelectrical impedance studies, you've done that. You have used your checklist, all right. Now you want to actually do a risk stratification. So the risk stratification is divided into 2 parts, BMI less than 23, BMI more than 23. If the BMI is more than 23, you should actually put this patient's data into the EOSS staging system. That is the Edmonton Obesity Staging System. So we have not made any new staging system because this system works very well. So we have adopted the EOSS into our algorithm. So if the BMI is more than 23, you apply the EOSS and you stage it. How do you stage it? You stage it based on medical, psychological, and functional issues. So actually, if you want to remember it very clearly, let's call it the 3M. What are the 3 M's? One is medical, or let's call it, it's not exactly medical, it's metabolic. Second, psychological, so call it mental. And functional is mobility or mechanical. Let's call it mechanical. So what will come under medical or metabolic? All your metabolic conditions like heart disease, diabetes, pre-diabetes, MASLD, NAFLD, whatever you want, all those names, everything comes under, even cancer comes under metabolic. Under mental will come depression, eating disorders, anxiety, etc. And lastly, under mechanical will come stress incontinence, obstructive sleep apnea, osteoarthritis of the knees, spine problems, GERD, all these are mechanical problems. So MMM, and then you stage them at how bad is it? From staging from stage 0, stage 4 is all end stage. This is how you stage it according to EOSS. More of that will be told to you by Dr. Rucha because she has got case-based. So she will actually take cases for you and stage them for you. And then if the BMI is less than 23 and waist circumference is less than 80 or 90, then you have to just go into preventive mode. One important thing that I would like to tell everyone is that in our algorithm, because it is India and ethnic cutoffs, if you look at it, it is BMI more than 23 and or waist circumference. It is not, it is or also, which means even if the BMI is less than 23, but if the waist circumference is more than 80 or 90, then also they come onto the right hand side. In no other algorithm, to my knowledge, will you find that if the BMI is less than 23 or 25, if the waist circumference is more than that, you classify them as obese. But in this algorithm, because of our Asian ethnicity, it is important for us to recognize the sole importance of waist circumference. This is the management as per the staging. So now you have staged, you've gone through step 1, step 2, step 3. Now you're coming to the management part as per the staging. So you can see that right across from stage 0 all the way to stage 4, you have lifestyle modification. You can't run away from lifestyle modification, it's always there. However, in stage 2 to 4, lifestyle modification alone may not be enough. And that is the reason you look at the other modalities. And so you consider pharmacotherapy from stage 2 onwards, but you also consider it in stage 1 if the BMI is more than 27 and lifestyle interventions are not effective. And for otherwise, the pharmacotherapy starts from stage 2 at BMI more than 25, you can actually give it. So these are all based on studies that have been done, and that is why they have been put into this. And then lastly, stage 3, stage 4, it is recommended for bariatric surgery. So this is how the staging is done, and this is how management is done as per the staging. So I'm not going to go into the details of how we came to a consensus, but a multidisciplinary team must be there. The core team must have a physician, dietitian, physiotherapist, psychologist, etc. There's no limit to this. Because if someone has sleep apnea, you will need a pulmonologist. If somebody has GERD, you will need a gastroenterologist. So that way, you will have to have on board in your consulting team based on the comorbidities of that person. So others are there on call. So this is how the consensus was reached, and the dietary targets that was set by Dr. Mishra, I think Dr. Makkar also was on this paper. We have used the same thing. Physical activity, we have talked about rigorous exercise, that is cardio, but we have also, if you look at the last panel, you will see that resistance training is a very, very important part. This was the consensus. The consensus for pharmacotherapy, I won't go into the details because the management part is going to be dealt with by Dr. Rucha. Consensus for bariatric surgery also will be taken. And the last step here is step 4. And the step 4 is please plan the follow-up very, very well, because that is the key to maintenance of it. Otherwise, you will your patients will go into a bad, vicious cycle of what we call weight cycling. Weight cycling is nothing but yo-yoing, regain and loss, regain and loss. And this actually causes more harm, more cardiovascular disease. There is data to show that. So weight cycling should not happen. And that is the reason that follow-up is an extremely important part. You may need to give rescue therapy to the patient. You may need to modify the treatment plan. So I don't know how clear it is because this is an LED screen, but the entire gist of my talk, you can actually see in this particular slide, where you have step 1 anthropometry, step 2 clinical evaluation, step 3 risk stratification and management, and and then step 4 is follow-up. So everything is there in one, but I refer you to October 2023 issue of JAPI, where you will find the entire article, including this table and everything in that. You will be able to see it. So this is, in short, how you can organize. Based on this algorithm, you can actually organize your obesity clinic, and based on this, Dr. Makkar is going to tell you what you need to get into your clinic, right? So this is the summary basically. BMI-centric approach is no more recommended. Complication-centric management is more important. That's why the staging is done. Pharmacotherapy is a vital cog in obesity care, and this proposed algorithm could help people in comprehensive assessment. I also refer you to one more paper that I was part of this year, where we gave an overview of therapeutic options of obesity management in India, which came out as I said, this year only in March, and this will give you a little more insights into the pharmacological aspects of it. So thank you very much, and I'm now going to invite Dr. Makkar to take off from where I left off, and I'm going to keep this slide in place for him to build up upon for the obesity clinic. Thank you. We can have a Q&A session at the end after all three of us finish, right?
Thank you, ma'am, for the informative lecture. I would now like to invite our next speaker, Dr. B.M. Makkar. He's the director of Dr. Makkar's Diabetes and Obesity Center, New Delhi, immediate past president, RSSDI, honorary secretary, RSSDI,
I think we can skip that.
Thank you, sir. Sir needs no introduction.
Still, I'm introduced every time. Thank you. Thank you for that. And thank you, Neeta, for setting up the context for what we are doing here. So, Neeta has very nicely elaborated on the whole concept of obesity management and also, took you through the current recommendations that we have. And the important thing is how to set up a obesity clinic. And these are actually, if you follow the algorithm, you know what to do and how to do it. Now, another important thing I am happy Neeta pointed out was that there is no end to it. There is no limit where you can, stop. So you have to customize your practice according to your needs. There are multiple things you have to decide. One, how passionate you are about, your obesity practice. What all you want to do in that obesity practice. Do you just want to do a clinical management of obesity, or you want to do some, clinical data generation, or you want to be involved in some research, clinical trials, and so on? So it depends what all you want to do, and accordingly you can set up your, system. So one thing you have to understand is that it is not an individual practice. You have to have a team. The team can range from 2 people to 20 people, depends on what you are looking for. And if you have a proper protocol or a, SOP in place, it's always better to, it is always easy to work, and it is always better in terms of, outcomes. Otherwise, it is very difficult to manage obesity as a single-hand person sitting in a clinic, and doing obesity practice in the middle of a routine practice is very difficult to do. So coming to the first thing, I think, use non-presentation mode, because I can then enlarge the slides, No, no. I don't want presentation mode. Okay? Give me a second. Let me. Don't do anything from there. Just leave it for me. Okay? So first part is the assessment of, anthropometric measurements. So basic requirement is you need to have a height, weight, and body mass index calculation. And another important thing is the measurement of waist circumference. First 2 components are very easy. You can easily measure height and weight and calculate BMI. But measuring waist circumference is always a challenge in clinical practice, especially when you are measuring waist for women. Now, so Another important area is people who are obese are actually very apprehensive when they are being measured in, a waiting area or open space. So you have to have a, privacy for them. You have to have an isolated area where you have all this equipment, and you have to have a dedicated person doing these measurements. For women, always make sure that there is a female attendant or a female person who is doing waist measurements. Also, measuring waist again is a challenge because you have to understand how it is measured properly. It has to be, there are two accepted modes usually for waist measurement. One is that you measure at the level of midway between the costal margin and the iliac crest in a horizontal plane, and you measure at the end of respiration. The second accepted line is the top of the iliac crest, which is the American recommendation, NHLVI. Again, you have to make sure that you are measuring at the top of in a horizontal plane, and flexible, non-stretchable tape is required. If your tape is stretchable, then your measurements are wrong. Now, another important thing is how do you standardize this? How do you make sure every time you are applying the same amount of stretch to measure? Because ultimately you will have to follow up these patients and see how much change is happening. So how do you do it? Anybody? Loud. So I am not making any presentation. Neeta has told me you have to play only one slide and that's it. And I am following the rule. So how do you do it? Anyone? AI? No, the same person is doing, again the stretch can be different. Same tape is there. But how do you ensure that you are applying the same stretch?
It's a non-stretchable tape.
No, but ultimately you are measuring. You are measuring. So the force applied, you can, pull it more or less. So how do you do it? So one is we measure, usually we use the spring tapes, so springs have the same power. That is commonly used. Otherwise, the best way to standardize is that you use a spring balance connected to one end of the tape. And every time you measure, you apply a pressure of 600 grams. So 600 grams. So connect the spring balance. At one end of tape, you have the spring balance. So when you are measuring, you are pulling the spring balance, not the tape. And you measure at 600 grams of stretch. So that is the most standardized way of measuring waist using a non-stretchable tape. Very important thing again. Hip
circumference also, which is the ideal place.
Pardon?
Hip circumference.
Hip circumference is the largest circumference around hip. Am I correct, ma'am? Approved. So, then is the important thing is which weighing scale you use. So most of the weighing scales that you are getting are giving you measurement about up to 150 kilos. But you will see patients coming with much more weight. So ideally you should use a sturdy weighing scale, which are used usually the industrial weighing scale with the big platform. And they are able to measure up to 200 kilos. But you can get the higher ones also if you are seeing patients more than that range. So 200 plus kilos weighing scales are also required at times. Second thing is, if you are seeing people who are having a lot of limitation of mobility, then there are weighing scales which have sloping edge of the platform, where you can wheel in the wheelchair on the platform and you can measure with the wheelchair, and then you make the patient sit out and measure the wheelchair weight, and you can decide the actual weight. So that is another important requirement that can be there. But most of the time, our patients walking to clinics are able to, climb on the weighing scale. So these are some of the important things that you need in the patient reception area, that you have to have a isolated privacy for the weighing weight measurements. You should have a proper standardized industrial level scale which gives you accurate weight also. The accuracy of the machines has to be in the range of 100 to 150 grams, because every time when you are measuring, these small measurement changes will happen. Second thing is it sufficient to measure weight in the clinic every time?
Ideally, it should be measured on an empty stomach early morning.
Okay, so how do you tell these patients to come every time, empty stomach, early morning, to get their weight done? So they have to monitor their weight at home. So it is not just empty stomach early morning. The best is to tell them to weigh once they have freshened up, taken bath, and once they come out of the bathroom, they have minimal clothing also. The clothing weight is also not a big variable. So that is the best time to weigh, and they should monitor weight on daily basis so you can get the trajectory on week to week basis. But you have to make sure that when you are comparing, you are not comparing the home readings with the clinic readings. So you have to maintain both the records, So this is about the anthropometric measurements. And one of the parameters now which is becoming more standardized and more popular is waist to height ratio. But again, waist measurement is very important parameter and has to be done properly and carefully also. Okay. Now, second thing is the evaluation of comorbidity. So you need a proper backup for the laboratory testing. You can have your in-house laboratory, or you can have, laboratories outsourced. But you should have a standardized lab which is giving you good results. The results also matter, because everything ultimately, you are kind of monitoring serially in these patients. It is not one set of recordings that is going to matter, because after 2 months or 4 months of weight loss, you will need to again check that. I think in the anthropometric measurement, I think I forgot to add the role of body composition analysis. This is again one more important parameter that you should have in your clinics. Now, the basic scales that you get, they also give you body composition analysis based on the bioimpedance. And I could see Sen Gupta, you were talking about bioimpedance and body composition analysis. So can you enlighten us more? Yeah. But you have other machines also. So basic concept of bioimpedance and body composition analysis you can tell.
So basically, a very low-grade current is passed through the tissues, and the electrical resistance to the tissues is noted. So if it's more fluid, the resistance is less. If it is more dense, the resistance is more. And that's how the machine picks up algorithmically the particular resistance values, and then it puts it down.
So then it tells you, how much fat mass you have, how much muscle mass you have, and the, cutoff points also. Depends on the machines. Most of the basic machines, they use the algorithms based on the Western parameters. They are not as good as, what is required for Indian population. Usually there is overestimation by about 5 to 10% in those machines. There is a comparative study done by Dr. Anup Mishra using Tanita machine on the algorithms originally there, and also comparing the Asian algorithms. So overestimation is there about 5 to 10%, but it actually does not matter. Ideally, you should have a good machine which gives you more accuracy in terms of calculating body fat. And the in-body machines that we are using, which is most popular in India, has a, the accuracy comparing with DEXA in the range of about 94%. So it is pretty accurate. purpose of this measurement here is one, to basically assess what is the percent body fat you have. Second is when you are following up these patients, why are we making them lose weight? That question you have to answer. So you are not making them lose weight, you are making them lose fat. So whatever, remobilization will happen once the fat is being mobilized out of body. So redistribution will also happen. But important thing is once you are making them lose fat, once they lose weight, they also tend to lose muscle. And we have to monitor how much muscle loss is happening. And this muscle loss is largely preventable if you are making sure that patients are exercising during the weight loss urotherapy. So during the weight loss, if you are able to measure fat loss and also see what is the muscle loss, then you can actually keep your strategies intact or modify depending on what needs to be changed. And that is where the role of these machines is there. So serial measurements will tell you whether you are losing fat, you are losing muscle, or you are losing more muscle, so you need to change your strategy. All that can be done based on this evaluation. Then, of course, we need to, look for the comorbidities and document whether the person has the components of metabolic syndrome, dyslipidemia, cardiovascular risk, renal risk, and so on, because all these comorbidities are part of obesity. And obesity, actually, if you look at the list of comorbidities, I think current number is more than 240. 240 conditions are related to obesity. So at least you have to document 40 the components of metabolic syndrome, the kidney function, liver function, NAFLD, and all that. And also, if you are suspecting some congenital cause or some metabolic disorder which is unique, some endocrinopathy, then you have to accordingly test. But large majority of people with obesity are the metabolic obesity without any, specific type of cause attributing to it. Most of the time you don't need specific investigation to rule out endocrinopathies or genetic disorders, right? So thyroid, okay, good question. So we so basic investigations include one, starting from the routine urine examination, complete blood count, thyroid function, liver function, kidney function, lipid profile, blood sugar, A1C, and B12 levels, vitamin D levels. Have I missed anything? Largely this. So you asked question about TSH. Good question. Why do you want TSH specifically?
So if there's any subclinical hypothyroidism because of which he's not able to lose weight.
So, Rucha, you want to answer that? TSH.
Why do we check? Why would we check? Should we check TSH in all?
No, TSH should be checked in. But how much does it contribute to obesity? That is good, important question.
They always come in the gray zone of 4.5.
So one thing should be clear to you that hypothyroid, even clinical hypothyroid, I'm not saying subclinical actually doesn't matter, does not lead to a weight gain of more than 2 to 2.5 kg. So the obesity is not because of hypothyroid. And even correction of thyroid will not make you change weight by more than 2 to 2.5 kg. But these are important parameters which are there, which are highly prevalent, and that is why we need to find them and also manage them.
Sir, so obesity packages which are done by labs, they do cortisol, they would do insulin levels.
Neeta, these are very interesting questions,
Now the question is that, yes, it's true that a lot of times you have to measure it for a variety of reasons and also to, see the progress. So if you ask me, yes, if a person is non-diabetic, I do see some insulin levels. Because I want to do a basic HOMA IR. So when you
But
do, when you
Neeta does we are doing it because we have interest in, other parameters, clinical research and
Yeah,
so on.
so not only
But
that, what we find is that once they start to lose weight and their hyperinsulinemia comes down, many a times what happens, I'll tell you, it also is important to tell the patient that maybe your weight has not moved on the scale, but look at the metabolic improvements. So that there is something that you can, and I think she's going to show that, yeah, a case with that. Yeah, so basically I do that. I don't do cortisol so much, but I do a TSH for everyone. I do this one, serum insulin and glucose. I also do, of course, all the LFT. I do HSCRP. And then I also do homocysteine. That is now plus minus, whether you want to do it or not. You can have an obesity and then you can have an obesity premium package where you'll also do the B12 and D, which I think are very important. Because you are going to restrict their diet, and if they're already deficient, they'll afterwards say that your diet did this. So you have to look at the practical aspects of it also. So you have to show them, look, this is your baseline. They're already anemic. And then if you don't, if you haven't checked the hemoglobin, they say your diet made me anemic.
So actually, a lot of times I've seen that unless the CBC is not corrected, they don't lose weight. If their hemoglobins are not right, or
No, they may lose weight, but they get worse.
they will lose weight, but the
they'll get
problem
worse,
is,
no?
see, they are already having anemia, which is more often than not, or most of the cases, iron deficiency anemia or nutritional anemia. And you are also going to make sure that you are putting them on hypocaloric diets. So you have to make sure that they are getting sufficient nutrition. So I am done in the first 2 points. So I can finish it quickly. So anyway, so you have to do, and ultrasound is very important now because NFLD is to be taken care. Second thing is, in women, we pick up polycystic ovaries quite often, and that is why it is important. So Neeta has given me a yellow light. In 2 minutes, I have to finish. So why we are doing this? Because we want to ultimately stratify the risk. We are measuring obesity. So obesity will give you, the measuring BMI will classify you non-obese or obese. But then from that, you have to also look at the stratification depending on the presence of 3 components: medical or metabolic, mental, and mechanical. Some of the patients where you have severe obesity, you might need to investigate in terms of, sleep studies also. So those are important parameters, but largely this is what is required. So in a setup, now you can have only a team of receptionists and a nurse who can do everything. If you train them on basic counseling, they help you. And then you can have, people providing consultation which is need-based, like you want a psychology consultation, can be there. You want a exercise physiotherapist, you can have them on call. Nutritionist is integral part. So in most of the clinics, a physician, a dietitian who also doubles up as a counselor or educator, and a nurse who can be your receptionist and other or multifunction person. This is the basic team required. And the basic equipment I've already told. If you have this, then you can start. But make sure it is not done, everything is not done in the waiting area of the clinic. Also, you have to customize little the waiting area because you are likely to get patients who are significantly obese and overweight. So you must have very sturdy furniture in the clinic. Then you should have chairs which are wide and preferably armless. If you have armchairs, again, they should be wide enough where person can sit comfortably. Provide privacy when patient is being examined. It is very important because they have psychological issues. So they are very apprehensive when they are visiting for obesity management. Some basic things that I have told you. With that, I end up my presentation on 3/4 of Neeta's slide and give it over to Rucha for this thing. Thank you.
So I'm just asking them to skip the introduction in the interest of time. So your theory ho gaya, abhi practical exam hai na? Chalo. Can I have my cases, please? Well, she's taking a picture, so I can wait. We'll have all three on stage and take picture together. Okay. What happened? I thought I would label that as cases in obesity and metabolism. And of course, we always like to blame thyroid, our genetic background. But remember, it all boils down to your lifestyle as to what you're doing. And let's move right along. And so what I'll do in the next few minutes, whatever you just heard from Dr. Makkar and Neeta, is approach and goal setting. What would you employ, and treatment and diet-wise, behavior modification, even a touch on technology. I mean, you need all of this to give a client the complete prescription. Let's not call them patients. There's a huge push, of course, why are we here discussing this from the ADA and everywhere, that you need to use obesity management as a primary treatment goal, and there is a time to reframe the conversation. Multiple guidelines exist. So this was the ACE algorithm, there's an ADA algorithm, and today what you saw is our own JAPI algorithm. So looking at how would you approach Asian patients, and Neeta pointed out the key highlights. So hopefully you'll keep this at the back of your mind. So I'm just going to kind of start as what happens in the real world. There'll be these patients. Here's a 28-year-old, his BMI is 32. He wants to lose weight. Now he also doesn't want to spend too much. Your testing that you're asking will cost 10 to 12,000 rupees. If you start adding ferritin, homocysteine, B12, D3, wish list can go be never ending, right? So you have to be conscious of those things also. Yeah. Dr. Makkar has a profile in a lab that can give it to you for 3,000. So what does he do? He's going to say, okay, chalo, I'll try something on my own. He'll buy a Fitbit or something like that, right? For a few days that will work, maybe for a few months. Then he'll say, let me download some free app. Once that app also will run out its lifestyle, he might pay some money in the cheapest possible version. Then he's heard about intermittent fasting, so thoda bahut wo try kar lete hain. So by the time they actually sign up for a program or come to see someone like you, they've tried a little bit of everything and they've screwed up their metabolism. Let me just say, sorry, this was off the record, but just in case you understand that by the time they come to you, it is, my God, a very uphill job now for you to do. So this is where this algorithm is going to help you. The purpose of this workshop is have very clear thought process. This history is very important. You need to collect this while they are waiting for you. So as what Neeta pointed out, that did you take a history, all of these steps are important. Your recall, what do they do? What time do they wake up? What time do they sleep? All of this is important. Let them wait for you for 1 hour, but your questionnaire needs to be detailed. Your nurse, receptionist, health coach, whatever name, fancy name you want to give them is important. Because the client identifies, your patient identifies with that somebody spent that time with them who's a healthcare professional. And then eventually, of course, it comes down to he has already been hunting. What should I eat? What works? So we have several things that we will include today. Carbohydrate, protein, fat, fiber. Is it just calories? Is it exercise? How do I go about this? That is the third part of the equation where Dr. Makkar just got. And eventually, last but not the least, is the follow-up and monitoring being a very important part. And of course, keep in mind the Edmonton obesity staging system. So I would just remind you of the 3 M's, right? Anybody remembers what was the 3 M's? Medical, mental, and mobility. No, I'm just making, I know, I'm just saying that, try to remember that. So now we'll walk our way. So let's have this first case. So here's a 29-year-old female patient. Her height is 165 centimeters, weight is 122 kilograms. So as a first step, you're going to do at least a BMI, waist circumference, hip circumference, after a detailed history and all of that is done. So that is one of the basic things. So BMI was 45 kilograms per meter square. I'm just going to highlight the important things in her history and not provide everything. So she had back pain, she has irregular cycles and was diagnosed with polycystic ovarian disease. And her family history is therefore type 2 diabetes. Her biggest fear when you ask was she doesn't want to get diabetes. So what will be your approach, okay? How will you think in your mind? So lifestyle modification is needed. So first, how much weight does she need to lose? Goal setting, right? Remember they said goal. Dr. Makkar asked you that why do you want to lose weight? What do you want to lose? Sorry? She doesn't want to. So prevention of diabetes in this patient's case is a goal for her. We might have other goals. So, like we all say we want to lose fat, build muscle. Patient ko pucho, usko kya chahiye, right? You want to ask what is the patient's goal. So therefore, every time, first and foremost, as you did, so is she obese? very clearly. इसमें कुछ सोचना नहीं है. Edmonton staging. So how will you approach this? So I put the steps of the algorithm over there, and then the questions you will ask in treatment, right? So what is your staging? Edmonton obesity. Does she have any?
Second factor is insulin resistance because she is PCOS.
Medical, mental, mobility.
So medical, and would you even think for a pushing for her? No.
So we'll get to that. First, just what do you have in history? She has back pain, right? So mobility issues ho gaya. What else? She had PCOD. So there's a medical issue also. So we know that there are already criteria and she fits into a certain class. Does she need evaluation for secondary factors for weight gain? What you just asked. Anita had put in the algorithm. So do we have to think about every patient who is obese, super obese? When do you think of Cushing's? So what are some of the stigmata you might look for on medical examination? So you can look for stripe, blood pressure, hypoglycemia. How many of your obese patients have all this? So stria is difficult to find. So stria is not your typical white stretch marks. They are purplish, splitting a part of the skin. You should be able to fit your finger in them is what they say, but not all patients fit the book. In fact, recently, unfortunately or fortunately, there is a huge push for subclinical hypercortisolism in patients with diabetes who do not respond to treatment. So there is an increasing push for this cortisol. So unfortunately, we have started screening. And if you decide to do them, I actually took the slide out with all the tests on it, because it's called the 1 milligram overnight dexamethasone suppression test. Just a random cortisol in overweight patients who are depressed will usually be high. So that would be like a pseudo Cushing picture. So don't just do a random cortisol, and if it's high, start labeling them as a Cushing's. You need to do more objective, maybe have an endocrinologist assistance if you truly suspect Cushing in somebody. So then you have to do, next step, as I said, is goal setting and what treatment will you offer. So we'll do one case slowly, but the rest will go quickly because you guys will be experts, right? So now goal setting is done, right? You will tell her to lose what? Her weight is 122 kg. So कितना करने का है?
To come down like 165 kg.
Height is 165.
So she should be 65 roughly.
Yes, Dr. Makar, can we have some microphone so that I want the other faculty also to give their...
So you got a very important question. What should be the goal for weight reduction? Now you are looking at remission of diabetes in this person or prevention of diabetes, whatever. So whatever data you have, if you are able, see, initially we were targeting only 5 to 10% because we didn't have means to achieve more than 10% except for bariatric surgery. Now we have better drugs, and if we combine with lifestyle interventions, we are able to go to 15 to 20%. Whatever data you have, if you are able to make patient lose more than 15%, you get remission of diabetes. So I think first goal in this case would be anything upwards of 10 to 15%. Am I correct?
Good. So very important, listen to your patient. So she's asking you prevention of type 2 diabetes. So very valid point made. You can calculate that for her.
One more point. If you give them a goal, if this is working, so if you give them a goal of losing 50% body weight, they will never do it. So goal should be realistic also. And it should not be, over a period of days, or you should also understand at what pace patient is going to lose weight. So you have to take into account multiple factors when you're planning all these things.
Okay. So what would you do for this patient? Once you have said, okay, you need to lose at least, let's start with 10% in 3 months is reasonable, achievable. She's already mentally probably disturbed by so much weight gain, so you don't want to overwhelm them. So say we decide about 12 kilograms in 3 months. What would you start as treatment? Somebody said lifestyle, so of course an intensive dietary, and what exercise can she do with back pain? She can do resistance training. Maybe she can still walk or backward walk, swimming. We don't know. You have to find the activity that works for her. Yeah. Yes, yes. So we would be very lucky if all of us had some physiotherapists in clinic, but you may not have that, but collaborate. So you don't have to have all specialties in clinic. As Dr. Makar said, you can start with basic 3 people at least, and then collaborate with other specialties. You need multiple specialties. It takes a village to raise a child. It takes a village to help in weight loss, honestly, trust me. And also maybe a mental health professional, which is a huge part of this. So once we do this, any medications any of you want to give her? So as I can show you over here, we had all her blood tests also. You can see, as we expect, the body fat would be 50%. The visceral fat would be of the chart at 20%. So we had all these reports. I'm trying to see. Her HbA1c came 5.1. You can't always believe that. You can see her fasting insulin level was 25.8. So I do check as I was talking to you, and because she talked about diabetes. Now this is an indication where I would definitely look at insulin resistance, calculate those values. I can give you all the slides. No need to take photographs. Yeah. So this is what we did do in this patient, just so you know. And would you start any insulin sensitizer in her? Is there any role for metformin over here? Neeta, you want to talk on that?
Actually, I wouldn't, because she's not even pre-diabetic, according to this. And though she has a strong family history of diabetes, metformin really hasn't shown much of a promise, so I wouldn't want to do that. The other thing that I also wanted to say was that it's very important to take in the history, the weight history. The reason being that people who have undergone multiple cycles of weight cycling are obviously going to show much slower results, much slower results. So when you're doing goal setting, some patients have unrealistic goals. They come back in 4 weeks and say nothing's moving. So you have to tell, that's why you need that weight history. If a person has lost weight multiple times and regained, you want the patient well in advance that you're going to go slow now. Now, since this patient is just 29, the hopes are good that she may lose faster at the age of 29 and hasn't probably undergone so many cycles of weight cycling. But to answer your question, I honestly wouldn't think of metformin in this patient.
How about you, Dr. Makar? And then I'll say what I did.
So again, it is very important to understand that there is no set rule, and everybody tries to customize according to one's own way of working. There is a prescription, the prescription, advice, which is the approved usage, and there is off-label usage also. So off-label, we end up using metformin also because it is shown very clearly that it does not cause significant weight loss. It's very clear. We know that. But we have very limited options in terms of pharmacotherapy. So in my patients, especially if they are high risk, family history of diabetes, severe obesity, acanthosis and other things, I use metformin. Helps in suppressing appetite very little, but does help in some of the patients and some minor weight loss. But it is off-label use. There is, as of now, the only approved drug that you have available is Orlistat. GLP-1, Rybelsus we are using off-label, liraglutide we are using off-label. What is approved for obesity is 2.4 milligrams semaglutide, which is not available in India. Even I think Mounjaro has got approval, but it is not available. So you will be using some off-label drugs, but you should be clear what you are trying to achieve with that. You should be able to explain yourself or justify the use of any medication that you are using there.
Okay, perfect. So this is why medicine is an art, and I can tell you what I did, of course. So my indications are similar as if you're looking at prevention of diabetes or if you're looking at acanthosis. I find high insulin, very high weight, and I use a surrogate. Some patients don't want to do all the blood tests. If the visceral fat is very high, total body fat is in these numbers, my success rate has been higher when I place them on metformin because I kind of tell them it seems to work better in helping whatever lifestyle intervention you do. So, sorry, Neeta, to be the devil's advocate, we started them on all the vitamins, and also we gave her metformin. She also had irregular periods. My approach is not to do birth control pills. So remember, PCOD was an indication in her. So in this case, there was another indication for using the metformin for polycystic ovarian disease. But like I said, everybody has a different approach. Very often, patients who even come with diabetes don't want to start any medication. So you have to have that discussion with them. If they are willing to, they're agreeable, and you feel there is a need in her, then we can start. Second thing we do is we always write the exercise prescription. So I just thought I'll put that in. You need to think about when you write this, so the frequency of exercise, intensity of exercise, type and time of exercise, how much time you're spending. And last but not the least, just like your monitoring therapy, the progression. So if they're just walking 5 minutes, 10 minutes, did they increase? Every time you need to see what's happening with that also. So with her also, we started very slow walking, then she moved on to Pilates, Zumba, and she's been with a physiotherapist for some rehab for a back pain also. So this has been now going on over months. And she has done quite well actually. In 4 to 5 months, she has lost about this many kilograms with a lot of hand holding, a mental health consultation, and her interest and life has increased quite a bit, I would say. So now I think now you've understood the progression or the assessment, how you need to think, take a breather, make sure you don't miss the goal setting. So let's do these cases. I have 1 second. Should I just go through a few cases quickly? Yeah, because it's more of if everyone is interested. Yeah.
There's nothing after this in this one.
There's nothing after this, yeah. So here is a 42-year-old female. She has a history of hypothyroidism because all the questions you asked, and she also came to you with a 30-kilogram weight gain. Now this young female has already had a bypass. She's had angioplasty bypass and she has a hernia. She also complains of back pain. Her height is 150 centimeters and her weight is 81.2 kilograms. So is she obese? I mean, I'm sorry, all these places, that by the time I think we see a skewed population, the ones who come to us. And then what about her Edmonton staging system? She has already had a bypass. And yeah, so there is no clearly medically also, she needs intervention and she's only 42 years of age, right? So dietary recall when we take, this is something very important. So in every case, I'm highlighting something. All our patients always tell us they're not eating too much, by the way. And they seem to have a very balanced diet when they come to us, but still they are gaining weight. So this is a real scenario. But of course, there is hedonic eating, which is not written in the recalls. There is pleasure eating, hedonic eating. We are all guilty of doing it. When I use my app also, I think 8 serving likhu ki 2 serving, Even if I've had 2 servings, I may sometimes just to feel good at the end of the day put in.
You need to be more honest.
Yeah, I'm honest. I'm telling you honestly. So again, same thing over here. Remember, keep this in your mind. Is she obese? Do the staging. Does she need evaluation for secondary factors for weight gain? Would you do, for example, Cushing's, thyroid, etc., etc.? She's already hypothyroid. So not really. Why in this patient you don't want to do just because 30 kgs is not as much as being 60 kgs overweight?
No, because it's GDM and she has multiple other comorbidities and she has gained weight
So she
out.
has good garden variety
Yeah.
obesity. Yeah. ठीक है. Okay. Goal setting. So what is her goal? Why has she come to you? She wants to prevent future heart attacks, metabolic conditions, right? So that was her main concern. So there are no real such studies that say lose 5%, 10%, but certainly you can start somewhere. Now remember, she's not somebody who'll go for a run, right? She's,
So
yes, sir.
15% weight reduction has been shown to cut down the cardiovascular risk, all-cause mortality, and also improve the heart failure.
Okay, so everybody can hear that 15% is the weight loss target, at least you're looking for. But again, you don't want to scare them, so you can always say, let's start with the first 8 to 10%. And our target in the next year, you can say, you don't have to say in these 3 months you need to lose 15 to 20%. You can say, let's take this slowly, you have all these underlying things going on. So in her case, what treatment, if say we lived in the, so she wants to offer semaglutide. Some of you might have just seen the select trial I presented in the next room, is that semaglutide in high-risk patients without diabetes and just with obesity who already had a cardiovascular event was very successful in helping with weight loss and preventing MACE. So it was more of a cardiovascular outcome trial and not a weight loss trial. So that is very important to keep in mind. So we have, it's on off-label, so I'm not going to say that's anything whether we did or not. But certainly diet intervention, I thought in this case, because we looked at her macros and everything. So we do this every single time, okay? So this case I'm highlighting how we kind of go in is, initially we bring them in easy. We might do an isocaloric or a moderate carbohydrate diet, optimize her thyroid and all of that. And then sometimes we'll do a hypocaloric, high carb, low carb cycling. So what is important is to understand perimenopausal women who are obese. There's a huge push and a lot of studies out there with this. Dietary interventions, they don't really work as well as they would work in the younger female we saw ahead. So you have to be very aggressive, and actually she was able to replace a meal every day. So we even guided her that one meal if you can replace, what would you replace? And she was having a couple of glasses of buttermilk and a plate of salad or something. So simple steps, she was not very affording. So you have to work with that and not just think about expensive things also. So this is her, as you can see. Her weight was 82 kilograms after 3 months. What I want to highlight here is another part is that her inches, as you can see, they went down. Her body fat has gone down from, so her total body weight went down by about almost 16, 17 kilograms. Body fat, we didn't see such a huge reduction in 3 kilograms. So what happened here? What is the significance we have to look at? HbA1c levels, fasting sugars, thyroid dosage also reduced. So what happens when people lose weight? And this is the monitoring I'm talking about. Do you lose only muscle? Do you lose only fat, or you can lose other things also? Yeah, so you can lose muscle also. We expect to in fact see a 10 to 15% muscle reduction in all patients when we start them on programs. It doesn't necessarily mean something significant, but if we are losing 20-30% of muscle or more than that, or continuously losing muscle, then you need to reassess what you're doing. Very often in intermittent fasting protocols also we see muscle loss. So we have to be very careful as to what they are eating in those eating phases, and make sure that you're following them with the body composition analysis. So that is what we found, is that she was skipping too many meals, she got greedy, she lost the weight very quickly. So we had to tell her that slow down, you're losing as much muscle as fat, and that's not the end game. We don't want to lose so quickly, okay? All right, so now moving on to case study number 3. We have this 56-year-old male. His height is 176 centimeters and he's 106 kilograms. He comes to you with diabetes, lack of energy, and skin pigmentation. Okay. So now, is there any indication for any? So how will you approach this case? Of course, is he obese?
Yes.
What is his staging? Because he has diabetes. They were all actually a little bit clear cases, I guess. And what would you do next for him? What is his goal, and what will you offer the treatment?
The lack of energy and skin pigmentation.
Sorry?
Lack of energy and skin pigmentation.
So when somebody with diabetes says lack of energy, and I don't know, Neeta, anything from your end as to what is the,
So maybe this person has does not have a good glycemic control. So bad glycemic control can cause a lot of fatigue. They also have multiple deficiencies. So I would like to definitely look at the B12, the hemoglobin in this particular patient, and of course I would also look for the fatty liver and all of those things.
this is somebody you're going to the mega $1 million workup. You might even think of underlying cardiac disease. You know, fatigue could be anything. Once you've ruled out all the usual things, then certainly you want to look at those things also. But he's only worried about his looks, so you know, that's something else also. But in case you want to check an insulin C-peptide, this is where you might check that, because what is the pigmentation most likely? Acanthosis, right? So that's what you're thinking about. Okay. So again, in him also, lifestyle intervention was done. We do use meal replacers, and just showing you some of his food photographs that he had sent to us. But after being enrolled and working up everything, what we found was he had very high insulin levels, insulin resistance. He's also done phenomenally well. Zoom in. Can you see it better here? You can't see anywhere, no? Here or there, yeah. Yeah. So his weight went from 106 kilograms to 90 kilograms. His waist circumference went from 50 inches to 41 inches. His skeletal muscle was 36.5 kilograms, and you can see at the end of 3 months it's 34, so just about 2 kilograms. And he had much more of a fat loss. His visceral fat, which was 20%, went down to 14%. Okay.
I have a question.
Yeah.
Treatment-wise for type 2 diabetes, did you change something in there also?
Yeah, so he was actually taking only metformin with a DPP-4 inhibitor, and he had uncontrolled glycemia. So whenever they start our diet plans with us, we actually take them through a whole thing of learning about macronutrients. There's a lot of educational component, and in these 3 months, we have not yet added a GLP-1 for him, just so you know. So we had just added an SGLT2 inhibitor. Instead of sulfonylurea, if I'm giving them a hypocaloric, low carb or low glycemic index diet, we'll add more of a carb blocker like acarbose or volibose, which seems to work very well in the Indian scenario. So sulfonylureas, especially, you want to make sure that you're stopping your patients. If they are taking rapid acting insulins, you want to make sure that their insulin dosage is reduced or stopped, because they might get into hypoglycemia, and that might stop your weight loss journey. Okay. And this is his improvement in BCA, and you can see over here, this is what he was concerned about, the pigmentation, and you can see a beautiful reduction in his pigmentation with the weight loss. So he still continues. Now he's encouraged and he wants to continue doing some more weight loss with us. Okay, so very quickly now, just I'll show you 40-year-old male surgeon. He has no comorbidities, okay? And he was honest, his diet, he's eating 2,000 to 3,000 calories a day, so many carbs, very little protein, right? He's a runner, okay? He's running 3 to 4 times a week. He has done 10 kilometers, but he's not able to lose weight with all this running or improve his pace. Why?
This diet.
Running, we feel it's a license to eat. People who exercise, actually, sometimes, I tell them stop exercising. Because then they're eating everything. They feel running kar liya to chalo jaake khate hain. After run, immediately they go for chai poha in Gujarat, in Ahmedabad, where I'm from. That's the thing, you know. See, that guy is also from Ahmedabad, I can tell. Yeah, you're shaking your head, yeah. So they
In Bombay, they eat vada pav.
Vada pav, which is even, I don't know, which is, pav is a little bit better than vada pav, yeah.
But you know, the CGM's readings show that actually the batata vada is giving lesser sugar spike compared to
That's
poha.
because of the fat.
Because of
There's
the fat.
extra
Oh,
sugar.
interesting, really?
Yes,
Oh, wow.
yes.
Nobody eats vada pav in the
Poha
morning in
gives a
Ahmedabad.
huge spike.
Okay, so what should we do first? So let's stage this guy now. So what is his, is he obese? Okay, he's obese. I'll tell you in the next slide his weight and all that, yeah. What about his EOSS staging?
Mobility is good.
Hmm.
There is no comorbidity. And it's
No mental issue also. He's very happy. Yeah. He's happily running. And eating. Yeah, he's smiling also. See that? Yeah. So his so what would we so does he qualify for
Stage 0.
Yeah, so he's a stage 0. BMI wise he's there. So again, when we are thinking about medications and all that, remember we said you could stage them, and Meeta had put a little caveat that if the BMI is more than 27 kilogram per meter square, when do you consider medications, you know, in Indian scenario. So keep that in mind, of course. Again, in his case, exercise was important and timing his nutrition was more important around his runs, and of course he needs little hypocalorie. But when they are doing a lot more training, sometimes if you put them very long on a very low calorie diet also, they plateau, right? So in his case, we taught him something called aerobic zone training, which will help in fat burning. And we told him to actually cut down that, do something on the other days to do resistance training. Frequency 3 times, add resistance training, nutrition changes. We taught him something known as an 80-20 training method, which is in running circles, something developed by Matt Fitzgerald. So only 20% speed work is allowed in that because they go into anaerobic or very high heart rate zones. When you're in high heart rate zones, you're not burning fat. Okay? And now he was able to add on more and more running because he was losing weight and slowly get there. So progression is also important. So you can see over here, he went from 98 kilograms to about 83 kilograms. His percent weight loss was about 15%. Here are his waist circumference. And then if we see the body fat at start was 30 kilograms and at the end was about 17.5 kilograms, and his visceral, and this is just a 3 to 4 month. You know, men somehow when they come in, they are able to always achieve faster, right? You know, men will lose weight. Sorry.
Women in the back are working all for them.
No, I wouldn't say that's the reason. We are programmed differently. So men will always, very often we get couples coming in. So you again you have to tell them that he's going to lose faster than you. So please don't compare to each other. I'm sure, Neeta, do you see that in your, yeah, all the time. Yeah. It's all the time, yeah. So we can see very nicely, and this, why I like InBody also is you can see this. We also ask the patients to, if they want to download the InBody application, so they can see further breakdown and see where they are at. Because after this, sometimes when they, and you can see his fat muscle loss was not significant from 39.3 to barely 38 kilograms. So this kind of muscle loss is okay to see. As I was explaining to you, 10%, something of that sort. But anything beyond that, like we saw in the other lady, it should ring alarm bells that something is going wrong, okay? Yeah. So there he is, and he has gone on to since then run full marathon, even an ultra marathon, and continues to, since he's running, now he can eat whatever he wants because he has improved his metabolism and everything. So I'm going to quickly now not discuss much. I'm showing you 3-4 pathological weight gain cases. So 44-year-old woman who had high blood pressure for years and years, and I missed this case in the beginning, complained of worsening bruising, lacerations. She would come on and off, you hardly saw her, so you were more focused on treating her diabetes, blood pressure, everything, you know. So then she started saying that she doesn't feel good, she had this swelling on and off, puffiness around eyes. So what do you think I should be thinking about? You are checking? There you go. So when you examine, what is more specific than striae for in clinical exam is dorsocervical hump and supraclavicular fullness. Okay, it's not very common to get fat pads in your supraclavicular area even when you're obese. So therefore, it's more important to look for all of this. Her primary care physician had checked her random cortisol, and it was 23 microgram per deciliter. So he sent her to me that time for. Yeah, so you should not do that. I just want to point it out. So I've not shown all the reports. Oh, I have shown. Okay, so we did the overnight suppression test, and you can see that even after doing the overnight suppression test, the ACTH level was high, as well as the cortisol level with the dex suppression test, the cutoff is 1.2. Hers was very high, 31 once and then 15.8 on a second test. Okay, and it should be less than 1.8 microgram per deciliter. So we actually did her MRI, and because the ACTH was also high, so you're looking for pituitary source. Just found to have a pituitary adenoma, underwent surgery, and she did not get cured with the surgery, but so she still remains on medications. Yeah. Now, lastly, again, we also see, as I said, a lot of pediatric patients. 6-year-old person referred from bariatric surgeon, full-term normal delivery. Again, in children, we do growth charts, okay? So you want to see if they are more than 100 percentile. There are criteria separate. Socially, she was inappropriate. She had obstructive sleep apnea. That was the trigger. She was falling asleep in school. That is what the teacher complained that, you know, she's just not, she's hitting people, falling asleep, etc. So what do you think she has? Anybody? And she's beautiful, of course. So her Prader-Willi test had come positive. Just to tell you that in children, how will you know this? So I'm going to just show you something. So you see her height is also low, 88 percentile, and her weight is more than 200 percentile. So it'll be very highly inappropriate when you look at height weight charts, okay? So when you start seeing this, if they are tall and obese, usually there is no genetic problem. If they are short, then there is definitely a genetic problem you must screen for. Prader-Willi being most common, we start over there, and history was also consistent, okay? Now again, as you can see, this is a 7 to 18-year-old short and overweight boy, and that's his cousin brother who is the same age as him. And so they said, no, okay, wo to badi nahi raha hai, ye bad raha hai. So he came to me for short stature. And when we did, you can see over here now, so you can see like his height is here, you know, when he first came to see us. So weight was way below the height again. So in children, you have to match the growth charts. Even if it's too much, too little, both are significant. And so it was diagnosed with, his TSH came more than 150, very easy case. And he started getting better, as you can see. So, like I said, all of this is needed. So you need to have a very open mind, have a clear-cut thought process. You can't have all of this in your offices. Your bariatric surgeon, your dietitians, physiotherapists, so collaborate. And that's how you will have a metabolic program. You don't have to have everything in your clinic, okay? This is the last slide. Thank you very much. Thank you. Yeah.
Thank you, ma'am, for this informative as well as interactive session.
Intermittent fasting and
You're welcome to do it.
Before we conclude this session, I would like all speakers and the chairperson to come on the stage for a group photo. And we would like to facilitate Dr. Neeta Deshpande. One second, I'm the cameraman.